pump while talking on Zoom to their work. So, oh, it's like streaming live. Keep quiet.
Oh, that's good. That's good. Is this going to be recorded? Oh, I see the recording. It is being recorded.
Yeah, it is being recorded, and you can see the presentations and everything. You can see it on YouTube after this conference is over. It is going to be there.
Okay.
They're coming in. I see one attendee increase.
Oh, do we?
Yeah. Nope.
So 20 minutes, Marian, 20 minutes, and then we'll do audience Q&A, and then we'll do your talk.
Yep, got it.
Okay.
I'm prepared for 20.
Wish me luck and good luck to you too.
Sure. We're all friends. The whole world is a big friend. It doesn't really matter.
It's really true, isn't it?
Yes, right. That's right. And I'm not sure, but are we live? Because I see no increase in attendees yet.
Yeah.
They didn't let them in yet.
Not.
Yeah. Okay.
Yes, not.
News here.
So you can probably share your experiences at length, and you can tell us. Yeah.
Yes, we will. We will share them at length.
So we have Mr. Shubham Garg joining us. Good morning, Mr. Shubham.
Good morning, ladies. How are you doing?
Good.
Well, good morning.
Great. So I was one of the participants and I was listening to your question, Marianne. So there is a different streaming channel for the participants, and the viewers. So you would not see the viewers in the list over here. That's being streamed live. And the questions they might have would be given to the backend team, and we will ask you the questions. So that's the way it's been designed, making it virtual so that people are able to view it, and we are able to ask the questions. I hope that clarifies your question.
Makes sense. And are we already live? Because it says live.
Yes, you are live. Yes, you are.
Hi, everyone.
Hello. It's nice to see everyone. We didn't realize we were live.
Yeah, on the top right side, you would see live. So you basically being streamed live right now.
Okay.
So Mr. Garg, do we wait for the other two speakers, or should we go?
We can start. Actually, we can start at this point. And whenever they join, they can join, and we can have a conversation at that point.
Sure. All right. So let me formally welcome everyone. Ladies and gentlemen, welcome to the day 2 of the World Healthcare Conference. It was a very beautiful day yesterday because we had a great day. We had very fruitful conversations. We had the 3 plenary sessions in Hall A and another 3 in Hall 2. And all these sessions focused on various issues related to healthcare. These are the topics that are not just relevant, but are pressing issues that need to be dwelled upon, to be talked about, to be discussed with passion and zeal, especially since we are in the middle of the pandemic. So it makes these topics even more pressing to be talked about, to be dealt with, and the takeaways and the decisions be implemented upon. So we had really thought-provoking sessions on digital transformation in healthcare, artificial intelligence, blockchain, robotic surgery, new health informatics, telehealth and telemedicine. And today, this session starts with 2 lovely ladies joining us at the moment because we are going to focus on women in modern healthcare. I would like to welcome Ms. Heather Lee Plenary, Founder and Chief Executive Officer, Census Health USA. We also have with us at the moment Ms. Marian Ubroma, Senior Assistant Director, National University of Singapore, U Lin School of Medicine, Singapore. Very good, very warm welcome to both of you ladies. And Mr. Shubham Garg is going to also be joining us. He is he's going to be the co-host for the show. So let me first welcome Ms. Flannery. Ma'am, the the show is all yours. You're going to be the chair for the session as well, but of course you are all welcome to make presentations and share your experiences as a pioneer in the field of healthcare. Over to you, ma'am.
Thank you very much. It's a great honor to be here. Hello, everyone. My name is Heather Flannery. I'm the Chief Executive Officer of Consensus Health. I'm excited to tell you more about the intersection of blockchain, other emerging technologies in the healthcare and life sciences industry. As we move through my presentation, at the close of it, there'll be a question and answer segment where we can interact live with the audience. After some live audience interaction, I will turn it over to my colleague, Marian, who will give her presentation. We'll have more audience Q&A and then ultimately move to a more free-flowing open discussion on the subject of both of our talks and the role of women in this industry during this time of transformation. So a little bit about myself. First of all, I'm definitely honored to be here. I'm a serial entrepreneur and technology strategist that decided to pivot my career to healthcare and life sciences due to a wide range of personal motivators having to do with my own experience as a patient and my role as a caregiver to family members. And around 2005, I decided to dedicate the rest of my career to doing anything that I could to contribute to the positive transformation of this industry. Consensus Health is my fourth company. So as we think about the role of women in healthcare, it's intersectional with entrepreneurship and the difficulties and challenges that all entrepreneurs face and the unique challenges that women face, including in the healthcare industry and in STEM fields in general, science, technology, engineering, and math. Presently, in addition to my role leading Consensus Health, which I'll tell you a little about in a moment, I chair the blockchain task force at the Health Information Management Systems Society. And I'm very proud to chair that for the 2021 year and was vice chair for the past 2 years. So it's been an incredible journey. I chair the only standards development working group in existence focused specifically at the intersection of blockchain, machine learning, and healthcare and life sciences at IEEE. And that's P2418.6. And if you're interested in participating in standards development, I also chair the healthcare interest group at the Enterprise Ethereum Alliance. The EEA, or Enterprise Ethereum Alliance, is a large organization focused on bringing the Ethereum blockchain protocol into enterprise grade or industrial grade uses. And I've also co-founded a nonprofit at the intersection of blockchain and healthcare, also under the IEEE umbrella. So first, just a very quick primer for those members of the audience who may be unfamiliar with blockchain generally. So I'm only going to spend 2 minutes on this because I'm assuming that most of the audience is already long since there. But just so that you're aware, the origin story of blockchain began with Bitcoin, which was an act of civil disobedience related to discontent with monetary policy globally during the last major economic downturn. And an anonymous activist computer scientist used old cryptography in a novel new way to bring the first blockchain network into existence, and developed an incredibly brilliant behavioral economic model that involved different stakeholders being intrinsically motivated to keep an infrastructure running without a CEO, without a board of directors, without even a jurisdiction. It was a concept so radical, so revolutionary, that it took the world quite a while to understand the implications, not only of cryptocurrency, but of the fundamental idea of trust infrastructure that could enable it to be possible for multiple parties to trust one another using common infrastructure, common data. the idea of being able to transact, in our context, we're talking about clinical, scientific, business processes, public health processes, person-centered, you name it, without necessarily using the intermediaries that we rely on today. This is the basic promise of blockchain technology, where you could think of it as the new software for trust in humanity. And if it is that fundamental, though, and requires that level of abstract thinking to determine how you could apply it, and it's been fascinating. My organization, Consensus Health, is a commercially independent spinoff from Consensus, which is the largest pure play blockchain company in the world. So just to give you a sense of a little bit of the origin story, Consensus was founded by Mr. Joe Lubin. And Joe Lubin is one of the co-creators of Ethereum and the Ether cryptocurrency. A lot of wealth was created with the appreciation of the cryptocurrency Ether, and a lot of that wealth was placed into investment to build software infrastructure so that enterprises and governments could make use of the Ethereum protocol. So that's enough of the background. More to the background on the intersection of blockchain and healthcare. The first point I'd like to make is that healthcare is now widely understood to be much broader a concept than what occurs in clinical encounters, what occurs at the point of care. We are now, as an industry, very focused on the total social determinants of health, the genetic determinants of health, and really looking at holistic and person-centered approaches to positive transformation of our industry. There are many unmet needs in our industry that have the potential to be impacted by this technology. Generally, if you, at a big picture, when we think about disconnected care paradigms where patients are receiving care, care is being paid for by many different parties, and all of those experiences are disparate and siloed. And the payment processes, the data infrastructure, completely bifurcated. Blockchain has the potential to create shared infrastructures that are mutualized and federated among parties who can then begin to function as if they all had one IT department instead of 20 IT departments. So as we think about how blockchain technology affects our industry, I developed this framework several years ago to think about stages of transformation. This is PHI is an acronym for Protected Health Information. It's just referring to health data. And the x-axis takes time and the involvement of PHI in a use case, and the y-axis juxtaposes population health impact. So as you move up the y-axis, you're moving from incremental benefit to transformational or exponential benefit. And then as you move through time, you're increasingly able to compute upon, transfer, and work with PHI. So the pattern that I recognized is that the use cases in our industry that were receiving traction early on really had one characteristic in common, and it was that they did not use health data. There was no PHI. So they were use cases like supply chain short of the point of care, directories of provider data, some aspects of revenue cycle, certainly credentialing involving public information about providers, all things that did not involve private, sensitive health information. So no PHI in stage one. I'm going to skip stage 2 for a second and go straight to stage 3. Everyone in our industry has been very focused on these use cases that involve having to work with PHI and including sensitive information and the requirement for patients to be firmly and conclusively identified. Those are things like care coordination across organizational boundaries, a range of precision medicine and value-based care models, even taking digital therapeutics to a next generation digital therapeutics 2.0 with the ability to have ultra secure and incentivized models. But all of these things, you could not put this technology in production in mainstream medicine as it stands today. There are too many constraints and barriers. And our hypothesis is that this middle stage is where we are now. And that is where we could use the technology in any research paradigm that was appropriately ethically overseen. And the reason for that is that research is conducted in what I call a walled garden paradigm. It exists within mainstream medicine, but with patients that are abstracted into research subjects, physicians and providers that are abstracted into investigators, capital sources and funding that is distinct and separate, and governance and ethical oversight models that are in fact quite distinct, as well as policies and review for distinct technology infrastructure. So all of that containment is what will allow us to use this technology in research settings such that anything that we could do in stage 3 in mainstream medicine, we can do today under a research protocol. And that is the method by which our industry will be able to ethically adopt all of this. But a key point here is that blockchain is a very important and disruptive technology, and it creates a lot of value. It also creates a lot of risk. Blockchain left on its own, viewed as a discrete technology, does much more to aid transparency, to aid visibility, than it does to aid privacy or anonymity. And that means that in order to meet the unique needs of our industry, you have to look not only at the blockchain protocol layer, but at the entire mass of exponentially growing health information and what to do about that. And there are other emerging technologies that in my view need to be integrated and converged with blockchain in order to make them work for healthcare and life sciences. I use a new vocabulary to talk about data to clarify what we mean. And source data is everything that we traditionally think about as health data today. That's enterprise data behind firewalls. It's patient self-sovereign data increasingly. Metadata to mean descriptions or technical descriptions of that data, but not the data itself. And then derived data is generally what everyone is actually driving at. Everyone actually wants to create value from the data in the form of analytical insights, perhaps to train a machine learning model, to make a discovery, to understand something urgent and important about a population, a cohort, or a person. That derived data, that value, today, the only way to create value from data is to make copies of it and send it from place to place. And wherever the copy is sent to becomes the new place where that copy of the data has to be taken into custody, governed, overseen, maintained compliance of. It has to remain in an appropriate setting. In the model that I believe is emerging and that blockchain is helping to bring about, but is not the whole story, we will be able to compute on data to create derived data and create value from data without needing to exchange it at all. And the core function that blockchain provides in that setting is the access control layer and permissioning layer to allow different algorithms and analytics to run on source data where it resides at rest. So we know that as data is growing exponentially, we've already hit the logistic, ethical, and cybersecurity boundaries of data lakes. our ideas of data centralization, where all of our strategies to support AI need bigger and bigger and bigger data in ever growing data lakes, that is an idea that has already been maximized. And I think it will be a part of history. For us to get to the truly massive scale of data that we need, we can't continue to rely on centralization of that data. And blockchain is on the critical path of decentralized approaches to creating that derived data, creating that value without building massive centralized data lakes. So there's a sunsetting and an emerging paradigm. In our sunsetting paradigm, this is today's normal. We have to copy and move source data from place to place. We have to perform analysis only on the limited source data that we are able to actually move from place to place. Often we have to de-identify it. Then it has to be normalized. That's a big process, usually involving lots of manual effort on behalf of teams of data scientists. Then it's finally analyzed and values created. The whole process is slow, labor intensive, extremely error prone, and fundamentally untrusted, such that every enterprise has to receive their own copies of source data and perform their own analysis because they can't trust other parties' analysis or the source data. In the emerging paradigm, where this new technology for trust is incorporated with other emerging technologies, that enterprise and self-sovereign source data remains at rest. The analysis is performed instead in blockchain networks, where the federated data is tightly coupled but off-chain. To be clear, I am not advocating ever storing any health information in the blocks in a blockchain. We're talking about tightly coupled but off-chain compute and storage. The normalization of that data is still required. Blockchain is not a panacea for semantic data interoperability. So you still require normalization, but that normalization can be done at the edge where the data is at rest by distributing rule sets and automating those processes. And then finally, the analysis is actually what can be centralized, aggregated, and combined. The derived data shared with that federated network, including federated learning, that can be incredibly amplified and accelerated. So at the end, you end up with a process that is rapid and automated, quality controlled, and trusted. Blockchain is going to intersect with a number of other massive trends happening in the industry. The move to precision medicine, the ability to apply behavioral economics for the first time due to tokenization, the move to increasing person-centeredness, the move to the everything as a service, or a new kind of utility thinking that is critical to supporting particularly patient-centeredness, patient sovereignty, dignity, privacy, agency, and the move to decentralization of data for all the reasons that we've described. These things are all intersecting and happening at once. And so finally, I'm going to close it out with this slide. This is everything that you see in the left-hand column in the lighter blue is what we think of as blockchain. You've got blockchain networks that are public, private, and hybrid. Those run smart contracts that deliver secure automation across organizational boundaries. Optionally, you can use tokenized assets, cryptocurrency, non-fungible tokens, all kinds of ways to tokenize data, to use incentives, et cetera. And then finally, decentralized apps that run all of this. But again, this technology in isolation is necessary, but not sufficient. The other two families of technology that are required, in my view, in order to create the massive transformational benefit is a bundle of technologies I call privacy in depth, paired with decentralized AI. So if you think about privacy and depth, these are both hardware dependent and software dependent modalities for confidential, trusted, and verifiable computing. Things like trusted execution environments, secure multi-party computation, fully homomorphic encryption, zero knowledge cryptography, etc. And decentralized AI is entirely new approaches that do not require massive centralization of data in order to train machine learning models, and where models that perform inference or make predictions are able to be deployed in a very secure and an improved bioethical and cybersecurity posture. So all of those things together need to be addressed with the intersectional barriers that require all of us as leaders in our industry to come together to address these problem spaces. And these include bioethics, identity, privacy, cybersecurity, and compliance. These 5 areas represent the fundamental problem space that our industry needs to resolve, and that these technologies uniquely can work directly to address those problems. So with that, I'm going to say thank you on the talk and invite any questions from the audience, and then we will move to our second speaker, Marian.
Right, and we also have with us at the moment Ms. Juby George Weiss RN, CEO and Chief Innovation Officer, Globex Health USA, joining us. A very good morning from India to Ms. Juby. Very warm welcome to the program.
Well, welcome, Juby. Heather, I think the presentation that you have showed is amazing. Great presentation, lot of information, and it has been represented in a way that a lot of people would really need to get more into details and understand each and every aspect of blockchain and how it really impacts everyone's life at this point, right? One of the questions that the audience had was it's related to COVID itself, and the question was, could we leverage ML AI help identify situations like COVID? I mean, that has already happened, but anything in the future that might happen, and could it be a way to be more proactive to figure out situations like this that might happen? So any color on this from you or any other panelists would be great.
Absolutely. So it begs the question, if we have had such powerful artificial intelligences from a software perspective since long before the pandemic, why did it not effectively, and could it not effectively be used for prediction? And it's not because our AI tactics were insufficient. It's because the data that is used to train and the deployment models to perform inferences are all siloed and splintered. And were we to think that we could predict something like this in the future, the way the world is thinking today is that it would require, the way everyone's thinking is, oh, our AI didn't work because our data lakes weren't big enough. So the answer lies in how do we inspire citizens, governments, corporations, everyone to be willing to share and centralize always more data. And I would suggest that those are incorrect assumptions. They're false premises. And that by using federated learning instead, so this means where you're bringing the machine learning model to where the data is, instead of bringing the data to where the model is. By using federated learning in large-scale blockchain networks, we have the potential to learn real-time, real-world evidence in the form of federated analytics, and we have the ability to train machine learning models so much more quickly than we can even imagine today, and with such improved outcomes because of the vastness of the data by comparison to what it's possible to centralize. It's not possible to centralize anywhere close to the level of data that you could activate if you didn't have to inspire the actors in the network to share their data. They didn't have to share their data at all. That's what's possible. But then I have to add, well, federated learning has been around for a decade. Federated learning was invented by Google 10 years ago. It's used in mobile phones all the time. Why hasn't that taken off? If that capability has been there, why aren't we using it? Well, the reason I believe is because federated learning also is one of those technologies that's necessary but not sufficient. There are missing pieces to federated learning in isolation that only blockchain technology can fulfill. And this is why that convergence of stop thinking about these technologies in isolation and begin imagining the art of the possible when they are combined. And then the answer to that question from the audience is a resounding yes. Yes, we will make better predictions, and we will be able to do so while preserving the privacy and dignity of every human being on Earth.
Thanks, Heather. And I think the second part is from my side itself. Like here in the US, you have CCPA, and then when you move to EMEA, you have GDPR regulations with the whole personal information. And when I'm trying to marry the information that you just talked about with the different regulations, so I think there is a fundamental gap between what the government regulations are to how we want to really use the data in our favor as a part of determining what could happen in the future. So again, that's my thought process. If you want to add anything else on that?
I think that's very insightful. Under GDPR and CCPA and similar regulations around the world, our governments are empowering citizens with rights to treat data as property of different sorts and different kinds of property under different jurisdictions. The problem is the parties who provide any of the infrastructure or the software that would enable a consumer or a patient to actually do that are not disinterested. They also have a claim to that data, and they also have a business model connected to how that data is monetized. So in my view, while the consumer by governments have been provided with rights and privileges, there's still a missing class of institution. Call it a data union. Call it a new, I think there's an initiative under IEEE that myself and others are working on called health utility grids. But the idea is that there needs to be a new kind of institution that corrects for the asymmetry between individuals and the enormity of governmental and corporate bureaucracies, and that allows individuals to have an ability to make legal claims against GDPR and say, I want a copy of my data. I have a right to it. Well, that entire workflow and that process, and then where that data goes, right now it would just go into chaos. So there's work to do as a civilization. It's wonderful that we have new rights and privileges, but there's still work to do to create order out of the chaos on behalf of humanity.
That is great, Heather. Thank you for answering that question. And I think the way you explained that, it's amazing. And thank you again. I think this was great insight and amazing presentation.
Thank you. That's very kind. It was wonderful to be able to share my thoughts, and I'm excited to introduce my colleague Marian and hand it to you, Marian, for your intro and your presentation.
Right. Thank you, Heather. I have a lot to say that will probably relate. I'll try. And then, of course, thank you everyone for attending and also the invite. I'm going to do it like a bit of a storytelling because Heather did such a great job of making it very concrete what we need to do. And I do the same for my work. But I'm going to do it like a journey for us in healthcare. And it's going to be like a before and after. So the first thing is before meant before everything happened, right? So before the whole COVID situation went the way it was, where we were as Singapore, where we were as healthcare, where we were at the healthcare system, and then now where we are, and also where we're going, right? So for those who do not know me, and I'm just Singaporean, but my name with the German is my great-great-grandfather's German. So he came to Singapore, immigrant like everybody else, and here we are, right? This tiny country. And in a country where it's so tiny, labor has always been, and talent has always been the greatest resource. So highly educated demographics, and therefore, as you know, entering the region through us was easy for most people because we are this little island. And from here, you can stop to get your oil, your refuel, your plane can land, and then you go on your way. And so it will end up being the hub for Southeast Asia in many ways, right? We have banks here, we have a lot of multinational companies here, blah, blah, blah. Through the years, the Economic Development Board in Singapore has built a very large and strong ecosystem of experts from around the world coming in, sharing expertise, growing the talent base, and sometimes leaving or sometimes staying. Sometimes staying in Singapore to enter the new markets in Asia, and sometimes again leaving, right? So it's almost like a little hotbed of testing whether a European company could enter and be of service to Asia or not, blah, blah, blah. So this is kind of where the story starts for the story of Singapore, but the story of me getting involved and anyone who's in healthcare, but not a doctor per se. So I'm a developmental psychologist, educational psychologist. I grew up in Singapore, did very well in school, and wanted to be a teacher. And so I continued being a teacher. Then I realized that along the way, it's not that we don't know what to learn. So like Heather said, all these things are out there, but there's a resistance to the learning or changing. And so I became a psychologist, right? That became a terrible journey because then you realize that all people do is not change. So education in itself is not helpful until people want to learn it. So I thought Heather would laugh because I actually had a data analytics course forced upon me in the midst of COVID by my university, right? National University of Singapore was such a compassionate career place, which was lovely. And people who had less things to do because they're not healthcare got some learning while we waited for the world to continue. But people like me, who was in the midst of healthcare and other things, we now know data analytics painfully, but very helpful because like what Heather said, many of us are now educated to do the next step. And it can't be the government, it can't be the education systems, it can't be the parents. It really needs to be each individual needs to be empowered enough to be part of a new system, right? So here's the storytelling, and here are my slides to concretize the story. But yes, I am now in healthcare. And what I do for NUS School of Medicine is I scale healthcare education, right? So what does that mean? Now, literally, the healthcare industry, I do not need to tell colleagues here, we are standing at over 9 trillion, second largest industry in the world, consuming around 10% of the GDP of most countries. Now, that's one thing to know. But the second thing to know is, of course, we still don't have enough healthcare workers, right? This just isn't enough. It wasn't enough before COVID, and it's totally not enough now. And how did this happen? Why is it still happening? So let's start with an example from Asia, right? I'm going to read this slowly with you. And of course, I'm sorry, I'm not going to be representative of all of Asia or even of Indonesia, but these are the research I gather in my work, yeah? So for Indonesia, which is a huge population, there's a shortage and poor quality of healthcare professionals because of the following things, right? They just don't have access to it. When they do get access to it, the level of the teaching or the level of the Center for Learning is not the best level. So we have many nursing programs in Indonesia, but only 2%, you can see the bottom orange segment, 2% are qualified as A accreditation. So this means that no matter how many nurses they have, there may be nurses who are unable to match what is needed in the industry. Okay, so for example, one of the call outs during the COVID crisis was some of the nurses needed to be reskilled as emergency ward nurses or ICU nurses, and they were not skilled that way. So they could not be as helpful in that emergency as per normal. And again, what happened during COVID was, even though Singapore has the ability to train, no one could fly over to Indonesia or the other way around. So this is where we started really pushing the online agenda. We've all pushed the online agenda, but we didn't do it this intensely because we didn't think it was necessary, right? What else can be done for Indonesia? As you well know, the telemedicine industry has grown in leaps and bounds, right? Previously, adoption was slow. With COVID, adoption in the ages of, if I'm not wrong, 45 to 50 or 60 grew multiple times over, and the older generation also accepted telemedicine. So when you see these new ways of functioning using technology, we are aware that people have adapted, adopted, and have become Zoom friendly, which is a great advantage to downloading content and downloading information. But as I said, it may not be a learning yet, right? Now, the agenda for us is actually very clear. Apart from this emergency that we're facing, as a general whole, there is no equity in healthcare, right? Life expectancy of a citizen is by the luck of the draw where you're born into. And that is really unfair, right? Not acceptable at all. And again, it doesn't even mean one country. Within a country itself, right? Like in America, South Dakota has a life expectancy of 66, Colorado, 86. So this disparity is not an issue about nation, right? It's then an issue about geography, access to resource, and socioeconomic status, as well as lack of healthcare professionals that are trained. This cannot be overstated, right? It's a long-lasting appearing issue. And then the harshest thing is those who are in healthcare, right, are aging. Okay, so I'll be very honest. People know that Singapore is a large consumer of international talent, especially in healthcare. We have a lot of Filipino nurses and other countries as well. Because on our side, our own people are not taking up healthcare roles, right? And the other thing, to be very fair, is not all healthcare roles are equal, right? So many people still do the doctor, maybe the dentist route, but general healthcare, allied health, overworked, underpaid sometimes, nurses, overworked. I'll give you a very strong example that happened during COVID that really hurt us. No? So I do a lot of groups with speakers, and many of them are like women's groups. And one of the head nurses said to us that during the COVID period in Singapore, it was clear that some of the women who are nurses, skilled nurses, were literally told by their husbands to stop nursing during that period of time, to stay home to take care of the children, because there was stay home, right? And no school. So we lose skilled workforce during this period of time because they were mother and nurse. Not enough support from governments, not enough support from society to change the way we look at healthcare as a talent pool and a key resource for the development of a country. The aging population in healthcare is going to happen, especially if there's also a geographical divide, right? And not all countries are equal in this divide. As you well know, Japan, Singapore, Germany, more of the super Asia countries have started being more aware of this and have started putting in place supporting help to nurses and support staff. Yeah. So one of the things that's been very interesting is my work is education. And my job is to see where best we can put in education to support the next level of need and the next level of demand. And we know, of course, that technology helps, but we also know that we cannot just use normal training this way. We have to do it more holistically, more engaging, and also retention as well as accreditation. So I'm going to give you a good example. Just because there is a COVID crisis doesn't mean the doctors and nurses stop getting the accreditation. Anyone that comes out as a nurse or doctor or pharmacist or dentist needs to continue getting CME credits. And in Singapore, what we started doing was my unit, started creating CME credits as well, which will allow for Singapore doctors to claim, as well as asking international participants of our seminars to claim within their own country. One of the desires we have is that if we are able to create more content that is credible and can be used as credits, people can just watch our program, take a quote from us and put it in their own country, and their own medical association would definitely redo it and use it as their own accreditation. So I am using technology for change because technology can scale things. But the mindset, that's a nice word. The mental shift, that's what I was trying to say, and the mind needed is not the normal mind, like what Heather said. From country location specific education, we must now move to global, local healthcare. What does that mean? It means taking curriculum design globally that's already considered best practice, sharing or making it very affordable, but localizing it for the local context. That is something we haven't done. We haven't done. And ironically, why? Well, the story of Singapore was we never had that ability to do that. We were very concentrated on doing our own work for our own country. And probably the same for most of the world. Most of the world was very concentrated on doing the best for their country. But the best for their country in terms of education was not scaling. And we need to change that. So, example again, in Saudi Arabia, expatriate healthcare workers represent most of the healthcare profession. There's an overdependence on foreign nurses all over the world, right? And even though now some of the countries still can pay for them, there's just not enough nurses. Heather mentioned her journey into this whole arena through family commitments. I watched my mom and dad in the hospital and then on their deathbeds. And the nurses and my friends who were nurses were the ones that taught us what to do to help them. There were not enough. If not for the fact that my mom had two of us, it would be a challenge. Two of us, meaning my brother who made the money, me who kind of stayed home while earning my own money in my own business, and a helper. This is not a luxury. This is a necessity that you have at least 2 to 3 people to take care of an aging, chronic ill parent or spouse or child. And again, it's not just nurses, doctors as well. There's not enough doctors. People are taking doctors from other countries instead of growing their own homegrown doctors or nurses. Not a good bad situation, just is. The economics of healthcare is not the best for equity or well-spread use of talent, not at all. So what did we do differently? This year, or last year rather, 6th of March, I remember it clearly, we decided to launch the COVID updates for Singapore, the first one. We've never done it before. We had a standee at the back of a room. We had internet that was unstable, whatever. Now, more than 20 webinars later, more than 6 months, in fact, I think 8 months of programming, we have 87,000 people from around the world tuning in because at that time, we knew something a bit more than most of them in March and April last year. Dale Fisher, who's in the middle, is a WHO expert who was in Wuhan and is very connected to updates. And our team did a weekly update. And people were desperate for information and education. They were desperate. Moving from that now, we have done a healthy longevity series. And we still do that now 3 times a month. You can sign up easily, free. And what we're doing now, because of the concern with aging, is a disease. Okay, aging is not a natural progress, it's a disease. And once you can work on reducing your aging likelihood through watching your biomarkers, through knowing your life modifications, as well as certain drug use. And our scientists like Brian Kennedy are doing work with stem cells and doing work with modifications, right? And doing studies. We are trying to share this with more people, right? Especially the countries that need a lot more educating before we reach another silver tsunami on top of a pandemic. Okay, so my favorite point. What are we doing now with the nurses? Guess what? we have really tried to make it more friendly for the generation at hand, which means it has to be more online, more accessible, more gamification. And again, not every country or every medical school can do this. National University School of Medicine, Yong Yu Lin, is a teaching academic faculty with NUHS, National University Healthcare System. Our NUH hospital is a teaching hospital. So we get direct feedback regularly, quickly. My faculty are medical, academic, researchers, entrepreneurs, fathers, mothers, and generally, I do not know how they have the time to do all the things they do, but we do it. And that has made our education really rigorous. We want to share or collaborate more with you and the rest of the world. Anyone here, reach out to me on LinkedIn. We are trying to make it together because we've already done most of the work. For example, we've considered all levels of interaction. We have heard from our colleagues in Europe, fresh off the press yesterday, that in UK, they're calling in for tenders on the first ever totally online blended undergrad medicine degree. They may have to use it for the UK, right? And they're calling in consortiums and e-learning to put it together, and they're open to it. We have to consider how this could work. And of course, AI, right? So one of the things people always say that you can do e-learning, but you can't do the actual skills. Well, yes and no. We are using a lot of modifications that are really handheld, not just computer like this, but no, actual live simulations. And we're not the best, but we're doing it. And again, if you are great at this, connect with us. We had international delegations come in and show us their best craft. We had surgery on hearts, right? AI, yeah. And you well know that before all this happened in Shanghai and Beijing, they were sharing their surgery theaters with some other hospitals in the world as sister hospitals, as sharing and learning. In fact, this year, was it this year? Oh my goodness, may not be this year. Last year, Latin America and South America countries reached out to us through their ambassadors here, and we did a remote consult, hospital to our hospital, Latin America, South America to Singapore, because they also wanted some understanding of the COVID situation, right? And they were not getting enough understanding from their usual learning partner in the US. So you and I know, and I love India for this. I actually love the tech in India. I go to Bangalore a lot, Delhi a lot. I miss you all. Please let me come back in soon. But you know, apps, online learning, crowdsourcing, right? These words all just came in from the COVID updates, right? All the COVID issues. And we have a bot medical person, right? Otherwise known as AI, that will educate our nurses, pharmacists, and people on the ground immediately on what is a new term or new procedure just on the go. And that's how they've been learning on their own, just created in the last 1.5 years. Yep. So I would like to remind you that education in academia, government policies alone, industry by themselves doesn't work, all right? We need to definitely partner more. We are now in a place where nursing homes are actually giving accreditation to their own staff that they train. We are now in a place where ministries of health build hospitals in remote parts of a country, and family business see that that hospital doesn't have a adjoining medical school and want to put money in for a school there. This allows us and US Medicine to give curriculum, to give guidance, to give supervision and mentoring to a local entity to do the local thing they need to do at the basic costs, because it's not longer about economy or market. It is about one humanity, right? Just like Heather said, we are not sharing enough in the right way. Share together in the right way, not give away our rights, but to be educated about our rights and also to ask for what you need from the global community. We are also very lucky. We are in the forefront of technology and we have been trying it out. But another thing that we know in Singapore is we are a small country, small island. And we want to make sure that this goes to countries where we also benefit from learning about new diseases. Finland and Singapore have been in discussions for years over diabetes. Different countries like in the world have been discussions with us so we can learn from each other, right? So robotics, AI, blockchain, I'm an educational psychologist in healthcare, not the normal route, but the new route. We need so much more administrators. Yesterday, I spoke to, again, another colleague in the UK, and they said for every one doctor who's a faculty member, you need 2 to 3 academic staff administrators to support, because this doctor cannot be doing healthcare and educating at the same time. But if he or she doesn't educate, we do not have the next generation of healthcare. And even if we did, they will not be well trained. And this is my final slide. Let's try to act as one. Okay, let's open some borders in academic communications, in sharing of resources and learning, and make the technology learning online good one, best practice ones. I'm not saying that out there is not good, but let's talk about it more so that we can make it benchmark to what is needed. And also give the right support to nurses, pharmacists, allied health. A lot of women in these countries, in our region of the world, right, have taken on secondary jobs. And therefore, when they're lost, like they're caregivers or teachers, their husband have the main job, and these extra people who are skilled or caring have no other way to come back into the economy. And we need to allow this to be easy. Yeah. So come, talk to me, ask me questions. And more importantly, let's keep the conversation going. We are all in this together. Yeah.
Marion, great insights. Following up to your point where you indicated that there was shortage of nurses and medical staff during COVID. One of the big things I'm seeing, at least in the Silicon Valley here, is that conversational AI is playing a big role. And what I mean by that is a lot of questions are being answered by the AI for people. That means that is freeing up time for a lot of nurses and a lot of medical workers to actually solve the big problems. So I think I'm already seeing AI playing a very important role just due to COVID, and different startups just booming up, focusing on conversational AI. But I think you nailed it to a point where AI is playing such an important role, and I think COVID really justifies how important AI is in this whole ecosystem, right? And that's one. Number two, this was a question from the from one of the participants. The question was in regards to bringing up knowledge about AI to the mass public, right? Right now, the issue is that, okay, people know about AI or people have heard about AI, but it's not in the mainstream, right? And I think it might take some time, or probably decades, for it to really get onto the general public, because people would be interested and they see the benefits. What do you think would be a good approach, a good strategy to get it out to the masses and see they realize that there are added benefits once they know about this knowledge?
Yeah, you're so right. So first things first, I needed to jump in and make a joke. Actually, right, we need translators. We don't need the AI. We don't need the information. Let me explain. We have done this. The tech people come into the room and the doctors come to the room and they do not talk to each other. Don't ask me what they do, but they cannot understand it. And there's actually conflict management issues. Because both domains are so strong and scientific. And so I actually, again, developmental psychologist I am, I play a translator role. I say to the scientists, that's what they're telling you. And I tell doctors, that's what they're telling you. And I push them a little along the way. So for Heather's course, I would make it a course. Heather, come and be our faculty. Let's make an online course. You know what I'm trying to say? But the point is, you have to push them a bit along the way. We do not have enough translators. We do not have enough curriculum designers. Customer service healthcare is the type that you're talking about. Just like if you buy a shoe, people tell you about the shoe. Why does no one tell me about what is the operation I'm going to go through? It can't be just the doctor that knows. There are many people in between. So to answer you about AI, honestly, AI, people are using it, right? How in the world do I get all the things I want from this? It's just they don't understand that this can be translated to healthcare, and the other way. Healthcare sometimes don't allow itself to be translated. There is
Sure.
an ivy tower around doctors and academia, and you have a master's degree. I'm sorry, it's not correct anymore.
Thanks, Marion. Great insight. Hedda, did you want to jump in and give your insights on this?
Well, Marian, I greatly enjoyed your talk. It was rich with insight and your personal experiences and the quality of your research. I was struck by your local global approach, particularly, and I really liked the way that you acknowledged that the way we've been thinking about this problem, it doesn't scale. And that kind of blunt message of, listen, everybody, the way we're doing it isn't working, just worrying about your own country's healthcare, it doesn't scale. It's not working. So we have to think differently. That was really inspiring to me. And I'm wondering, was there any one moment of insight that caused you to see that, or was it more of a gradual understanding that you developed? How did you arrive at that?
My dean is an amazing man. I'm not going to take credit for him. My dean is the one that says inspiring healthcare for all. And my dean is the one that just came in 1.5, 2 years ago and started intentionally growing the outreach. But of course, all of us are now doing our part to extend our own thinking. So we are extending our own thinking, and also we are overwhelmed. Every day, my doctors, I take off my head. My head of my department is doing surgery all the time. I need to talk to him like 7 in the morning or 9 p.m. at night, whatever. Between his 3 children, his surgery, he's being the head of a department, So we do what we can. That is why all of us should know. Actually, healthcare is not about the doctors or the nurses. We need more everybody. We really just need more of everybody. And everybody to be a bit more kind to the healthcare professionals, because they can't do everything either, right? I had my women leaders in healthcare that we just did in International Women's Day month, right? Last month. I tell you, so amazing. And all of them are sharing me one finger, one toe, one hand, because they just can't do anything else. But they wanted to meet and talk so much. They have so much to share.
Thank you, Marian. Well, we really appreciate you sharing your perspectives, and thank you. So I think we have the opportunity to move to our next speaker. Hello, Juby. Lovely to see you. And I'm going to hand the floor to you, and over to you for your intro and talk.
Well, thank you, Heather. By the way, if you guys don't know, Heather and I know each other pretty well. So we were both kind of surprised. So we're doing this together, of course. Apologies for running a little late. Had some Zoom trouble. And one thing, I had to put a few slides together last minute because I thought I was going to talk about the journey of women in healthcare versus some of the journey that we had in the past year for a COVID, but I'm going to do a blended. I hope that is okay. Let me just share my screen. And let me pull up my, gosh, I have a lot of slides open because I was moving things around. You guys are able to see my screen?
Yes, we can.
Okay. So I started with women in leadership, healthcare leadership. I'm just going to try to start to focus on that. I'm a nurse by training and have an MBA in health systems management, over 25 plus going into 30, but I tried to stay at a 2 decade. I don't want to age myself. I started my first computer coding was somewhere in 30 years ago. I have a natural talent for it, but I also have deep insight and knowledge into healthcare finance, and technology, but also cybersecurity compliance. Heather and I intersect in the area of our work, joint efforts at the HIMSS blockchain, and of course also in the IEEE blockchain. And she's more, deeply involved in blockchain than I. My current focus, I've done large scale transformation work in healthcare in the US, and that is in multi-billion-dollar range with the millions of population. And the current focus with the Globex Health is a company that I started with the help of doctors, nurses, technologists, engineers, and finance people. Is our focus is in elder care, aging, polychronic condition management, and some innovation and technology. So it's a little brief outlook. The only thing I want to bring out is we have extensive experience in this industry. And during COVID, because we are led by an infectious disease doctor who's also a population health lead, is a pediatrician, is an internal medicine doctor with a background in biochemistry, genetics, cell biology, I have to tell you that we were pulled into interesting worlds within the world of COVID management. Because my background is in healthcare finance, I always want to look at, US healthcare spend is about 3.6 trillion, and 50% is between hospitalization and physician services. And the area that a lot of innovations and funding and resources are pushed toward is to reduce that cost base, to reduce it so that people can be managed better at home. Part of it is under Medicare, which manages the elderly. They are paid into the system. It is retirees for over 65 and over, and their budget is $800 billion. But the challenge right now is there are more people coming into the program because baby boomers are hitting retirement age. Right now, it's averaging about $13,000 per person, while the average spend for the rest of the population is about $10,000 per person. All this is driven by fourth industrial revolution, and we have a lot of tools. Can we do more while spending less? Yes, I've done that before, and it's possible. And it's some of the work that we're doing. It means digital health. Some of the things that Marion was talking about during COVID, I'm working on utilizing tools like telehealth, remote health monitoring, optimizing revenue cycle, smart devices. And this is an ecosystem that I'm working on. This is patient-centered. It's got a little bit of blockchain in there, but nobody wants to call it blockchain. This will transform elder care and community-based management. It is a lengthy process and complicated and multi-industry stakeholders, but something that's needed. And because I work with infectious disease and other type of experts, we got pulled into different aspects of COVID early on, and that means March of 2020. So we had a 14-part webinar series for medical community because there was so much information coming at them. There was no clarity. We hosted about a lot of physician leads and heads of hospital systems, and it was an experience, a learning experience. Early COVID, we supported a lot of ICUs in the New York, New Jersey area, and they were getting to a capacity. And there were issues with trying to do convalescent plasma. Convalescent plasma idea was published on March 14th by Johns Hopkins and Einstein. Is the medical director that I work with, Dr. Grossman, she's one of the few people who's still alive and practicing in this area who actually have physically done it. And the head of transplant at Mount Sinai knew about it. So he had pulled us into this whole process to support all these efforts from massive amount of academic institutions trying to do it. So we are all like in the middle of the evening, night, weekends, trying to put it all together. And it is because she and the Mount Sinai worked together, is because the Mount Sinai was the first one to do the convalescent plasma. We ended up having to help a lot of hospitals in the area do that. And then we just got flipped right into the nursing home struggles. And we had to help a lot of nursing homes get on telehealth pretty fast. Some of the doctor practices and everything tried to convert into telehealth. Some industry and businesses having to understand how to manage employees at home while trying to work remotely. Now we are focused a bit more on educating the industry and government about post-COVID syndrome, chronic post-COVID syndrome. We just did a few series of presentations on in the last month. There is a $1.5 billion funding to study this, but studying doesn't do a thing because you need to actively manage it. Right now, it's a hidden time bomb. So that is an area that we are working on, and I'm trying to bring some attention to it, but it is very hard when you are already focused on the PPE, the vaccine, and the active COVID. This, myself and Dr. Grossman, we worked for a company that was on One World Trade Center, and we were impacted by 9/11, but we were medical management for health insurance. So we actually had the patients who were impacted by 9/11 for over the course of decade and plus. So we just have a longitudinal understanding of what happens with it. This is very similar. So, but moving faster without the oncology or cancer issues, but all the others are very similar. It's affecting children, adults, everybody. And if you don't intervene, it just becomes a lot of complicated problems. So it's getting some attention and some funding to work on it, but we'll see what happens. I think I put in another slide. So that was the kind of presentation on that kind of work we did and continue to do during COVID. And we do have other things that we're doing. We have a physics-based technology solution that does have some effect on COVID in the air. It is very interesting. I consider what we are doing almost like Steve Jobs in 2000 trying to explain iPhone 12 to any audience. It's very complicated. The only people who understand it is physicists, such as the Department of Energy, nuclear, areas in that complicated world. But we did get an emergency use authorization from FDA, but well, I have to say it correctly, emergency use discretion. And we're in the middle of getting a full 510K. It's in the process. So it's an exciting area. So that took me, this nurse, into having to deal with the BSL level 3, BSL level 2, enhanced biosafety labs that has real live COVID virus, aerology tests, multiple interesting world that I would never imagine that I had to do. It had have me go, I have to deal with the DoD, active military command, and places that even manufacturing. Now I'm dealing with manufacturing of a device. It's interesting, but this is not our regular normal operation, but we chose to involve ourselves into this. And so it's an interesting space to work on. And all these efforts, actually, our company was recognized by Cranes New York, and my medical director and the company won an award for some of these early efforts, and they call it Health Heroes for New York. So we are proud of the work, but it's been a lot of work, different things that we have to do to just support. And we didn't want to take on the post-COVID syndrome because it's a heavy lift, but we've kept trying to make sure it is addressed. But the only thing was 4 or 5 months ago, we went to them and said, this is a problem. We got to do something. You got to create at least an ICD-10 code. So they actually listened to us and created 3 ICD-10 codes. So there is a way to catalog it. Now, the next step is, how do you educate the physician community to start putting that together and the patient community to address it. Because of how payment systems are set up inside the US, and if you have a COVID diagnosis code, a lot of things just slide under the radar. Many hospital system, and I don't mean it in a very negative way, they started creating this post-COVID care center. They call it PCC. So now pretty much there's 100+ attached to each hospital, in the country that's trying to treat the long haulers or the chronic post-COVID syndrome. The challenge is nobody's standardized, and the things that they are doing is very, it's just whatever they have an affinity for. It is not, and it's just Wild West, to be honest. And we don't know what's happening. Even with this $1.5 billion release to kind of support all this, it's not enough. When you think about what is the total spent and what is happening. So we are also working on the legislation side to kind of have them release more money to apply it the right way so that more can be done before this becomes a larger, significant problem.
I have to interrupt. I'm going to interrupt. Juby, you are exactly the people I work with. And when you say it's actually, she actually means me, okay? Just everyone here, she means me. And I have to do this, and still survive. Hats off to you. Hats off to you.
Yeah, I mean, I the everyday is an interesting world, but you have to understand, I work with some women. So we talk about women leadership. I am just a pathway. I work with some amazing women leaders who have paved the way for me. So Dr. Grossman, some of the other people that's with me, they're there to support me, guide me, and they have done this in a massive way where I'm just following those footsteps. So I do have some support, but it is very tough and it is not easy. I mean, listen, I can go code something. I can go figure things out. The US has big data work. So the data, just to understand and identify what is COVID, then what is post-COVID, you have no idea. Nobody can agree on some of these algorithms. And I'm looking at, the data core, and I have access to it now. First of all, you got to go through crazy things to get to access. And I'm looking at like, why are you guys here? Why aren't you here? Then they're looking at me, can you help us? I'm like, I don't have time for this. This is not something, but I speak computer coding, but I also speak healthcare coding, CPT and ICD-10 and all those revenue cycle side. So it comes together easy in my, just that one brain. So it's very hard to kind of say no. And I'm like, but I have to say no. Like, that's one of the things I was saying, you have to say no at some point, because otherwise you cannot survive and function.
Okay, so she's a translator. You hear that, translator? She speaks this, she speaks that. No one, see?
Yeah, it is. And I can speak clinical. I mean, you can throw a cardiac transplant, anything at me, and I work through that because that is my world. So I actually had a few slides ready to talk about that journey that I went through because I really thought this was, talking about each person's leadership journey. So I had some slides put together for that. So let me run through that if you have time. Is that okay, guys? Because I don't know, what you guys want. I'm very flexible.
I think we have time. Absolutely. Maybe if you spend 5 minutes on that, and then we spend another 10 or 15 minutes discussing, discussing our experiences together, and that will wrap up our segment. So please proceed.
All right. I immigrated from Kerala, India, when I was about 13, and I didn't know any different. I ended up in a high school where that's not too far from the IBM's world headquarters. So IBM and Apple had some sort of competition going on within itself. So there was 2 rooms. One room was full of Apple computers. Another room, double the amount of IBM computers. I mean, 50 or 60 computers not being used anybody. IBM with Microsoft at that time. And, I just learned to code and do a lot of things very early organically. And, and then I ended up getting involved with a lot of the financial side early on at a young age, understanding how things work. But, family, practical decisions influenced by family went into nursing. I was bored out of my mind. So I took a lot of extra courses, all the way down to golfing, to horseback riding, to law, to, you wouldn't believe the amount of, but that got me interested and understand what's working. But the college that I went to is also right next to IBM's world headquarters. So a lot of people go back and forth. A lot of resources are thrown into that college too. Here's an image of it. So I got access to a lot of cool stuff early on and learned to do a lot organically. And from that, I actually went to work. My office was on One World Trade Center on the 24th floor. And I was assigned to New York Presbyterian Healthcare System. And this is very young. I wasn't even 25 yet. But I had enough background and work experience to understand and navigate all this. I had a T1 line. I'm directly hooked up to the World Trade Center from Columbia Presbyterian, but I'm telecommuting half the time. And I'm managing millions of dollars and looking at complicated clinical. But I need to understand contracts. So all these extra courses I took in college came in handy, and I'm doing my MBA at the same time. So interestingly, I was able to do a lot before I was 25. Even supported converting a nonprofit company to for-profit that had a valuation of $4 billion. $1 billion had to be given away as a foundation money to allow for the IPO to happen. And it went on IPO at 4.5 billion, had a merger at $6 or $7 billion. And then I ended up having to participate in this New York Presbyterian and joined up with Cornell, which also is Columbia University and Cornell University. So that's 2 medical schools, 2 nursing schools, a lot of other things. It was interesting background and I ended up on the board of some organizations early. It all happened to me before I was 25. And I decided I needed to have a personal life and get married and have kids. And I took a little step back. But how do you navigate path to leadership? Corporate culture. Ask for it. You don't expect them to give it to you. You have to ask, build your own network. Mentor. I mentor a lot of people. I am mentored by a lot of people. You get to a point where you had to make a choice. What's important to you? Money, being a CEO, work-life balance. I personally have a lot of roles, and I value my role as my mother of 2 children, being a wife, being a friend, and having a healthy life rather than all the other things. But one of the things is that even I fell for it is I thought I can do it all, and it's too much. You cannot do it all. At some point, you have to kind of say, no, I cannot do all of this. You have to kind of and I when I was struggling to figure out what can I do it all, this article came out on the Atlantic about this college professor, who also had a Washington DC big job, having to say, oh no, I can't do this all. I have to take a step back because I'm a mom and I have to deal with my family. There's always this gender inequality inside the business world and healthcare world. You do end up dealing with that, and you have to work around it. It's been 20, 25 years. It has improved. If you have a female leader in your organization, it can help. There was a certain point in my career, my CEO was a woman, myself. A lot of people benefited from that. She really created some channel streams that allow for women to rise up. A lot of organizations now have a women's network within. Like, for example, I recently had a conversation with someone who manages one of the Merck is one of the drug companies, their women's network internationally. And there are a few other organizations, pretty much they all have one of them. Otherwise, you can find one outside of any individual organization. And then find your balance. And I made sure there was those little blocks, because you had to choose if you want to take something on. You really have to choose if you want to take anything on, if you find your balance. And you had to figure out that and what is the price. It's not easy, because balance is not something that just happens organically. You have to create it, and you have to have boundaries. This wasn't a slide that I put on the side. So there you go. That was just the little thing that I prepared.
Thank you, Juby. That was, it was really terrific to hear more about your story and your background. It's extremely impressive. I mean, not only have you been an incredibly courageous frontline worker through the absolute darkest times in the United States' pandemic, but what you did earlier in your life, so much courage, so much bravery. It's really striking, and it's an inspiration to other women everywhere. I'm sure that you're willing to tell your story. So thank you. Marian, what do you think?
I wish I featured you this year for our International Women's Day, but we will get featured next year. And I've done a
No
bit
worries.
of networking already to try and see where we can put you in some sort of something that I do for education and understanding. So hopefully. But
Remember the boundaries and what I say, what I do. So you have to let me know, and I'll let you know, maybe.
No, I'm not asking. I'm just looking you up to letting the right people know. But the other thing is what you said, right? It's the networking. Just so we're clear, I personally just add up a space where all of us can hang out, because you never know who you need when. And I really appreciated that when you said that. And you have the Merck Women's Group. I have the BD, Bench and Dickinson. I have the Pfizer. I have the J&J Women's Group because of the International Women's Day. And last year when we didn't have it, we just all out put ourselves out there, and everyone put their LinkedIn profile to be tagged, so that we end up being a marketing campaign without any extra costs, just our own LinkedIn, right? And then one of the women said that because she was featured in this, her boss asked her for a career discussion that he never asked her about before. And then you see, and then last year we had 2 companies that featured the women in their LinkedIn profile thing because of the campaign. So just putting you in the right place allows you to amplify your OD strengths. Don't do extra. You're right. I personally have taken a back seat in my career. I wrote a whole article on how I gave up the high performing life, because it doesn't mean that you can do it means you do it all. It also means that you do the best thing for you, and also that new people need to step up. And education for me is how new people step up. We need to bring the new people in across gender, across diversity, across geography, right? And then they step up. Yeah.
You know,
Thank you,
I agree with you, Marian.
Go ahead.
One of the statistics that you presented, Juby, that was striking to me is that the 65% of the healthcare workforce is female, and only 13% of CEOs in healthcare are female. What do you think, Marian and Juby, are the biggest barriers to female leaders becoming chief executives?
Yeah. So we actually asked this question. Sorry, go ahead, Juby. Go ahead first.
So it's a culture. It starts from the beginning. If it's a hospital, it could be starting at the nurse's aide level or the housekeeping level. I mean, I still remember, they are not encouraged to step out of line or think beyond it. And I truly say that because I did a non-traditional path. If I didn't do that, I would never be where I am. And so that is a barrier. If you are a nurse, you're a nurse, and only you get to be a nurse manager. Maybe the highest you get to is the head nurse, what you call, or it could be now it's called the chief nursing officer or that kind of role. You never step into the finance role. And in the United States, healthcare finance is not something that you can just walk in. You do not walk into healthcare finance. I could say a different version of it, but you have to be brought up in it is the right word. And I'm brought up in it. You know, I put in like 25 years into it. So I have the right access, the right people, it's a process. So I can easily step into, if I choose to, a CEO role of a hospital system or a health insurance company. And that is the track that I would have been if I did not got off that track and decided to start my own company and do it at a pace that my work-life balance allows me to do. Prior to that, I was responsible for a lot of people, large budget, massive spend, and my hours are so long. I mean, I'm dealing with people in Hawaii, there's stuff in India, Bangalore. I mean, I don't even leave my house. It's home office, man. I don't even go into any office. But it was just, and I had a live-in nanny to manage my kids because I just couldn't do any of it. And there you hit a point where you realize you can't sustain that, or you're not happy with the track that's happening, and you had to make a choice of, well, how do you get off that and reinvent yourself and make some changes. I say that, I mean, I did similar. Before I started that work with Empire Blue Cross, that World Trade Center one, I actually was working in nonprofit. I was helping homeless, mentally ill people in New York City. And the track that I was in, it was not something that I was happy with, meaning I loved helping people, but I was very young. It's too heavy work, mentally taxing. And I'm too young and too pretty. So the patients get attached to me and even try to follow me home. It's really, it was not a good place. So I had to get off of that. Prior to that, I worked with, where I helped gangsters and mob bosses. I'm not kidding you. So, I just had exposure to interesting, and I said, okay, this track cannot happen. I got to get off that. So I did that one time. So this is the second time I did to my life career path where I have to change that. So not every nurse or every woman in healthcare look at it things that way, make decisions, or have the opportunity or ability to shift like gears like that.
Yep. I so hear you on that part, because I became an entrepreneur to take care of my mom, right? Because my dad passed from, and that's how I'm also lucky that I can make choices that most people would not. And also, you are not the normal woman or man. You are quite gifted. So obviously people are attracted to that gifting. I would like to share something I did at another workshop. I hope you can see this. Hold on. Trying to get it to be a big screen. Oh dear, maybe not. So if you can see this, hold on a minute. I'll stop the share and put it up to a big screen. I actually did a lot of research into this whole segment of what does it mean to be empowering and what does it mean not to be empowering, as in to people, right? And what happened was there are, of course, studies. I'm a psychologist, so I study human behavior. And the psychologist studies, of course, show this, right? Let me know if you can see the screen. You can, right? Can you all see my screen?
Yes.
Uh-huh.
Yes.
So really depends on where you are in a culture. So just now, I want to clearly mention Prof. Chong Ngap Singh, my dean, is in a high performance zone. He is very respectful. He's encouraging of the women agenda and diversity and gender. We put money where our mouth is, right? Our top is. But again, in the healthcare system, there are many people whom I know personally who have been slighted, harassed, and abused within the system. Giving examples of older people who are helping in the operating theaters, where some surgeons are very mean and nasty and move things fast, not because they're God syndrome, right? At the same time, there's also being ignored, which I have felt multiple times by senior leaders who do not think our inputs are strong enough or good enough, whatever that means. And so one of the things we do as a women groups or women discussions is to move the damaging to the high performance zone by giving leaders more indicators of what high performance looks like, right? And getting more allies involved. Some of the people I know, some of the young men and very good men I know have stepped up and said, we want to be allies, but what do we do, right? They cannot just stand up and say, here I am. They need to know what is a benchmark and how to help. So one very good example we had from a Duke conference was a man said in his younger days, he had taken out a notepad, he was ready to take minutes, he was the youngest new person in the room, and everyone was a man and him, and there was one woman, more senior than him. And then the CEO or the person leading the meeting said, lovely woman, blah, 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 why don't you take the minutes? And this man was there with, yes, with everything ready, and he paused. At that moment, he could have said, no, I want to take the minutes, I can, or something. He gave the notepad to the woman, and the woman took the notepad. This is not like, 1950s, all right? I'm sorry. This is like 1980s, 1990s, 2000s. So that is the moment that the conscious gap between I know and I do needs more context, more checklists. I'm sorry, I'm a very active woman leader here. I have so many things to share. Next time.
Very interesting.
That reminds me of an anecdote that always seems to happen to me before the pandemic, and you're in working sessions kind of through the day with a bunch of people in a conference room, and people start to get hungry. It's mostly men, and they will tell me they're hungry in this way, like it's my problem, like it's somehow mine to manage, like I need to deal with it, or I'm supposed to care or something. Like, great, I don't know, get some food. Doesn't have anything to do with me, you know. And but there's a sense that I guess because I'm the female among them, I'm supposed to feel responsible for making sure people are hosted and entertained and well fed, though they don't bear any such thought themselves. But it's just one tiny example of 1,000 things. But I believe we are at time now in our segment, and I'm wondering if there's one question from the audience, we might have an opportunity to take it. But otherwise, I think
comments even
or comments. Yeah, I think. Do we have any questions from the audience, or shall we wrap?
So no questions from the audience, but Aishwarya and Dr. Garg, if you want to add anything.
Madam Chairperson, welcome. And this session you have very ably demonstrated, chaired, and the subject is role of women in healthcare sector. But from very high technical level to social level, to training and personnel, and finally, highly productive women from Singapore. That has been done, so it is a diverse. Madam Chairperson, we have to honor you. You are required yesterday so that we should provide Energy and Environment Foundation, Modern Healthcare, Women Leadership Award in Healthcare Industry 2021. I will ask Aishwarya to start the formation and award function to Madam Chairperson. This is honor to each and every woman of this planet.
Right. Thank you so much, Mr. Garg. And not only Ms. Heather is the chairperson for this session, but she's also been bestowed upon a very significant award, and that is the EF Modern Healthcare Global Excellence Award. Let me tell a little bit about the award. Well, the annual Energy and Environment Foundation Global Excellence Awards were introduced for the first time in 2011 by the Energy and Environment Foundation to celebrate excellence, innovation, and best practices in environment. And as far as healthcare sector is concerned, this is the award that has been formulated to serve as a tribute to the winner's professionalism and commitment to demonstrate excellence in the healthcare sector. So let me announce the award for Ms. Heather. It is the EAF Modern Healthcare Global Women Leadership Award 2021. And a little bit about Ms. Heather and her contribution to the field of healthcare. She's the founder and chief executive officer of the Consensus Health, a spin-off from Consensus AG, effective March 2020. She chairs the IEE SA Open Standard Development Working Group, that is the blockchain in healthcare and life sciences. She's also the co-founder and board chair of Blockchain in Healthcare Global, that is BIHG. Ms. Plenary has served as industry faculty for the United States Department of Health and the Human Services Office of the National Coordinator for Health IT, and is an active consultant and advisor. Ms. Plenary also founded and led Obesity Prevention Policy and Management, Inc., an innovative provider of disease management, population health, research administration, and information technology managed services for health systems in the Americas, and an early adopter of blockchain technology. Ms. Flannery has driven business model innovation via technology early adoption throughout her 25-year career as an entrepreneur, technologist, and strategist. She has consulted in the public sector in the context of international development, bringing a global health perspective to her work. Ms. Flannery demonstrated as an outstanding international leader in blockchain in healthcare. So the EAF Modern Healthcare recognizes her excellent contribution and leadership role in the healthcare sector and confers her the EAF Modern Healthcare Global Women Leadership Award 2021. Congratulations, Ms. Heather.
Heartiest congratulations, madam. And this award will be couriered to you on your address. And this is time to give your brief acceptance speech, please.
Oh my goodness. I'm incredibly humbled and honored by the recognition. It means a great deal to me, and I can't thank you all enough. The first thing that comes to mind is about all of the other extraordinary women that I'm honored to work with and that I know and who inspire me every day, and all the wonderful men and colleagues of every gender and race and religious origin, and demography and geography and and you name it. I think part of celebrating the contributions of particular groups of people, be they women or any other demographic segment, really gets to the idea of what happens in human cultures that value diversity of thought, opinions, experience, backgrounds, and how the diversity of humanity can come together to be more creative, more innovative, to have more potential to solve the audacious challenges that face humanity today. And when we remember that it's not about just women, we live in families, we live in communities, we live in nations, and we're all spinning around at 35,000 miles on the same rock out in outer space. we're all one in that way. So it isn't just about women, it's about diversity, inclusion, and the kind of innovation, creativity, and possibilities that creates. So in that, I'm profoundly honored and hope that I have an opportunity to inspire young people of all types who want to chase their dreams. So thank you very, very much.
So thank you, Mr. Chairperson, Madam Chairperson, and this is an honor to all the women, and the woman which is most comfortable and in the most productive zones are here. Hopefully, these messages will percolate throughout the planet, and the woman will be more productive in times to come. With these words, I will just add that this conference is an annual conference on the fixed date of 15 and 16. And in future, we will honor some more outstanding women and excellence award in healthcare sector. So we will meet 15 and 16 April next year, hopefully in the physical form, but at this pandemic, the situation is so grim that some of the speakers are suffering from corona. So hopefully this phase will pass, and with all encouragement from you all, we will have something good in times to come. Thank you very much.
Thank you so much.
you.
And let me again thank the chairperson, Ms. Heather Lee Flannery. I'll also like to thank all the speakers for the very wonderful session we had this morning in India. Ms. Marian, Ms. Chubi, thank you so much for having joined us. And it was indeed a pleasure listening to all of you and getting the insights into this topic, and especially getting to know the women's perspective on several topics related to the healthcare field. Thank you so much, and we look forward to your presence in the subsequent sessions as well. And of course, looking forward to your presence in the next year's conference as well. Thank you so much for having joined us. Thank you so much.
Final word from Shubham. Final word of this session from Shubham.
I just want to add to a fact that I really enjoyed the conversation. Heather, you brought a lot of great points. Marian, you brought amazing points, and Juby, looking at your life history, I think it just gives a different sense of respect with the fact that so many things, every individual really goes through to achieve excellence as a part of your personal growth. Again, that's commendable, and there's something that every one of us can learn from you all women. So I want to thank you once again, and we look forward to having you in the next year's event as well. So thank you again.
Thank you all very, very much.
Bye.
Thank you, Juby and Marian. And to all of you, thank you.
Thank you.
Great.
Good night. Good morning.
Thank you, Marianne. Thank you, ma'am.
अरे यार ये तो वीडियो
Hello.
हेलो
Yes. You want to share a presentation?
yes sir, I just wanted to just share the presentation once to see whether it is working or not.
Okay. Okay. I will just stop my share screen. Then you can share.
Definitely sir.
Just wait. Mr. Yogesh, please stop sharing screen.
Can I share the screen now?
Yes, please.
Okay.
It's
Is
fine.
is the screen visible?
Yes, it's visible.
Okay, okay, okay.
Please
Great.
full screen. So it will be.
One second. I am not.
It's a PPT.
Yeah. Now it is in full screen.
Yeah,
But
it's
generally,
full screen.
if you're
Fine,
seeing
fine.
the reading mode, actually, if is reading mode okay, sir, or should we make it full screen?
No, no, it's fine. It's fine.
Okay. Okay. So I will keep it as reading mode, sir.
Full screen maybe. Full
Full
screen.
screen. Okay. Understood, sir. Understood.
There are some few icons are visible. That's fine.
Yes. I understand, sir. I understand. Yes.
It's fine. This one is fine.
So, sir, just one second, sir. I will just do this once again, sir, because I am not familiar with
Sure,
Zoom.
sure.
I'm here and sharing it again.
Just stop and please. Okay.
Yes. So I'm just going to share. Okay. Fine, sir. Fine.
It's fine.
Thank you, sir. Thank you so much.
Thank you. Welcome. Please stop share screen.
Yes.
Thank you.
Yeah.
So, yes.
उसको बंद कर दिए. Am I
Okay.
am I audible?
Yes, sir. Yes, Dr. Vipul. Thank you. It's fine.
So can I share my screen? Can you just allow me to check whether
Yes, sir. I will just stop my screen.
Yeah.
Yes, you can share, please.
Not able to. Just a minute. Yeah. Screen sharing. Mask or.
There's a in below green colors button, share screen.
Cancel.
Yeah.
Zoom ही है sir.
It is saying that it would not allow unless you exit and then log in again.
Screen तो then I will see share sir.
Dr. Vipul, I think you logged in at two places. It says Dr. Vipul Agarwal at
Yeah,
two
so
places. You have to log in out of one.
Yeah, it's my colleague. I think he'll support me with the screen sharing. Can you just share your screen?
Yes,
Yeah,
sir.
so
Yes, sir.
is
We have
with
it's fine.
Yeah. So I think it is working. Yeah.
Yeah, it's fine.
So I'll talk from my laptop and my colleague would share the screen from that one. So I think we'll have two Vipul Agarwals continuing. I think that should be fine.
Yes, fine.
Okay, thank you so much. Thank you.
Welcome.
Yeah.
Please stop your share screen.
Stop.
Thank you.
Yeah, sure. Getting done.
Welcome, Dr. Robert. If you have, please, if you have presentation, then please check.
Okay. Wait for a while.
Sure.
I have to.
मेरा भी वो start करा देना video.
Okay.
Welcome, Dr. Robert.
Yeah, it's nice to see you too. How are you? Fine.
Thank you, Dr. Vipul Agarwal.
Yeah, thank you very much. Good morning.
Can you see my presentation highlighted? Good morning.
Dr. Robert, it is visible. Yeah.
Okay, thank you very much. So I will just give you the full screen. Okay, I think it's better. Okay.
Dr. Garg, how much time more for the session?
So we'll be starting in about 4 minutes from now. We'll be starting at 11:30 dot.
On the same link?
Yes.
Okay, thank you.
Yes.
So Dr. Garg, the conference time shows as 11:30 to 1:30. So kindly excuse me, I would not be able to join beyond the quarter to 1. So I might have to leave in between. So quarter to 1, I'll have to leave this. I have another meeting lined up here.
Okay, no problem, sir.
Thank you very much. Thank you.
I know the importance of pandemic and others. You are
Dr. Robert, please stop your share screen.
Okay, I will stop it for a while. Okay, I did it.
Welcome, Rajdan Saab.
Welcome, sir.
Thank you. Dr. Vipul Agarwal is here. And Mr. Robert is here.
Yes, I'm here.
Greetings to both of you.
Greetings to you.
So within next 2 minutes, we will start, sir.
Good morning, Rajdan sir. Good morning.
Good morning. Good morning.
Good morning.
Good morning, Dr. Agarwal. Good morning, Mr. Robert. Dr. Robert, good morning.
Good morning. Yeah, good morning. It's nice to see you. Nice to hear you.
Namaskar, everyone.
Hello, namaskar.
So we'll be starting with the award ceremony in about 2 minutes from now.
No, first award. First is presentations. First presentation by Dr. Vipul Agarwal, because he has to leave early. And then all presentation will be over, then award.
Sure, sir.
And now you can start without taking any time.
Sure, sir. All right. Good morning, ladies and gentlemen, and welcome to the most awaited part of the conference, which is the EF Modern Healthcare Global Healthcare Awards Ceremony 2021. Before starting with the awards, I'll welcome Dr. Vipul Agarwal. I welcome Mr. Rajiv Nath and also Dr. Robert Skalik, who is joining us from Poland. I welcome Mr. Anil Rasdan, who has been a pillar of support for us throughout this journey. And before we move on to the awards, I'd welcome Dr. Vipul Agarwal, who is the Deputy Chief Executive Officer, National Health Authority, to say a few words and start with his presentation.
Yeah, thank you, madam. And first of all, thanks to World Healthcare Conference, Dr. Garg and his team for giving the National Health Authority an opportunity to share the thoughts and share an overview of what we are doing as Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which is the world's biggest public funded health assurance project. So I am Dr. Vipul Agarwal. I'm a police service officer from Gujarat cadre. I am working as Deputy Chief Executive Officer, overseeing the implementation and policy making in Ayushman Bharat Pradhan Mantri Jan Arogya Yojana as Deputy CEO of National Health Authority. National Health Authority is implementing two flagship schemes of Government of India. Both would in fact, Ayushman Bharat already is the world's biggest project, and we have started the world's biggest digital health project, that is the National Digital Health Mission, that is going to be the biggest in another 1 or 2 years. So that is something that we have recently started, and that's slowly and slightly developing. So please come to the next slide. Yeah, so I would divide my presentation into 6 subheads. Why did we go for Ayushman Bharat Pradhan Mantri scheme? Then the salient features, the models for implementation of the scheme, what role we are playing as National Health Authority as the nodal agency in implementation of the scheme, the achievement so far, and what we have planned as the way forward in the scheme. Next. So when we went for this scheme, we thought that India needs a scheme of this magnitude or this nature, because we are facing an epidemiological transition from communicable to the non-communicable diseases. And the disease burden, especially of NCDs, has increased to almost by 25% in the 25-year period from 90 to 26. And NCDs peculiarly require a long-term treatment, and this causes a lot of dent on the exchequer's pocket and on the pocket of the poor people especially, and leading to the people going below the poverty line. Approximately, as per 2011 purchasing power parity data, India's 22.5% of the population lives below $1.9 a day. That is really serious. We are also, when we conceived the scheme, we thought that there was a lack of any affordable health care for the poor citizens of the country, and the private sector in India, there's especially the tertiary care segment of treatment is skewed towards the private sector, and approximately 70% of the healthcare needs are being satisfied by the private sector, which is costly in nature, and poor people cannot afford it. So high out-of-pocket expenditure is leading to impoverishment of around 60 million Indians annually before the scheme started. Another thought when we looked about going for such a scheme was the portability aspect. So many of the states in the country are having their own schemes for the poor people of the states. But when the citizens go out, because the people go out to work in other states, states like UP, Bihar, we have people population going to states like Maharashtra or Gujarat for work, but the schemes, the local schemes don't work there. So we wanted us to have a scheme which has a portability feature, so any beneficiary can avail benefit in any of the nooks and corners of the country,
Okay.
be it any hospital. The beneficiary should be able to avail treatment. Next, please. So there are
Over.
two arms to the Ayushman Bharat scheme. One is the health and wellness center that takes care of the primary component of this scheme, and the second is the PMJY, which takes care of the secondary and tertiary healthcare segment. So as National Health Authority, we have been made responsible for the second arm implementation, whereas the Ministry of Health and Family Welfare is taking care of the primary healthcare segment. Next. So just in a nutshell, we launched the scheme on 23rd September 2018. As I mentioned, it is the largest public funded health assurance project. We are providing us health cover of 5 lakh rupees per household per year as per the 2011 socioeconomic caste census database. And this 5 lakh cover is available on a family floater basis, so that one family member or the family members clubbed together can avail the benefit in a calendar year. It covers secondary and tertiary care hospitalization, and the scheme is entitlement based. This means that the beneficiary database is frozen on 2011 socioeconomic caste census. So as and when we go for the next census, the database might get revised. So currently we are working on a database 540 million population. So 540 million beneficiaries are entitled to avail the benefit of the scheme. Next. So the portability I've already explained. There's no cap on the family size, age, or gender. So this scheme came as a byproduct of the Rashtriya Swasthya Bima (RSBY) that we had in the initial phase. So there was a cap of 5 members on the family. So what we used to see was that most of the treatment was availed by the male members because of the dominant nature of males in the Indian population. So we thought of having a scheme where there's no cap. So any number of members it may be, but they can avail benefit. You do not need to have no disease at the time of entitlement or enrollment in the scheme. So it covers the pre-existing diseases also. And we've already provided COVID-19 testing and treatment worth more than 2,000 crore rupees in the last 1 year that we launched the treatment packages. Next. So the implementation model, so we are implementing the scheme. Health is a state subject in India. So this scheme is being implemented with support of the state governments. So the state health agencies are our partners, and they in turn implement it through insurance or the state assurance model. So they have a set of insurance companies or the TPAs, third-party agencies, or implementation support agencies in case of the trust model. Over and above that, we for the district level implementation, we have district implementation units which provide the ultimately healthcare to the providers, that is the hospitals in public, private, and government of India field. Ultimately, the beneficiary is the final person for whom we are targeting the entire system. And we also have a hybrid mode of implementation, wherein a particular upper limit is fixed for insurance model, and beyond that the trust takes care. The implementation states are divided into two. One is the green field, and the other set of states is the brown field states. So the brownfield states are the ones where there was there was already an existing scheme when they joined the scheme of Ayushman Bharat, whereas the greenfield state were added. And when the greenfield state got into our scheme, they did not have any pre-existing insurance model in place. Next. So to avail the treatment, we need to register the beneficiary and identify and register him or her into the system. So there's a simple process of registration, and beyond that, so registration can take place either as the first point of care, that is at the level of hospital. The beneficiary does not need to carry any identity, any card. He just needs to have he does not need to carry his own e-card, that we call for availing treatment. The e-card can be generated in situ on site, and he just needs to have a personal and family ID to identify himself, and then he gets hospitalized, and the entire cashless and paperless process initiates, wherein the authorization request is sent and it is approved online. The treatment is initiated. Post discharge, the hospital is raising a claim online, and the claim is settled in a paperless manner online. So we are able to take care of all this within very short turnaround times that we have set for the scheme. So on an average, with a scheme of this magnitude, we are able to maintain a turnaround time on an average of 15 days in claim settlement. That can be called as extraordinary by any standards. Next, please. When we see how we are able to implement the scheme is through a very robust system, and the entire set of verticals that you can see on the screen. These are the supporting mechanisms through which we are implementing the scheme. At the center is the health policy and quality assurance wing that ensures that constantly we are able to update and revise the packages, health benefit packages, and there's a quality improvement in terms of the services that we are providing at the level of healthcare providers. There's a service provider engagement which constantly engages with the providers at the field level and ensures that their grievances, the issues that they're facing, are taken care on a real-time basis. We are also having one of the best IT infrastructure in any of the government projects in the country. So we have very senior, more than 300 IT professionals who are supporting us in that wing, and this IT infrastructure is the backbone of the entire system that we are operating. We have a very robust coordination wing which takes care of state, interagency and international cooperation. Constantly we are in touch with the stakeholders through IECs. Capacity building arm constantly improves and upgrades it is involved in training on constant basis. And we have a robust call center with around 1,000 odd call center operatives who support us in terms of real-time settling of grievances. So 14555 is our 24/7 call center number, and the call center operatives are spread over 4 cities. And grievance management system is entirely online. So we have a 3-stage grievance redressal machinery in place. Beyond that, we also have a robust monitoring and research division, and we have engaged the world's biggest, largest health data analytics company, that is SAS, to develop the fraud analytics software for us that generates real-time triggers, and I'll be dwelling upon that in the subsequent slides. Next, please. So as we can see, we at the core of the IT processes, we have 3 modules which are the core heart of our IT system. One is the beneficiary identification system. The second is the hospital empanelment module, and the hospital admission, treatment, and claim processing takes place on the transaction management system. So these are the 3 modules. And beyond that, as I mentioned, grievance, fraud control, monitoring, they are working on the top of this IT system and providing real-time support to our entire ecosystem. Next, please. We are providing treatment through health benefit package concept. So we also have a robust program of CGHS, Central Government Health Scheme, which takes care of the central government employees. Now, the central government health scheme works on a unbundled concept of treatment, so that if the patient, for the bed charges, they are counted separately at the time of claim settlement. The hospital doctor's visit is counted separately. The diagnostics are the separate head. Whereas in our case, our health benefit packages are on a bundling concept, which is an more advanced concept in terms of claim settlement and processes. So the entire cycle of activities, starting 3 days pre-hospitalization, up to 15 days post-hospitalization. Everything is covered. All inclusive packages are built up. So it includes the diagnostics, medicines, hospital charges, doctor visits, everything all inclusive. So it is very easy for the claim processing agent also, and at the same time for hospital also the compliance becomes very, very easy. So we are implementing through a set of around 1400 odd packages, and everything and anything under the sun is included in the packages except a minor set of exceptions, including a few transplant surgeries. So kidney transplant is already included, the rest of the transplants and normal delivery, few of the things we have not included, rest of the packages are all included. Apart from that, we are providing incentives also, as we can see on the bottom right side of the screen. Next, please. We launched a quality certification program, which because of COVID could not take much headway, but this program we launched later in 2019, and we are providing incentives based on the NABH accreditation status of the hospital. So 80 gold quality certificates and 92 silver certificates have been issued so far. Next. So regarding the monitoring, we have two major portals, IT portals and systems in place. One is the Insights that constantly gives us a dashboard view on the beneficiary identification operations, the performance of the states, the transaction management system. So it's a very state-of-the-art portal which works on Power BI, and we are giving policy inputs at the strategic level also. So in COVID times, we provided inputs to the topmost policymakers in the country for giving real-time, getting real-time information on the policy and how to plan ahead for taking care of the pandemic. We also have comprehensive dashboard in terms of impact for coordinating the activity of insurance agencies that are our partners. So any deviance, any frauds, any abnormal activity can be flagged, and wherever we are finding that there's scopes for improvement, we are giving constant inputs to the stakeholders, and we are trying hard to see that the performance improvement takes place. So this is proving to be very, very useful for our partners in terms of insurance agencies as well as the state governments, and improving the ground level implementation. Yeah. Next, please. Apart from this, fraud analytics is an important aspect. When we run a scheme of this magnitude, it is always important that real-time triggers and inputs are generated for the ground level staff to act on them and ensure that there's a deterrence in place, and there are strong provisions in place to ensure that people are not motivated or promoted to get into wrong activities. So we have two portals. One is Radar and other is Facts. So Radar is a portal which gives us information on the outlier activities. So if some hospital, for example, a hospital, 100-bedded hospital, which ought to do X number of cases on an average is doing 5X, outliers we are identifying, and we are generating triggers. We are auditing the cases of such hospitals, and we are pushing those cases to the states for taking action. Whereas Facts is a state-of-the-art multi-level information system that gives us insights into all the aspects right from the beneficiary identification up to discharge. So this is being handled by SAS, and this probably is one of its kind in the world. I think no other country would have developed a portal of this nature. And the triggers are state-of-the-art. They are AI/ML capable triggers. They keep on constantly evolving. And we implemented this in last February. I think we have our implementation capacities to tackle fraud has gone by at least 100x ever since we started this. Next, please. Apart from that, we have our own grievance redressal 3-step process in place that's end-to-end IT enabled, and which is paperless, and it works on a very stringent TAT turnaround times, and 24/7 helpline in terms of call center, our website, our app, all are giving inputs into this grievance system, and the grievance machinery at the district, state, and national level is taking care of real-time addressal of grievances. Next, please. So just a brief on the current status and where we stand now. We started conceptualizing about the scheme on 1st Feb. We were asked to initiate the scheme, and the scheme was launched on 23rd September. So we, in a period of 3 months, we entered into MOU with 5 states. The policies and guidelines and IT system were onboarded in a span of 3 months only. We ran the pilot on 15th August 2018. Initially, we rolled out the state in 22 the program in 22 states, and in the first 6 months, we generated 7.5 crore cards, and 10 crore e-cards were issued in September 19 itself. So pandemic has slowed the speed a bit, but still we are on target to achieve at least 50% of our card coverage by the end of this financial year. Next, please. So far, 15.56 crore cards, inclusive of 5 crore state cards that have been issued on the system. We have had 1.77 crore hospitalizations, which run into an amount of 22,000 crores rupees so far. The hospitals, almost 50% of our hospitals are private hospitals. 20,000 plus hospitals are empaneled under the scheme. It is one scheme of its nature where such a big chunk of our partners are private hospitals. In fact, private hospitals are providing treatment. Around 60% of the treatment provided is by private healthcare providers. That itself shows that there's a trust. Otherwise, a scheme would collapse. It is running since 2.5 years, and 60% of the treatment is being provided by the private healthcare providers, where there is no force. We cannot force them to act. It is only because the scheme has a very facilitative construct and positive spirit that we are seeing such a good participation. We also have handled around 70 lakh calls through our call center. Apart from that, portability cases, almost 2 lakh portability cases worth around 450 crores have been handled. A remarkable feature, and that might this thing appeal to the people who know about the Indian rural construct, that females are getting almost 50% participation in the scheme. So total treatment provided, almost 50% of it has been sought by the females. So that's a big achievement of this scheme. We've had 25 lakh mobile app downloads, and we are providing total care, which the general medicine and general surgery are the top 2 segments where the treatment has been imparted. Next. So the scheme utilization graph, as expected, we saw a very sharp decline in the initial part of the pandemic. Then the scheme utilization increased. We were almost about to reach the maximum in the scheme in terms of utilization just 15-20 days back, when again we have had this next wave of pandemic. So again, we are expecting that the scheme uptake might show a bit decline in the coming few days. Next, please. So the final aspect in my presentation about what we are thinking of in the days to come. So first thing is that one nation, one scheme. So the government is now slowly and steadily looking towards converging all the various schemes that we have for the various beneficiaries into one single scheme. So we are in consultation with various central government ministries so that their own beneficiary schemes can get converged into NHA IT platform. Almost 8 schemes are already getting converged. We are in very advanced stages. A scheme for employee state insurance corporation workers and Ministry of Health, Central Armed Police Forces have already been converged. Union Home Minister launched the scheme in January for CAPF officials. And as we can see, National Health Program, there is a lot of duplication in the health programs, also leading to a lot of loss to the exchequer in frauds and abuses. So this also is the target that once we converge, we'll have a single database to act on and a single IT system taking care of all the beneficiaries. Next, please. Another aspect that we are looking for is evolving cost-effective models for people who come in the missing middle class. So as Niti Aayog coined this term of missing middle, it is the middle 20% population of the country that is not so rich that it can take care of their out-of-pocket expenditure without causing a dent on their pockets. And it is not so poor that government needs to 100% reimburse the cost on their healthcare. So we are evolving cost-effective models. Let's say, for example, a scheme of a magnitude of PMJY for 5 lakh cover, a private insurance agency is charging somewhere around 25 to 30,000 rupees a year. So we want to make it to 1,500 to 2,000 rupees only for a middle class population. I think almost everybody would be comfortable spending that much. And we want to provide treatment to all the middle class population of the country so that in effect, we reach a universalization of healthcare for all. Next. So that's it from my side. Thank you so much again for giving us a chance to speak. I would like to congratulate and thank the organizers for organizing such a excellent forum seminar where we could present our thoughts before all. Thank you so much.
Thank you,
Thank
Dr. Wal, for excellently presenting. With the permission of chair, now I will request Rajiv Nath. Sir, if you want to ask some question, then Mr. Rajdan Saab.
I think that was a very precise and excellent presentation, Dr. Agarwal, and I think you've done us proud. The problem is the unorganized sector. How do we tackle them, and what is the methodology you have in mind? Because during the pandemic also, they seem to be the worst affected. The others who are more privileged like us, you see, we managed to group ourselves together for various essential benefits or schemes. But this unorganized sector, and particularly the lower middle class amongst them, I think they're all at sea.
Yeah, thank you, Mr. Rajdan, for this question. It's an excellent question. In fact, that is one thing I probably missed in my presentation also. One aspect which is going around on which we are working is how to expand the database to cover all the poor and needy in the country. So apart from the missing middle, for which we are coming out with pilots and doing studies, what we are doing is 40% of our poor population is already covered, but the problem with our database is that the database is frozen, and we might have missed out few needy people, as you said, in our unorganized sector, the people who might be needing the scheme benefits, but there is nothing currently available for them. So we are trying to push the case for a wider database. For example, a database like National Food Safety Act, so NFSA, that ration card holders. So I think most of the workers in unorganized sector are ration card holders. So why can't we have a ration card as the database to as the single source of truth for availing the benefit of such a scheme? So that thing is there in our minds. We are constantly in touch with various other ministry. For example, Ujjwala, the Ministry of Petroleum, is launching a scheme of Ujjwala for the poor and needy. So there are multiple schemes of social sector which are catering to different set of beneficiaries. We want to consolidate the beneficiary base and evolve a beneficiary base which can be called as real poor to avail the benefits of any government health scheme or any government social service scheme. So for that, in due course, I think something would come up, and we would come out with some better database on which all these people would be included, and there would not be even a single exclusion, and all poor and needy would be able to avail benefit of the social sector schemes of Government of India. Thank you.
Thank you.
Thank you.
Now, I request Rajiv Nath ji, who is Managing Director, Hindustan Syringes and Medical Devices Limited, Forum Coordinator, AIMED. So, Rajiv Nath ji, please.
Thank you, Dr. Garg, for kindly inviting me to represent the medical device industry at this August gathering and forum over here. And I also thank Dr. Vipul Agarwal for that excellent presentation and update on the great initiatives which have been path-breaking done by NPPA in the last few years. We look forward to hearing from Dr. Robert Skaig and Mr. Razdan as we proceed as fellow speakers. So this is going to be a presentation as to how the Indian medical device industry is impacting the global healthcare for COVID and beyond COVID. It'll be in three parts. So in the beginning, I'll be talking about quality for medical devices. Second part will be about the regulatory aspects and how other countries can also follow India in its search for regulations in the developing world. And the third part is as to how India has been ramping up capacities in trying to be self-reliant. And COVID has shown that other countries also need to follow similar strategies. So India is mainly 85% currently import dependent, with more than $5.5 billion import bill. But at the same time, we are very ambitious, and we do have a vision for India to be one of the top 5 manufacturing hubs in medical devices and repeat the story of IT and pharma. as a manufacturing hub. Now, when it comes down to regulations, this is a cultural issue. So you can see over here, this kind of chaotic traffic jams, because either there are no regulations, or when there are regulations, the regulations are not respected. And when regulations are not respected, then you will have a traffic jam. So this is a typical scenario which we are familiar with, whether we are visitors from overseas or we are Indians over here. And this chaos slows us down. Whereas if we understand what regulations is all about, we understand what our role is and what the other person's role is, and we all follow that in a self-disciplined manner, and we fulfill these clear expectations and responsibilities, then we allow each other to progress and we can all go fast. This is a slide which I've shown of Germany, which is quite different than what people may imagine in most Western countries or Japan. In case of a traffic jam on the right side, you'll find that the traffic immediately moves to the left and to the right side of the road and clears the center path for the police, the ambulance, and the crane, etc. vehicles to debottleneck the traffic jam. And this allows them to have no minimum speed limits in any of the autobahns over there. So if we appreciate what regulation is all about, we can actually free ourselves and go faster. So people think that regulations is bad. We in IMED do encourage responsible manufacturing and medical device manufacturing, and we think regulations are good. So the problem in India has been that there's been a traditional lack of trust of medical devices in the country. So people and doctors prefer imports, considering them to be of higher quality. And because of lack of regulations, we could not weed out the poor quality imports or the poor quality manufacturers. And buyers, especially in public healthcare, tend to rely upon third country regulatory certifications like US FDA or C certification to buy their products. And this kind of scenario has been confusing the manufacturers from investing, because nobody would like to make a building and find it has to be reconstructed or destroyed because it does not meet tomorrow's laws. So from IMED, we did realize that there was a need for voluntary certification. This need was also felt by the consumer organizations and by IMA and AHPI, whom we normally communicate with. And we decided that, yes, all of us jointly need to move something to create a voluntary quality standards. So what is quality all about? A manufacturer may have his own quality standard, which may be higher than anybody else's or the competitor's quality standards, because that is his vision of quality. When he has to measure it against the competition, he may do that using voluntary quality standards. Now, regulatory standards typically, because of political reasons, are bare minimum regulatory mandatory standards. Now, people find that tough to achieve. I find that very strange, because regulatory standards are bare minimum standards. There should be no question of finding it difficult to achieve that. Manufacturers in India and elsewhere need to strive to achieve much more higher quality than what the minimum standards prescribe. So in India, along with QO Quality Council of India, we had created the Indian certification for medical devices, which is in three categories: ICMED 9000, ICMED 13485, and the ICMED 1345 plus. The 9000 and 13485 are quality management system standards, and 1345 plus is going to be launched shortly, is going to be a product standard on the lines of CE marking. So people think ISO 13485 is enough, and we want to tell them, no, it is not enough, because it does not take care of risk management, it does not take care of essential principles for patient safety, and does not take care of many regulatory requirements which we have put into ICMED certification. So doctors in India and elsewhere, when you're looking for Indian medical devices and you want a quality supplier, if he doesn't have a US FDA or C certification, do ask for an ICMED certification. It can only come from an NABC graded certification body, so no question of fake certification, and you can have the trust that it meets patient safety needs. And the next steps that what we are looking for is that now that we have all the medical devices under the Drugs Act being regulated under the medical device rules, by August 2023, we are going through a 3-year voluntary registration period. Going forward, we are hoping for a new act, a draft of which Niti Aayog has tabled to the Prime Minister's office. So this is the new medical devices bill, which we're looking forward to, which will take care of patient safety issues, not discourage innovation, and also address the apprehensions of the consumers and to the doctors, and make sure of the patient safety needs without delaying the access of affordable products or making them too expensive to make. And also decriminalizing many issues of the Drugs Act, which discourages manufacturing of medical devices in the country. The next area I want to touch is regarding the ethics. So beyond quality certification, when we come to ethics in healthcare, what is ethics in healthcare all about? It's basically our moral compass. So what do people need to do in absence of a regulations, in absence of an act? What is the right conduct for a doctor? What is the right conduct for a manufacturer? What if something goes wrong? So how does a manufacturer, a hospital administrator, and a doctor decide what is fair and what is unfair? So this is his moral compass, which is important in ethics, because we are dealing in a noble profession of healthcare. So we have to address this ethical dilemma, that is it okay to compete by quality, by diluting quality, or by making quality barriers? Is it okay to compete by lowering pricing excessively so that it becomes non-remunerative and we are hurting quality? Is that ethical or not? Is it okay to compete by inducing hospitals and retailers to push your product by labeling them with a very high inflated retail price so that they are more happy to sell that particular brand because they make more trade margins in that? Is that ethical or not? And is it okay to have bundled sales so that the hospital is forced to buy not one product, but the whole range of products from a particular manufacturer? And is it okay for hospitals that if they get discount from manufacturers, that they pocket them and not pass them on to consumers? Because manufacturers have reduced the prices or given discounts for the benefit of the consumers. And is it okay for manufacturers to pay for doctors fully paid overseas trips in the garb of training and capacity building? Because finally it affects the product price and finally the consumers have to pay for that, and this distorts the system. So these are the ethical dilemmas which any manufacturer faces when he faces the competition. Other people are doing it, shall I do it or not? And the patient gets caught. The patient gets caught between a defunct public healthcare system, which NPPA kind of organization is trying to address, and a very expensive and unaffordable private healthcare. So the middle class is getting squeezed. The rich are able to afford the expensive hospitals, or they can go abroad, and the poor patients may be helped by NPPA, like Dr. Agarwal has explained to us, but where do the middle class go? So they get squeezed in over there because they may not have insurances. So we have to move not only about healthcare, but about human care. So what is the consumer's expectations and how do we address that? Do we permit them in hospitals to have a choice of brand? Or we should push the doctors what they want and what hospital wants, where they make more trade margins? And do the hospitals allow the patients to buy the brands from other chemist shops or other surgical dealers or other vendors so they can make it affordable for themselves? Why not permit that? It was being permitted earlier. And can we have a transparent system whereby patients get a discount over the MRP, because hospitals are big buyers. So they get a price which is much lower than the MRP. Can we have a transparent system that the hospital says that whatever the MRP on the product is, I will not charge you on that. I will give you a 30% flat discount on that. Can the government cap the trade margins with the help of the ethical doctors and the ethical hospitals and the ethical manufacturers? Let's have a system whereby there's a fair play. And can hospitals stop cross-subsidizing? Because that distorts costs. And when you distort costs, you are unable to pinpoint what the charges of the surgery should be. So I'm sure Dr. Agarwal is challenged by what should be a fair compensation in case of various kind of surgical interventions. And the doctors who were treated like gods in India, they are challenged because they need to earn the trust and respect back, which was earlier universally available to them. And now currently many of them do find it as being challenged and being tarnished. So let's get this back. So it's either about making ethical choices on a voluntary basis, or it's about regulations. Now, the third part I want to touch is where IMED and IMED's members, as responsible manufacturers, have come forward, and other Indian entrepreneurs have come forward in this pandemic to make India self-sufficient and not only help India, but to help the world. So pre-COVID, for example, the biggest cry which came forward was access to high quality PPE kits and coveralls. There were only 20 manufacturers in India listed with IMED before COVID. And after COVID, we got more than 150 manufacturers. And the capacity has gone up from 6 million pieces, the sky blue at the bottom, to more than 256 million pieces per annum. So on today's date, we got surpluses for the country and can export to the world and help the world. Similarly, for ventilators, we had only 8 manufacturers making hardly 3,500 ventilators per year. And within 4 months' time, the capacity went up to more than 17 manufacturers to make more than 400,000 ventilators per year. And even more can be achieved. And now that they've achieved that, they can diversify to other medical electronics. So again, that is available for the world and the global healthcare. Surgical masks. India was, for a simple product like this, India was highly import dependent. So when the COVID came and imports were restricted, it was a big challenge to come forward. So from 25 factories, 75 factories came forward in 3 months' time. And from hardly 300 million pieces per annum capacity, we went up by more than 10 times to more than 3 billion capacity by July last year. Similarly was the case of more stringent quality, the N95 masks. There were hardly 5 factories in the country and making mainly for the pollution control and the chemical industry this kind of product. It was not being used mainly in the medical line. So from 5 manufacturers, we went up to 37 manufacturers, and from 13 million pieces per annum, we went up to nearly 800 to now nearly 1 billion pieces per annum. So not only enough for India, but for the world. In test kits, this was a new disease, so testing was not available. There were 0 manufacturers, but we had many manufacturers who had capacities and capabilities. So 8 of them came forward, and on today's date, we have a capacity to make 1.5 billion RT-PCR test kits per annum. The VTM tubes to catch the samples and the swabs was again a challenge. And from 0 manufacturing, we went up to 10 manufacturers making nearly 4 billion VTM tubes per annum. In swabs, from 0, we went up to 5 and nearly to 400 million pieces per annum. So when there's good coordination between the government, between the entrepreneurs and the investors, we can see mountains can be moved in a short while. So we should not lose the impetus, and we should keep on working in collaboration with the global community, the Indian medical community, the Indian government, WHO, and other resources. So in various categories, we've got 7 verticals in IMED: disposables, consumables, electronics equipments, and we got implants, diagnostic and instruments. And for each of them, now we've got global players in India who can feed high quality technology products, whether to USA or to Europe or to South America or to India or to the Middle East. These are respected names in the presentation. Because of paucity of time, I will not read out the details to you, but I will share the presentation with Dr. Anil so he can share it with the rest of the forum over here. The biggest now challenge for all of us is vaccines. In vaccines, again, India has shown that we are leading in the world in providing low cost, affordable access to vaccines and in very high volumes. And not only to be the pharmacy of the world, for vaccine delivery, you require drug delivery. And here my own company has ramped up capacity from making 500 million auto-disable syringes for vaccination. Currently, we are making 900 million per annum capacity within less than a year's time. And we'll be making a billion by June and 1.2 billion by September this year. Our overall capacity has gone up from 2.5 billion syringes per annum, which will go up to nearly 3.5 billion syringes per annum by September this year. So we are all rolled up our sleeves, and we are working very sincerely and eagerly to fight COVID as a team member over here. So in India, what has been our Make in India achievements? So this is something for the developing world to learn from India. What was required was that for technology, that you needed to have an interface between the academic institutions, the R&D departments, and the medical profession, the engineering colleges, and the industry. And this sort of ecosystem has been created now very well in India with BioValley, MediValley, IKP, CCamp, Venture Center in Pune, etc., which allows developers and entrepreneurs to make these innovative medical devices to meet the doctors' ever-changing requirements and wish lists. So any doctor over here wants to have a variation or any problem statement in what he's using, he can come to IMED, give his problem statement. We will share that with our young startups and developers, and then they can discuss with the various R&D centers and supporting innovation centers and try to come up with solutions to meet your challenges. You wanted patient safety, so medical device rules were framed. Patients wanted affordable access, so price caps was put on stents and knee implants, and manufacturers in India supported that kind of regulation because we did realize that patients should not be taken for a ride. There should be something which should be profit-making but not profiteering. MedTech parks have been created in Visakhapatnam and Hyderabad, and more will come forward in other parts of the country, which be specialized in different technologies. And then hospitals and medical professionals needed biomedical skilled engineers and technicians for maintenance and upkeep of the equipment and for selling them. And for that, a biomedical skill development consortium was created, which certifies and builds competency now. So we've created an ecosystem for having an investment for $10 billion investment opportunity in the country. I'm sure something similar is there, whether it is Poland, whether it is Dubai, or whether it is Brazil, where each country now wants to be having some sort of self-reliant. We do need to import, all of us, but we also need to have certain basic products being made available in the country. COVID has shown that. So while we've taken measures for the Drug Act to be changed to the Medical Device Act, like I just explained to you, other factors which India has done recently has been by having a public procurement order to encourage public procurement for Indian-made goods, to encourage domestic manufacturing, a production-linked incentive scheme. So what was not being made in the country, high-end, 4 categories of equipments to be made in the country, a good scheme that came out, a phased manufacturing plan for products like X-ray machines who were importing components and sensors to make those components and sensors in the country, and the medtech parks like I explained to you. So thank you for listening in, and you're very welcome, any of you, to reach out to us, and through us reach out to the manufacturers in the country. I look forward to receiving any of your queries and questions. Thank you all for your patience, and I hope I did not overrun my time. Thank you.
Thank you, Rajiv, for excellent, comprehensive presentation. Now I will straightforward look to have presentation from Robert, Dr. Robert from Poland.
Okay, show the presentation, please. Highlight it. I hope you can see my presentation.
Yes, we can see your presentation.
Yes, it's okay. Can you see my presentation? Okay, thank you. At first, I would like to kindly thank you for the invitation. It's by the speech of the previous speakers, really impressed about the project of digitalization of healthcare system in India. This is unbelievable what you are doing, really. You can be really proud of your country because, you know, Poland is only 37 million people. And we have the same, maybe not the size problem like in India with healthcare system, but also we are short-staffed, under-resourced and stuff like this, even though we are the 6th strongest economy in the European Union. So for me, this is really great story. So for this reason, I decided to prepare my short presentation on the perspectives for implementation of digital health technologies for reducing the global burden in cardiovascular diseases. Okay. I believe that the digital health technologies may change the image of today medicine, both in the richest and the poorest countries across the globe. I believe that cardiovascular diseases should be the first target because, as we know from the global statistics presented by the World Health Organization, for example, the cardiovascular diseases are anyway, together with the cancer, the most significant problem for the world population. For this reason, I can see great opportunity and great platform for creating a really modern, not expensive, affordable system to control the morbidity, mortality of cardiovascular diseases and contain these, also we can call it pandemic. We have a pandemic of COVID, but we should not forget about the other pandemic of cardiovascular diseases. And what are the targets, in my opinion, for the digital health technologies as concerns the containment of the cardiovascular burden? In my opinion, it's of course quite complex story about the technology, coordination, orchestration of all the elements of the system, but we should focus on 4 main targets, very simple to control and analyze by remote screening models. This is the problem of arterial hypertension, diabetes, hyperlipidemia, and overweight. In fact, these 4 determinants contribute to the global morbidity and mortality within the cardiovascular system problems. Why blood pressure? Blood pressure is responsible for the most frequent cause of the cardiovascular diseases. Dysfunction, I mean, of course, the abnormal value of uncontrolled blood pressure. This is the heart failure. What about the others? Diseases that might be induced by the unnormalized, uncontrolled blood pressure is aortic aneurysm, arrhythmia, brain stroke, and heart attack. Blood glucose level, diabetes. So diabetes is the main cause. I would call it the insidious killer, because in many patients do not have with a high blood glucose level, do not present any symptoms for many years, and they suddenly die from heart attack, or they have myocardial infarction with severe heart damage, which must be treated with very sophisticated and expensive treatment methods. And lipids, of course, and uric acid. This is the last story that might be effectively controlled remotely without special assistance of doctors on the regular basis. So what kind of technologies we could apply in the effective remote screening models of people with cardiovascular risk factors or people who suffer from cardiovascular diseases? So here we have some definitions certainly known to all of you, especially to guys responsible in India for implementation of this remote screening model. This is the Internet of Things, artificial intelligence, machine learning, and robust data mining. I'm not going to go through this definition because you certainly know what is it all about. But this methodology, these items certainly will help us to create new dimension of medicine in the future, which will not only make the life of the people more comfortable, but certainly reduce the costs of treatment all over the world. Now, some short, maybe just to make put everything in order, I will just start from the Internet of Things, going to Internet of medical things, and some case reports about how these implements, how these tools might be effectively used for the remote screening of patients with cardiovascular risk factors of cardiovascular diseases. What is the Internet of Things? Yes, this is not a new idea, but also not very old. Internet of Things is the idea from IT technologies. At the beginning, it had nothing to do with medicine, yes? The definition of Internet of Things, it's the platform that is allowing to connect devices over the internet, let them talk to each other, exchange information, and also in this way, this kind of Internet of Things platform should help us to live better and create a brand new model of life which will be more friendly to the environment, more friendly to the people, and more friendly to the governments, just as concerns the expenditures on various fields of industries. And these devices, which many of them are, there's the household devices, first of all, are to help people just to use less energy, make their life more comfortable, just allow us to save money on the heating system, especially maybe it does not concern India, but in Poland, we have very severe temperature differences throughout the year. For example, nowadays it's 15 Celsius grades in my city, Wrocław in Poland, but 2 months ago it was minus 20 Celsius grades. Yes, so we have quite high cost of heating of our houses. So all these things related to the Internet of Things just were just created to improve our economies. So what does, you may ask the question, what does it have to do with Internet of Medical, what the Internet of Medical, what the Internet of Things might have to do with medicine? It does a lot. So we can talk about nowadays Internet of Medical Things platforms. As you know, we have a whole variety of sensors which are used in, you can say, chaotic manner by regular people. They measure the blood pressure, they have glucometers, thermometers, pill bottles which dispense the drugs they use, and they use weighing machines and other stuff like this, which is fixed to sometimes the smartwatches, to smartphones, or just these are independent entities. But at this moment, all the information gathered from these machineries is not synchronized, is not analyzed by any outside application, any outside platform. It's not screened by doctors. There's no system except for that you are going to create probably in this world on such an unheard of scale. What are the drivers for development of remote screening platforms to control the cardiovascular diseases and chronic diseases? Because cardiovascular diseases, these are a group of acute diseases, but also chronic diseases. So first of all, people in today's world live longer, evidently, especially in well-developed countries. People are richer and richer, and they want to have appropriate comfort of life. Besides time to have an appointment with a doctor, but they want to be screened, yes. There is the first driver for the first target. There's a first driver to develop the system, and these people are a perfect target for remote controlling. But the most important thing is that we have more and more people who suffer from chronic disease. This is not only cardiovascular disease themselves, but also the others, diabetes, hypertension itself, without any complications with the heart, and also chronic pulmonary obstructive disease. And these diseases produce enormous costs for the societies, for the governments. And what is more, almost all systems, medical systems in the world are nowadays underfunded or under-resourced. We don't have too many doctors. We don't have too many nurses. So it produces enormous queues for the visit to the doctor, especially, for example, in Poland, if you want to have appointment through the public healthcare system with cardiologists, you have to wait half a year. So it does not make sense. But in my opinion, many of these patients who are just seen by the doctors, for example, cardiologists, might be effectively screened by the remote systems assisted by IT experts and sometimes with the consultation of a doctor. In this way, we could effectively shorten the queues, and these people who really need really fast care, who must be managed by specialists, could get helped. And in this way, we would not lose these people. Many of them are very active. They are not old people. The cardiovascular diseases are no longer diseases of very old people. Young people start suffering from these diseases all over the world. Young people have myocardial infarctions. Young people have brain strokes. And if these people could get effective preventive measures, preventive system to screen aforementioned parameters, we might reduce the burden, not only from the social point of view, but also it will be very important for the governments to save money and reallocate the money they saved for other targets, or just boost these fields of medicine, which are extremely cost consuming. So this is the slide. I mentioned the story just before, but I will show you this. So the cost reduction is another very important driver for the growth of the remote digital screening models in healthcare systems. Also, lack of doctors, nurses, and I believe that will not change too much. It's very difficult to educate doctor and nurse to be professionals. It's not only the question of graduating from the school or the university. It's about next 5 up to 10 years to be really well qualified. So many of these patients who go to the doctor remotely, in order that the high level top specialists could take care of these people who really need it. And this way we would both improve on the comfort of life of the people, and also we would alleviate the expenditures of the government. And here I just want to show you a very simple diagram, the scheme of the system of remote screening that I and my colleagues a couple of years ago contrived, colleagues, computer scientists, and me as doctor, how we could effectively control the people's health as concerns the cardiovascular diseases, also others, and all just to screen in order to reduce the rehospitalization and hospital admission rates. So here we have some elements, very simple elements of the system. So we have the home, so this is where the people live. So we have the sensor, there's wearables, which measure various parameters like weight. We have the weighing machine, we have the ECG. There are many manufacturers all over the world who offer just apparatuses, wearable apparatuses to control not only heart rate, but also ECG tracings. We have the blood pressure meter. We may have the glucose meter. We may have also a pill bottle dispenser as a sensor, which is fixed to the remote controlling, remote screening platform. And all these appliances, all these devices are integrated, as I said before the moment, with the platform, which is located probably in a hospital or outpatient clinic. If it concerns the patients who suffer from some cardiovascular diseases, for example, they suffer from arterial hypertension, from chronic heart failure, or they are after cardiac surgery, and also, it may be only controlled at the very beginning by the computer scientists and artificial intelligence. If we talk about the patient who do not suffer from any diseases, they want only to be screened and watched by someone to detect any abnormalities on time to avoid serious cardiovascular consequences. And owing to this integration of the data collected by the sensors remotely, the platform based upon artificial intelligence, robust data mining, and other techniques just used by computer scientists, we may get fantastic charts, reports about basic life parameters, which like blood pressure, glucose level, lipids, and others, which in fact allow us to control the system, control the disease, and prevent the development of the serious consequences of cardiovascular diseases. Here you get such an example of the platform, which the patients are coupled with. Yes, the patients may have all kind of devices which monitor various parameters. This is, as I said previously, the blood pressure meter, weighing machine, glucose meter, also pulse oximetry, which is especially important at this moment with the COVID pandemic. As we know, we may have a patient with COVID infection who suffer from hypoxemia, so low concentration of oxygen without any other symptoms. But these people, even if they don't have any symptoms, but they have a poor concentration of oxygen in the bloodstream, they need to be hospitalized because they are at high risk of death. Also, we have thermometer. Also, we may have mobility analyzer, so how much we move, how much exercise we take a week, for example. And also, we may have a pill bottle, sorry, that will just facilitate patients to have a right dosage of the drug he takes, for example, for heart failure or for the arterial hypertension. And all this platform would be coordinated by the doctors and also IT experts, hospitals, decision makers, individual patient who would just get the feedback, automatic feedback from the platform, just with the report generated by the artificial intelligence. If any alarming graphs would appear in this report, that might be automatically, the doctor might be automatically informed about some abnormalities in the report and could make analysis in the context of the symptoms of the patient remotely. And if necessary, have a remote teleconsultation, and then if necessary, the patient might have appointment with the doctor. So before the patient would see the doctor, it would be still big space, yes? So a lot of time would be saved for the doctor. He could, before he see this doctor, this patient, he could manage many other patients who really need his help. And of course, if necessary, the patient who is screened remotely, if there are any abnormalities in the basic parameters, and if some symptoms came up, then of course the visit might be mandatory. But owing to the system, we make really huge, much more effective the system we have nowadays. And this is example of a machinery. This is the blood pressure meter, which might be used just for building such a platform of remote controlling. This is not a regular blood pressure meter. This is a very specific blood pressure meter. When the patient makes measurement, he pushes the start button, the measurement is done, and at this moment when the digits, the result is the outcome is highlighted on the screen of the machinery at the same moment, without any accessory intervention by the patients. The data would be transferred through the special gateway on the right. You can see the gateway, special gateway to the remote platform, which might be located thousands of kilometers away from the place of living of these patients. Yes. What is the gateway? It's a kind of a plug that is plugged into the socket in the wall of the house. So the patient is walking around the house, is doing something, and he making measurements. He may measure this way the glucose level, blood pressure, and or make the spirometry evaluate his lung functions. All these parameters would be streamlined and sent to the central portal where the artificial intelligence would perform the selection, aggregation, and analysis of this parameter in the clinical context. Also, patient may take this appliance outside when he goes to work. He is a businessman. He's also a doctor. He works in a factory. He's a director engineer. If he, of course, works in the closed space in a building, then he may plug this appliance, this hub, this gateway to the socket in the wall of the house, of the office building. And from time to time, measure his parameters if necessary, if recommended by the system, by artificial intelligence, and the doctor, how often he has to do it, not disturbing his work, not seeing the doctor. And this is a picture which summarizes what I said. So we have many data, medical data, blood pressure, heart rate, ECG, glucose level, lipids, and so forth. These data would be sent to the platform, central platform controlled by the IT experts and artificial intelligence system. Of course, the contextual data will be also gathered. What I mean to the contextual data, you know, for example, the symptoms the patient presents, and the climate in he is at nowadays, the temperature outside, the pressure, air pressure, and other parameters that might also affect his life and health condition. All these data are analyzed by the artificial intelligence Also, if necessary, by the nurse or doctor expert who would take a look at the results, if it's necessary, if some abnormal values would be highlighted. And then the decision would be made what to do with the patient, to make an appointment for him with the doctor in a hospital, outpatient clinic, or it's enough to change the, for example, the dosage of the pills for the blood, for the arterial hypertension remotely at home, not just disturbing the workflow of the doctors in the hospital of outpatient clinics, who are usually very busy. And also this model might be very useful for science and for decision makers, because we would get a lot of data, robust volume of data, which would be automatically analyzed, which present the graph statistics. And these statistics might be used not only by doctors, but decision makers in the governments to change the policy of the healthcare systems, to modify the policy and relocate the financial resources to these environments which really needed in a given moment after analyzing the data delivered by the artificial intelligence. And also, this is very good for universities, for our education, and creating new models of treatment. This is excellent for pharmaceutical companies that would have access to the data to evaluate the impact of the new treatment methods, new drugs on the health status of big group of people, not just encouraging them to come to any facility for examination. They would just do it automatically, yes? Just would take a second or minutes to measure blood pressure, glucose level, and send it to the central portal for analysis. And this is, I would say, multi-dimensional project, which will not only affect the quality of life of people, but also the government's expenditures, the progress in medical sciences, and also the reallocation, effective reallocation of the financial resources by the governments. And one use case, I don't want to just take too much time, one simple showcase how it could work in the practice. This is virtual patient, yes? Patient who has, he does not suffer from any disease. He's 50 years old, he's male, but for some time he suffers from headaches and palpitations. So what to do? So he goes to the doctor, and doctor makes the physical examination, auscultates his heart, his vessels, his lungs, talking to him. And at this moment, he finds nothing. Yes, blood pressure is normal. Nothing happens. Heart rate is normal. ECG is normal. But at this moment, yes, but maybe 10 hours later or in 2 weeks' time, he will have some problems. So normally what the Okay, can you hear me? Because I got disconnected probably.
Yes, we can hear you.
Okay, I'm sorry. Just I'm finishing. I hope you. So just I will make a share screen. Sorry for that. So I hope you see again my presentation. Normally GP sends this patient to cardiologist. In Poland, the patient has two options: either to wait in a queue for a couple of months, or just to pay for the visit from his pocket. Of course, there are also some queues to the private doctors. And by this time, what might happen? A lot of bad things. He may have a stroke because in fact he has hypertension, or he has arrhythmia that may also cause the brain stroke. He may also have heart attack. And at this moment, the costs of servicing this patient will be enormous. Treatment of the myocardial infarction, of brain stroke, goes to thousands of euro, thousands of dollars. But with owing to this system of remote screening, for example, recommended by the GP in this moment, this system which allows the patient monitor his blood pressure, heart rate, ECG, glucose level remotely, and send off the data automatically to the central platform with which the doctor, computer scientist, nurse may have access to. We may get nice overview of his parameters within the next couple of weeks, not in half a year, but maybe within next week, within 2 weeks, 3 weeks. And we may, owing to this information, we can take the intervention much earlier, even remotely sometimes. The doctor, as we do it sometimes in Poland, without the system, we try to do it. We doing the so-called e-consultation. Patients is administered the drug, and everything's coming back to normal. Maybe we saved his life, maybe we prevented the brain stroke or other serious cardiovascular problems because he was remotely controlled, because he got the drugs on time without necessity to wait for the visit to specialist for a couple of months. And sorry. And pre-last slide, summarizing what I said. What is the yield from the digital health technologies? So first of all, we can create relatively cheap, affordable, and well-coordinated remote medical care system assisted by doctors, IT experts, and nurses. We can obtain effective screening of fundamental risk factors for cardiovascular morbidity and mortality. Owing to that, we can prevent many complications, cardiovascular complications, and reduce the financial burden for the governments. Also, we may effectively monitor patients who suffer at this moment from cardiovascular diseases, who are after brain stroke, who suffer from chronic heart failure. In this way, we can mitigate further complication of the diseases. We can reduce the hospital readmission rate, and also this way improve the comfort of life of these patients, and also reduce the cost for the hospitals. And completely new dimension, this is the new way of scientific insight into big population data, which will allow the scientists, cardiovascular scientists and other scientists and governments, decision makers to create a brand new model of treatment, diagnostic, and also this is a great opportunity for pharmaceutical companies to get access to huge data, which allow them to produce new drugs, new models of drugs, and also test new model of drugs on big population, reducing the cost of this test, which is also very important. And at the end, some photos from my city, where I live in the southwest of Poland. It's about 100 kilometers from the border with Germany. We are in the European Union. We are the 6th strongest economy in the European Union at this moment. My city, Wrocław, is one of the Indian culture. I'm very interested in Indian culture. I have great respect for your achievement in science, in culture. Your cultural diversity is really impressive. My city is 1,000 years old, and with many old buildings, historical buildings, and it has the great contribution to medicine. Many famous doctors lived and worked here throughout last 100 years. For example, Alzheimer disease, everyone knows what is Alzheimer disease. Alzheimer was living in my city, and he discovered this disease in this city. So thank you very much for letting me give you this lecture. It was a great pleasure and honor for me to be with you today. Thank you.
Thank you, Dr. Robert, for excellent presentation. And now we will go to Aishwarya for announcing the World Global Healthcare Award 2021 in modern healthcare.
Thank you so much. Thank you so much, Dr. Garg, for that. And as Mr. Garg pointed out, it is the time, the most awaited ceremony, and that is the EEF Modern Healthcare Global Healthcare Awards 2021. Now, the EEF Global Awards are annual awards. They were introduced by the Energy and Environment Foundation to recognize and honor outstanding organizations that are taking responsibility for defining a commercial future by adding value through excellence in healthcare, innovation, and technology in a disciplined manner. The Global Healthcare Awards encourage and motivate to adopt best practices and become role models for others to emulate, encourage implementation of strategies for improvement in operation standards, create harmony between industry and the environment. So let me announce the EEF Modern Healthcare Global Healthcare Awards 2021 that are being awarded to selected organizations by the eminent jury. Now the winner of the EEF Global Healthcare Operational Excellence Company of the Year 2021, and the award goes to Aurobindo Pharma Limited. And we have with us Mr. Suresh Raman, Vice President, Corporate Engineering with us, who is joining us. Congratulations, sir, on winning the award.
Thank you, Aishwarya.
Yeah.
Yeah, Aurobindo Pharma Limited, thankful to EF Global for awarding us the Operation Excellence Company of the Year. We emerged as a top 2 pharmaceutical in India with a revenue of $2.8 billion and exposed to over 150 countries across the globe. Overall, the employee strength of 26,000 all facilities in India. Since inception, Aurobindo is working for continual improvement in its operations by setting appropriate objectives, targets, and KPI. As an energy efficiency, we have a path adopting latest energy efficiency technologies. We standardized to stores premium energy efficient equipment, and so far conducted various assessments on utilities, boilers, steam systems. So 557 initiatives we have identified that equivalent savings of 524.6 Indian rupees millions. So during the financial year 20, the company accrued the electricity savings of 20.9 million units, cost savings of coal savings of 4,996 metric tons of coal. This arose to bring down our 26,467 tons of CO2 emissions into the environment. Apart from that, on the engineering excellence, we brought Internet of Things in utility systems, inventory control through ABC analysis, and harmonization of our standard operating systems of the equipment and process, which brought down the engineering expenses down by 245 million, which is equivalent to 10% of the engineering expenses for a year. So we have taken care of the environment and safety, where we have gone with the double stage process for the process and membrane bioreactors of the effluent treatment. Thank you very much for that, giving an opportunity to be part of this assessment.
Thank you so much, sir.
Our chairman, Mr. Anil Razdan, is here, and he is happy that energy efficiency and environment concern is taken care by Aurobindo Pharma. So I will request Mr. Anil Razdan to congratulate Aurobindo Pharma.
Well, my heartiest congratulations to Aurobindo Pharma. I think they've not only done a great job for medical health care in this critical time, but have also done resource efficiency and energy efficiency, which all contribute to a greater global cause of environmental protection. And I think this meets the objectives of the Energy and Environment Foundation. Good luck to you, and kindly publicize your achievements so that others can follow in your trail. Thank you very much for calling me here, and congratulations once again.
Thank you, sir. We'll do it, sir.
All right, now let me also announce the EF Global Healthcare Operational Excellence Company of the Year. And the award for 2021 is also being bestowed upon Apollo Hospitals Group. And we have with us Mr. Gaurav Loria, Chief Quality Officer and VP Operations. So congratulations, Mr. Loria. And would you like to say a few words?
Good afternoon, everyone. Mr. Gaurav Loria could not attend, so I'm Yogmaya attending on behalf of Mr. Gaurav Loria. So on behalf of Apollo Hospital, I would like to mention that we are extremely honored to be receiving this award. I'm honestly grateful for the recognition of our effort in operational excellence. Thank you very much, Global Healthcare Award 2021. Thank you.
Indeed, very, very congratulations. Indeed, achievement, it is said, is connected with action, and successful men and women keep moving. They make mistakes, but they never quit. And that is what these awards are meant for, to give recognition to those people, to those organizations who have kept moving despite making mistakes, but they have moved and they have excelled in their respective fields. So let me now announce the EEF Global Healthcare Innovation Institution of the Year 2021. And the award is being bestowed upon Kyushu University Hospital. And we have with us Professor Naoki Nakashima, Director and Professor, Medical Information, joining us from Kyushu University. Congratulations, Professor Nakashima. Professor Nakashima. All right, we also have with us Professor Ashir Ahmad, Associate Professor, Global Health Team. Do we have Professor Ahmad with us?
Yes, I'm available. Thank you. Sorry, Professor Nakashima is not available. Can you hear me?
Yes, we can.
Okay, thank you. Actually, we have Professor Rafiqul Islam as well. Is Rafiqul Islam there? Okay, if not, then, okay, thank you very much. I'd like to thank the committee for selecting and recognizing our effort. Actually, Kyushu University Hospital and Kyushu University other departments worked with Grameen family of organizations in Bangladesh, and we developed a portable health clinic to reach the unreached communities in Bangladesh. So we targeted rurality, poverty, and disability to three major burdens of the society. And we are honored that we could reach a lot of unreached community and receive so many thanks. And this award, of course, will be a very good recognition for all of us. And I would like to thank our colleagues in Kyushu University and also colleagues in Grameen Communications for working hard, and also our sponsors in Japanese industries as well. Thank you very much.
Congratulations, Professor Ahmad. And in fact, Dr. Rafiqul Islam Maroof, Associate Professor, Medical Information Center, is also joining us. Congratulations, Dr. Maroof.
Thank you very much. And I would like to convey my sincere thanks and gratitude to the World Health Conference and Organization and the judges panel for considering our contribution for this award on behalf of Kyushu University Hospital. And this is a great honor for us. And we have developed, as Professor Rashid mentioned, we have developed this system to reach the healthcare service to the unreached communities. And we have found that this system is very effective in the last 10 years. And we have extended this operation, this service in 10 countries. And I feel that there are a lot of opportunity to improve it further. And today's recognition gives us more responsibility to continue these activities. And we would love to extend these activities to other parts of the world. So if there is any person who is interested in this program, we will be happy and welcome them to work together. So thank you very much for this recognition. Thank you.
Thank you so much, and very many congratulations, sir. And let me next announce the
You are muted, Sharia.
Yeah, sorry, I'm sorry. So let me next announce the EEF Global Healthcare Nutrition Excellence Institution of the Year 2021. And the award is being given to Medical Institute of Continuing Lifelong Education, the Moscow State University of Food Production, Ministry of Science and Higher Education. And we have with us two professors from the university joining us. We have with us Professor Mihail Balyev, President, the Moscow State University of Food Production. Professor Mihail, congratulations.
Hello, my dear friends. If you don't mind, I would talk in Russian and then several words in English. Дорогие коллеги, я исключительно рад вас поприветствовать от всей нашей страны, от Российской Федерации. Для нас это большая честь, для всего российского образования и прежде всего для университета пищевых производств получить такую большую награду. Мы университет с 90-летней историей, работаем по направлениям ветеринарии, ветеринарной экспертизы, большого блока технологий, биоэкологии. Но и самое главное, то, за что мы получили сегодня, из ваших рук получаем большую награду в области здоровья и сбережения, медицины, фармы. Для нас это серьезный стимул для дальнейшей работы, для подготовки специалистов высшей квалификации, реализации научных исследований. Ну и, безусловно, это очень серьезный доступ для нас на международные рынки. И хочу сказать, что мы по праву являемся одним из крупных и наиболее известных университетов инженерного направления в нашей стране. И вот сегодня мы получаем награду от вас, а вчера мы вошли в топ-70 лучших университетов страны в области инженерного образования из 1000 входящих в общий контур наших высших учебных заведений. And several words in English. Thank you very much. It's a great honor for us to get such an award. We're biggest university in engineering and technology of food production in Russia. We are about 90 years old. This year we have a 90 years anniversary in Russia, and we have a lot of experience in technology, bioecology, biotechnology, food production. And of course, medicine. Your award is very big pleasure for us. It's a new market in Europe and all over the world. So I would like to tell you that we are very big partners for you. We have a lot of R&D centers in our university, not only in medicine and pharma, but in bioecology, food production, veterinary, and special technology and engineering directions. So I would like to say you that we want to work together in the future, and thank you very much for such a word. It's a very big honor for us and great pleasure to be with you. Thank you.
Mr. Chairman.
Yes, sir.
These 3 universities in Moscow, they are working together for a digital cause in healthcare, and they work together, and you can understand Russian, so I will request you to say a few words about their excellence.
Thank you very much. Yeah.
Thank you. Congratulations. I'm really pleased that these Russian institutes have bagged this award. You have a great tradition in medical science, which to the rest of the world is a little unknown because of a language barrier. But I think your medical research, as well as the health of your nation, through a system which was one of the strongest systems at that point of time, has ensured universal health care and universal health for your citizenry, which I think is a very great lesson for all developing countries to come forward. You have combined the results of your highest institutes of learning, which were situated in the western part of your great country, and have spread them almost uniformly across your entire great nation and earlier the republics of the Soviet Union. Thank you very much for your participation and many congratulations for.
Thank you very much, dear professors, dear friends. We'll work together.
Professor Victor Glado. He's the Director of Medical Institute of Continuing Lifelong Education, the Moscow State University of Food Production. And he's also joining us. Do we have Professor Victor with us? Congratulations, sir, on winning the award.
Next.
All right. Next, let me announce the EF Global Healthcare Entrepreneurs of the Year 2021. And the award is being given to Blisson. And we have with us the CEO of the company, Mr. Tushar Patil, joining us. Congratulations, Mr. Tushar, on winning the award.
Thank you very much. At the outset, I would like to thank the jury and the organizers for presenting this prestigious award. At Blisson, we believe in value-added quality products for the patients. Our strong team and our well-wishers, that is our customers. Blisson, basically, I would like to congratulate to our product development team. We have come up with value-added therapies as per the need of the therapy and the segment. Congratulations to our passionate sales team and marketing team who have put their best efforts in spite of pandemic challenges. And most importantly, a big thanks to our customers, doctors who have believed on us in spite of young company, and they believed on our products and our team efforts during this last 1.5 years of these challenges. Therefore, I once again thanks to jury and the organizers for recognizing us with this prestigious award. Thank you very much.
Chairman, sir, would you like to say a few words?
Yes, congratulations to you for the Blisson's achievement. And we only hope that success stories like yours are put across on the electronic media, if not in the print media, for people to learn and grow. My congratulations to you. Thank you very much.
Thank you. Thank you very much, sir. And we'll follow your guidance and we'll try to excel from onwards. In
success stories must be shared.
Yes, sir. Sure. Sir. Thank you.
Indeed, the starting point of all achievements is desire. And that is how the desire first comes in, and the desire for excellence. And that is what these awards are for, to recognize the desire and the ability to excel in their respective fields. We have with us now Dr. Ravi Gaur, the EF Global Healthcare Diagnostic Professional of the Year 2021 has been bestowed upon Dr. Ravi Gaur. He's the Director and Chair, Medical Advisory Committee, OnQuest Laboratories Limited. Congratulations, Dr. Ravi Gaur.
Good afternoon. It's my pleasure and honor to be awarded as the Diagnostic Professional of the Year. I'd like to express my sincere thanks to the EF Modern Healthcare, organizers of the World Health Conference, and the foundation. I think it's a wonderful work done by you people over the last 2 days, and of course, what I've been hearing the past 2. I'm truly honored to receive this award. Award becomes all the important to me at this juncture when diagnostics are at the forefront. I would like to take this opportunity to thank my organization, the OnQuest Laboratories, my team members, my industry colleagues, my mentors, and all well-wishers. And most importantly, thanks to my family members, especially my wife, son, and parents, who allowed me to be around the clock in the war zone. I think without their support and blessings, I would not have delivered during the crisis time. I am an outcome-driven diagnostic person, and it's my passion and dream to build up a world-class diagnostics, which is affordable and accessible to the last man there in the remotest area of India. And that's what in OnQuest we have been trying to do, get the best of technologies in India, make them affordable to India, and make them affordable to masses, and show that the success and the technology and the best of facilities of diagnostics are there to continue forever. Thank you so much again, sir, and wish everybody a safe time ahead. Thank you.
Thank you so much, sir. Chairman, sir, would you like to say a few words?
Yes, Dr. Ravi Gaur, congratulations for your achievement. And I think diagnostics is like the investigator of any incident or event, be it crime, be it some other incident. And I think the sanctity of investigation is the starting point of any subsequent action, and its affordability. I'm glad that you are giving attention both to quality and affordability, because in developing countries like India, both are equally important. Quality, so that the resources, precious resources, are not wasted, and affordability, so that there is participation across the length and breadth of the population, and the true benefits of any progress are made available to the country at large. Congratulations once again, Dr. Gaur, and wish you many years of success.
Thank you so much, sir. I think I like to say, for me, every sample is a life. So we have to actually take this quality at at whatever cost. We cannot compromise the quality. And of course, cost is most important so that people can afford it. I am sure with the well-wishers, people like you out here, we will be able to deliver and come up to the expectation of Indian healthcare space. Thank you so much again.
Congratulations.
Congratulations, sir. And now let me announce the EEF Global Healthcare Cardio Care Professional of the Year 2021. And the award is being bestowed upon Dr. Rajesh K. Nair, Clinical Director, Department of Cardiology, and Chair, Midland Regional Cardiology Network Specialist, Coronary and Structural Intervention, Woki Hospital, New Zealand. Congratulations, Mr. Nair.
Thank you very much. It is a real pleasure and a privilege to have this award bestowed on me. I trained in Trivandrum Medical School in Kerala, and then moved to England and did multiple fellowships across the world in Denmark, in Australia, Japan, and started working as a consultant in New Zealand just over a decade ago. So my interest is pushing boundaries of what is possible with technology in cardiology space. I have a passion for innovation. I design new devices for the heart, and I also have a special interest in health informatics. So it is a privilege for me to be amongst you, and I look forward to my presentation in another hour. Thank you very much.
Thank you so much. Chairman, sir, would you like to say a few words and congratulate Dr. Nair?
Congratulations, Dr. Rajesh Nair. I'm so glad that you have done your institution proud, and you have traveled across the globe virtually in the quest for excellence, right from Trivandrum to UK to the other end of the globe in New Zealand. And I know New Zealand is a country of its own kind, of its own excellence and serenity. I had occasion to visit it in 1996, 97 to study the governance models. And some of the governance models in local government for excellence are something which the United Nations had put us on the job to try and study and emulate. I think you're working in a great country with a great cause, and good luck to you, and hope that you can bring your technology, your expertise back to God's own country, that's Kerala, your home state. My congratulations to you.
Thank you very much.
Thank you so much indeed. Right now, our healthcare workers are on the front lines really of battling the novel coronavirus. They are putting themselves in path of the coronavirus, and that's why thank you so much for all the sacrifices that you've made every day, and especially during the pandemic. Now let me announce the EEF Global Healthcare Cardiologist Professional of the Year 2021, and the award goes to Dr. Robert Skaik, physiologist and cardiologist, Wroclaw Medical University, Poland. Dr. Robert, congratulations.
Thank you very much. This is really great honor and pleasure to be with you here. And this is great distinction for me, for my family, for my university, and for my country to be rewarded with this fantastic award. I'm truly happy with that. I'm pretty proud of it. This is great remuneration for my hard work as a cardiologist, scientist, and also physiologist on the local and international arena. So once more, thank you very much. I really great pleasure to join you today. It's a great prestige, and I'm unbelievably happy to receive this award. Thank you very much.
Chairman, sir. Razdan, sir. All right. Very many congratulations. Indeed, your sacrifice and your services is saving countless lives and making thousands of differences in people's lives across the world. Thank you so much. And now let me announce the EEF Global Healthcare Leadership Award of the year 2021. And the award goes to Dr. Mustafa M. Hussain, MD, Professor of Psychiatry, Neurology, and Biomedical Engineering, University of Texas, Southwestern Medical Center, USA. Congratulations, Dr. Hussain. Do we have Dr. All right, now let me announce the EEF Global Healthcare Digital Women Leadership of the Year 2021. And I'm very delighted to announce the name of Dr. Uma Nambiar, Chairperson, Digital Health India Association, Bengaluru. Dr. Uma, very many congratulations.
Hi, thank you very much for bestowing this honor and a privilege to me. I've been a professional in this field for the last 30 years, and healthcare is one profession where there are more women than you would see in most others. But at senior leadership positions, here also there is a deficiency of women, and I think we need to change that. For me, healthcare is not just a vocation. It has been my passion. And all along, I have felt that digital health was the way to go for increasing the ethics and transparency in medicine. And I'm very, very passionate about making sure that healthcare is ethical and transparent. And it is, I came back to India about 3 years ago when digital health movement sort of picked up steam, because I thought that, with the right kind of people, if we get together and like-minded people, we formed DH India to make sure that we can make an impact in the country where it is needed. And we must do selfless, almost voluntary contribution to make sure that digital health in India becomes an example for the rest of the world. And that has been my passion, that drives me. And I am very, very thankful to the organizers for really honoring me with this award. And it's an extremely humbling experience. And it is not a journey that I have done alone. I have had a lot of people who have been my partners in this journey, all my colleagues, my friends, well-wishers, most of all my teachers and my patients, who are all for this award. Thank you very much.
Thank you so much, Dr. Uma, and very many congratulations indeed. Your commitment, your courage, your dedication to the profession, everything, they all deserve our deepest gratitude and admiration. Thank you so much. Now let me announce the EEF Global Healthcare Young Professional of the Year 2021. And the award...
Before that, we will request our chairman, Anil Razdan, to say few words.
Razdan, sir, you there?
Mr. Razdan is here.
Yes. Congratulations, Dr. Uma Nambiar, for your great achievement. We are really proud that you, as a lady, are getting this award, which is very special, not only for women leadership, but also is the future of health, is digital healthcare. And you rightly mentioned that healthcare is an area in which I think, like education, women are the natural front leaders. And I think the whole healthcare system, as nature had devised it for us, rests on the shoulders of women. And I'm so glad that you are leading from the front. My congratulations to you.
Thank you very much, sir. Thank you. Thank you, everyone.
And Chairman, sir, we have another very important section, and that is the EAF Global Healthcare Young Professional of the Year as well. So let me first announce the name of the people who have got it. There are two awardees, one from the national arena and another from the international arena. Let me first announce the EAF Global Healthcare Young Professional of the Year 2021 from the national arena. And we have with us Dr. Arun Raghavan, Director, Consultant Diabetologist, and also Dr. A. Ramachandran's Diabetes Hospital, Chennai. And he's also an intensivist as well. Congratulations, Dr. Arun.
Thank you. Thank you. I'm a diabetologist from Chennai at Dr. A. Ramachandran's Diabetes Hospital. At the outset, I would like to thank the jury as well as the organizing committee of EEF Awards on bestowing upon this honor, bestowing this honor upon me. It is indeed a very, very proud moment for me as well as the colleagues and other staff of my hospital. And I would also like to thank my family members, my friends, well-wishers, as well as all the colleagues and staff of my hospital, and most importantly, my patients as well. We've done a lot of original research work on diabetes, which we've published in many international peer-reviewed journals. What we try to do is we try to apply our own, whatever we've published, our own research, extrapolated into actual patient care, improving patient outcomes in this part of the world. And we've also been instrumental in highlighting the prevalence of diabetes in India. And recently, we've also started a new digital initiative from our hospital called Dia Home, which is looking to transform diabetes care digitally, which is going to probably help us to reach many patients throughout the country, every nook and corner where they are not able to access quality diabetes care. Thank you for this award. It's probably a validation and recognition of my efforts thus far, and it also motivates me and encourages me to work harder. Thank you very much.
Indeed. Chairman, sir?
Yes, congratulations, Dr. Arun, for this achievement. It's so good to see young professionals achieving such high degree of expertise and excellence. And the future rests on you. You're dealing with a disease which is directly related to lifestyles and also, I think, to the food chain. And I think you would be only doing your duty to society by highlighting both dangers that exist. And I think as a diabetologist, you ought to be working very closely with the food controllers and drug controllers, preventing the onset of this disease on those who are being attacked by it. It's a disease which was not so prevalent in India when we were growing up, but as we have grown up, it is virtually a full-blown disease across the country, and its causes are known to you professionals. It's high time that we put it across in the media and educate the masses and come down heavily on bad lifestyles as well as a bad and a harmful food chain. Thank you very much.
Thank you for your valuable input, sir. Thank you. Thank you so much.
Thank you so much. And now let me announce the EF Global Healthcare Young Professional of the Year 2021 from the international arena. And the award is being given to Dr. Ankur Kathuria, Operations Head, GMC Clinics, Dubai, UAE. Dr. Kathuria, very many congratulations on winning the award.
It's my great honor to accept this prestigious Global Healthcare Award on the Young Professional of the Year category from World Healthcare Conference. And at the outset, I would like to thank Platform Jury for selecting me and giving me this recognition, which is really a testimony of the hard work of my entire team at the GMC clinics in Dubai. And I would like to dedicate this award to the determined leadership of our CEO, Dr. Safia, and my colleagues and all the healthcare workers who have worked tirelessly during this pandemic, and definitely my management team also. So because of the strong support, we at our level are able to make some difference, which is sometimes reflected through such recognitions, which means a lot, and which motivates us further to work towards our goal and in this direction. And we as operation heads, we try to balance operations efficiency, quality care, and also the top line. So we are just trying our best to strive to achieve the excellence. Thank you very much. And also thanks to the EEF Modern Healthcare Organization and Dr. Anil Garg for this support. Thank you very much.
Chairman, sir, would you like to say a few words to Dr. Ankur?
Dr. Ankur Kathuria, our congratulations to you as the operations head of the GMC clinics in Dubai. Dubai is clearly emerging as a clear leader, I would say, in developing centers of excellence in various fields. And it's so heartening to see that people of Indian origin are leading from the front there. I've had occasion to see the excellent work that our young professionals are doing there and are doing global good. I think promoting excellence in an area which has the money to afford it, but more important, it has the will to move towards excellence. And you people are participants in that. We look forward to your leadership in other countries also. Thank you very much.
Thank you for your kindness. Thank you.
Thank you so much, sir. And now it is time for me to announce the EEF Global Healthcare Young Dentist of the Year 2021. And the award is being bestowed upon Dr. Nishtha Kaushik, dentist, public health enthusiast as well. Dr. Nishtha, very many congratulations.
Thank you. A very good afternoon to everyone. I'm truly honored and grateful to the organizing team and the jury for considering me for this award. As mentioned, I'm a dentist by profession, and over the last couple of years, apart from clinical dentistry, I have worked with various NGOs where in pursuit of public health, we have organized several oral and breast cancer screening camps across India. And we use newer health tech devices for the same, some of which were even discussed during the course of this conference. Also, I would like to mention that it has been an absolute privilege for me to be a part of this conference where speakers from India and across the world have shared their journeys, their thoughts, and the inspiring work that they've been doing in the field of healthcare. In the future, I hope to be able to build on the path that you have paved for youngsters like me. So yeah, thank you for giving me this opportunity and conferring upon me this award. Being the young dentist here, I'd like to say thank you and keep smiling. It will surely help us get past the strange times that we're living in. Thank you.
Right. Chairman, sir?
Congratulations, Dr. Nishtha Kaushik, for achieving this Young Dentist Award for Global Healthcare for 2021. I can see from your few words that you're a woman of substance, and your bite into your area is surely going to achieve great results. The dentists have a great job to do, and I think when you are talking of oral health care, and also you're working in the field of oncology, it's an area that is promising to grow in the future. And I think a lot of public health education, and particularly, I would say, the women population of the world is most important, because what mothers can impart, very few others can impart. Lessons given by mothers to their young children are something which even at my age, they can never forget. Thank you very much for your participation and for your good work.
Thank you, sir.
Thank you, and congratulations to all the winners. And the next two awards are going to be bestowed upon people with same names, actually. And we have with us first Dr. Divya Sharma, who has been bestowed upon the EAF Global Healthcare Community Service of the Year 2021. And she is the Medical Officer, Uttar Pradesh Medical Health Services, Ministry of Health and Family Welfare, Bulandshahr. Dr. Divya Sharma, congratulations to you on winning the award.
Thank you so much. Aishwarya, you're doing a great job.
Thank you, ma'am.
And I would like to initially start with congratulating the organization and the team for doing such a great work, putting out such a brainstorming event for 2 days. Yesterday I could come alive, but at night I have seen your conference, and thank you so much for such a prestigious award. I would like to thank the jury, the organization, Mr. Anil Rasthanji, Chairman for the Energy and Environment Foundation, and former Secretary, Government of India, Dr. Anil Kumar Garg, Chairman, and for the World Healthcare Conference. It's a great feeling to get recognized for your work at this field at the time of pandemic. I would like to dedicate this award to all my colleagues, my COVID warriors, and the survivors who are coming out so well with so much of grace and strength and bravery. I was hearing yesterday, and I'm completely in agree with Mr. Rajdhanji, that he said that what is COVID-19? COVID-19 is a social, health, and education issue. That is so much true, coming from the community medicine health. Community itself working with so much of people and having that bridge in between and giving that link to the people and working with so many people in itself comes a social issue. And going with so many communities and making them approve with what are your thoughts and process for the educating pandemic people, getting them educated for the vaccination, for everything, for what whatsoever. Now people are knowing it. We are giving awareness so well about the social distancing, masking, the vaccination, the medicines, the COVID-19 protocol, everything. So much right words have been said. And yesterday, as very rightly said by Dr. Gularia, the director for the AIMS, he said that yes, in community medicine health, not in medicine, R&D is required. Research and development is very much required. And I'm very glad for this and great work done by Honorable Prime Minister, sir. And saying this rightly, he said about each one vaccinate one, each one treat one, each one save one, and creating micro-containment zones. At the end, I would like to conclude by saying a few lines that I have read few days before by Swami Vivekananda ji, that the sign of vigor, the sign of life, the sign of hope, the sign of health, the sign of everything that is good is the strength. So my take-home message to all the dignitaries, ladies and gentlemen out here is please behold your strength at this time of pandemic. Thank you so much. Jai Hind.
Thank you so much, Mr. Rajdhan. Would you like to say a few words to Dr. Divya?
Congratulations, Dr. Divya Sharma, for attaining this award at such a young age. And I do remember your presentation in the previous conference and the good work that you are doing. But I normally speak from the heart, not so much from the head. My head doesn't have much in it. And I really feel that health is an issue, particularly this COVID-19, in which the community has as much responsibility as a health worker to bring the pandemic under control. Medical research and other research will produce the cure, but its prevention and its non-proliferation lies squarely, I think, in the hands of the community and the home where it starts. Congratulations to you for having attained this award, and best wishes to you in the years to come.
Thank you so much, sir. And let me announce the award for the the EEF Global Healthcare Training and Telemedicine of the Year 2021. And of course, we had the greatest pleasure of listening to her, and because she had presented her, she basically showed us some of the glimpses of her work as well. So we got to see some of that as well. You're doing great work, Dr. Divya VS. Congratulations to you. So the award for the EEF Global Healthcare Training and Telemedicine of the Year 2021 is being bestowed upon Dr. Divya VS, State Nodal Officer, Training and Telemedicine, National Health Mission, Kerala. Congratulations, Dr. Divya VS.
Thank you all. Thank you, the team, Global Healthcare, World Health Conference team for arranging such a wonderful opportunity so that we can have an introspection of what we are doing and present it somewhere so that somebody is seeing what the work we are doing. Actually, I being a professional, medical professional, and managing 2 teams of training and telemedicine in state of Kerala, mostly during this COVID-19 times, we are through a great pressure and great stress while doing so much of activities, while coordinating so much of activities. And in between, getting such an opportunity to present ourselves, the good works we have done, and getting motivated from the words of the renowned persons like Dr. Anil Kumar sir, and Anil sir, Anil Razan sir, and many from world across is such a good experience. I'm very much thankful for towards the entire team for arranging such an event, and most of and over and above that, most thankful to Dr. Anil Kumar Garg sir for inviting me for such an opportunity, with such an opportunity ahead, and giving opportunity for all of my team to attend and listen to the entire presentation. Many of the presentations that I heard yesterday and today are from world across activities, which are giving me new hopes, new ways to try, and I'm assuring you that we'll come out with different, new and innovative experiments that might give us new hope and new ways. Thank you for all the opportunities you gave me, and thank you for the awards. Thank you.
Thank you so much. Razdan sir, would you say a few words to Dr. Divya?
Congratulations, Dr. Divya, for attaining this award for medical healthcare, global healthcare training and telemedicine award. I think the Dr. Divya VS stands for very special for us. And we only hope that you will carry this good work with the kind of dedication that's very evident in your remarks, in your speech, your work, and be an example for the others to follow. Because no work of this nature can be achieved without dedication. Profit is normally a motive in business or commerce or economic activity. But in the social sector, it is motivation and commitment to the cause. And that is what people like you have shown, and for many others to follow. It is priceless. Congratulations once again.
Thank you, sir. Thank you for your good words. Thank you, sir, again.
Thank you so much, sir. And congratulations to all the awardees. You've done great work. But as it is said that we have promises, we all have promises to keep and miles to go before we sleep. So I hope that we all keep up the good work. Congratulations on the great work you've already been doing. And I hope that you all achieve greater achievements in life and make not only yourself and your family proud, but the entire nation and the world proud of the work that you're doing. Congratulations to all the awardees. And with that, we wrap up the award ceremony as well. And Dr. Garg, would you like to say a few words?
Shreya, these awards are just recognition of excellent work done by organizations, individuals for the great cause of humanity. Thank you.
Thank you so much. And with that, we'll wrap up this session. But we have another very interesting and very thought-provoking session. The plenary session is going to come up ahead in the next 30 minutes from now. We'll take a very short lunch break, but more interesting technical sessions coming up in the post-lunch session as well. So we request all of you to stay with us, stay put, and join us in about 30 minutes for the next technical sessions, because we are going to have some really thought-provoking and interesting topics that are going to be discussed by experts in the post-lunch session as well. So thank you so much for joining us, and we'll be seeing you in about 30 minutes.
Thank you, sir, for sparing this time, which
Thank
is
you.
very, very important. I know you have many calls and other problems, but thank you very much for sparing
Thank you.
this great time.
I had to excuse myself. I was to be in executive committee meeting at 12:30. They were going on calling me.
Okay.
I had to excuse myself.
Thank you, sir.
Okay.
Thank
Thank
you,
you very
sir.
much. Bye.
Good afternoon, Dr. Nair.
Good afternoon.
Dr. Nair will be starting with the session in about 2-3 more minutes. We have with us Dr. Mahesh Nayan Kumar also. Very good afternoon, Dr. Mahesh.
Good afternoon.
So do we have Dr. Viveka Kumar with us?
Yeah, I don't see his name in the panelists right now.
He is supposed to be chairing the session. Then, Mr. Garg, do you want somebody else probably to chair the session? Or would you be doing it? You need to unmute yourself.
Yeah, it's okay.
Yeah, so since Dr. Kumar is not here, we can request Dr. Nair to act as the chair, and we can start with the session.
Yeah.
And we're also supposed to be joined by Dr. Alok Chopra as well.
Is that? Yeah, I saw Dr. Chopra.
Yeah, his camera is on. Yes. I guess he's going to join us soon. So, Mr. Garg, should we start with the session?
Yes, let's go ahead.
All right. All right. Very good afternoon, gentlemen. Very good afternoon to the World Healthcare Conference 2021. This is the technical session, the post-lunch session that we're going to start with. And the topic that we'll be discussing in this session is going to be new technologies, innovations in cardiology and cardiovascular medicine. Dr. Rajesh K. Nair, Clinical Director, Department of Cardiology, and Chair, Midland Regional Cardiology Networks, and Specialist Coronary and Structure Intervention, Waikato Hospital, New Zealand, is going to be the chair for this session. Very warm welcome to you, Dr. Nair. And we'll also be joined, we are also joined in by Dr. Mahesh Nayan Kumar, cardiologist, Senior Gregoris Medical Mission Hospital. And Dr. Alok Chopra is also joining us. He is the Chief Consultant Cardiologist, founder, Ashlok Hospital, and Daivam Wellness. Very good afternoon to all of you. And I'll now request Dr. Rajesh Nair to please chair the session and begin with the technical session 9 that is going to focus on new technologies, innovations in cardiology and cardiovascular medicine.
Thank you. Good afternoon. Greetings from New Zealand. This is a very exciting topic, particularly new technologies and innovation at this time when we have a global crisis. I'm a cardiologist. I've trained in interventional cardiology, structural heart disease cardiology, and imaging cardiology. So I've got disclosures. I've provided clinical advice and proctorship to a few companies, both hardware and software companies over the years. There are several direct cardiovascular sequelae following COVID. And there are numerous studies that are coming out across the world that suggests patients die, a terminal event of patients is cardiovascular disease. So in New Zealand, we are extremely lucky. Yet we had 4 months where we had 4 weeks rather, where we had a complete shutdown of the country. We saw the trends of what others are seeing across the world, in that patients who have had troponin positive events or troponin cardiac enzyme raised tend to die sooner during COVID pandemic. And this is quite significant. So what we also found is there is a significant reduction in patients presenting to the hospital with a heart attack. And that is seen across the globe. And the number of interventional procedures that are done in the hospital is also significantly reduced for New Zealand for the 4 weeks. And we have trends to show that. And I'm sure across the world, many of my colleagues report similar trends. For those who come to hospital, often they come late. And therefore, the mortality following a major heart event is significantly raised during this time. The sickest who survive come to the hospital and many don't. What is interesting here is the world is waiting for the third event, the third component of COVID, the collateral damage that is not apparent right now. It gets apparent several years, perhaps almost a decade later, following a major pandemic. And we need to be prepared for that. And that is where innovation to promote heart health has to happen. It has to happen both in the hardware category as well as in data and digital transformation. And both are important. If you don't plan it now, in another 5-10 years, we will be grappling with a third wave of COVID. We are able to do that because we now have excellent appreciation of heart using software and hardware. This is a CT scan, a 4D scan of the heart. And this is a patient who have had aortic valve disease. He is in his 60s. He did not particularly want to stay in hospital. And this is what he would have otherwise got. And we were able to treat him using a minimally invasive technique with 1 centimeter cut on the shoulder and change this valve. And this is day one. That evening, following his heart valve replacement, he went home the next day. He did not want to stay in hospital. So this is where technology and innovation should go. And over the next 15 minutes or so, I will share with you some of the work that we are doing in New Zealand and some of my involvement globally in designing new therapies. This is 4D CT, 3D echocardiogram of the heart, transthoracic and transesophageal, to understand the different structures of the heart. Much of my work these days are in structural heart disease, in both intervention and imaging, and some of the on-calls that I do coronary artery intervention. So this is a patient who was admitted to a hospital with critical mitral stenosis and florid pulmonary edema. And the patient was sat up 45 degrees. We had an intracardiac echo probe in the heart, and we ballooned the mitral valve, and patient gets better in the next couple of hours, and she goes to surgery a few days later and gets home with an excellent outcome. And these are therapies that are usually done perhaps quite commonly in India and other parts of Southeast Asia, but in New Zealand these are very rare. Therefore, the technology helps us to get across these patients through the line. Now we have the same intracardiac echocardiography in 4D, where the probe is miniaturized to understand the three-dimensional structures of the heart in real time. And we are able to take this, the tip of the probe in different parts of the heart and see the structures very closely in 3D real time. And we are able to plan different procedures. There are several heart valves that are being studied. Several are being designed. I'm very lucky to be part of some of these designs. And this is a patient who has severe mitral valve leak. And again, these are patients who are high risk. And if we were to operate on these patients, they tend to stay in ICU for several days. And here we have a small catheter that is inserted through the apex of the heart. The valve is crimped inside that small tube, and it's released at the mitral position, and the patient has got a new mitral valve which is similar to a valve that patient would have got if they went for cardiac surgery. And the patient goes, this patient stays in ICU for 2 days because we have made a hole in the tip of the heart. But now we have designed strategies to close that hole percutaneously so that they don't need a major cut in the chest. This is another patient who has had 2 valve replacements in the past. It's the 3rd time the patient is coming. So you can see a small break in that ring across the tricuspid valve. So here, the valve, the patient's heart is imaged on a CT scan. That CT scan is then superimposed on an X-ray platform. So the cardiologist is looking at the X-ray platform with superimposed CT scans. So we are then identifying spots in 3D space within the right-sided chambers of the heart. And that dots are also superimposed on X-ray. So we are then able to tell the surgeon exactly where to place a nick on the skin, where to touch the heart, where they would find the mid part of the chamber and go straight into the previous ring and then replace the heart valve. The procedure is over in about an hour and a half. Patient is woken up in the cath lab and is able to mobilize that evening. This is another procedure we've done in the mitral position, the same valve inside a ring. And this time we are able to go through the vein itself. The cut in the skin is about ½ centimeter. And that cut is also closed using stitches that go beneath the skin on top of the vein. Again, the patient had torrential valve leak following a valve repair operation about 6 years ago. And now a patient has been admitted with heart failure. This is an elective procedure. Patient went home, came back the day of the procedure, had the procedure done. The following day, the patient goes home with a completely new valve. This is made possible because there are multiple specialists working together in the operating theater. This is another technology where we can put a small clip-like device on the leaflets, on the valve leaflets to minimize leak of mitral valve. The same technology is used to treat other valves like the tricuspid valve also. And much of this is done under guidance. So what the cardiologist sees is guided by the imaging cardiologist who has a small probe in the throat and then looks at the heart and sees the heart real time in 4D, quite like how the surgeon would see the heart valves when he or she operates. We are able to identify every part of this anatomy in great detail and then place the clip at the point of leak. If the leak is slightly on the left side, we are able to move the clip or move the device by millimeters and then land the clip at the desired position. And is that all effective? We have got data to suggest these patients who are treated with a percutaneous technology, with a new innovation, fares just as well as an open heart operation up until 4 years, including the saving lives. The number needed to treat to save 1 life in select patients is 4 with these technologies. If this patient had gone for an operation, particularly at this time where there is COVID, these patients linger around in ICU for a considerable period of time. And technology has been shown to be both clinically effective as well as cost effective. This is a new device that we have helped design for the tricuspid space. It's made by a company called Navigate. Here the tricuspid valve is severely leaky. Patient tends to be in hospital several times with fluid overload, swelling in the legs and in the tummy. And patient is severely breathless. The valve is not touching each other and it's severely leaky. So we are able to understand the distance from the chest wall to the valve, distance from the chest wall to the side of the heart, understand exactly where the mid part of the valve is. In tricuspid valve particularly, especially when there is no previous operations, we are now touching the native heart tissue itself. And we are able to understand all of this in real time by echocardiography guidance. we have a specialist in echocardiography with us, showing us exactly where to go. Patient is anesthetized but not connected to a heart-lung machine. And the valve is landed exactly at the right spot. The valve is attached to the native heart, native leaflets by small tines. And these are also released very carefully. And we have almost perfect results, quite like how the patient would have had if they went for an open heart operation. The significance of this particular procedure is there are patients who have right-sided heart failure. The tricuspid valve is in the right side of the heart. When that particular valve leaks, patients tend to have right-sided heart failure. Those patients don't tend to do very well if we were to connect them to a heart-lung machine. This is another patient with severe coarctation of aorta, where there is narrowing of the aorta, and these patients are treated with stents. But when there is complex coarctation of aorta with aneurysm of the aorta or the swelling of the aortic wall, then we don't have stents available off the shelf. Then we custom make stents. We take these measurements and we work with engineers. We custom make covered stents at a desired length, desired radial force, and then we are able to release these stents and then treat the patient effectively. And these patients do very well following discharge. And we follow these patients up regularly with CT scans to make sure the aorta is well with no late complications. However, not all technologies turn out to be what they are meant to be. This is augmented reality from Philips. I remember being on the advisory board for them. But this technology sadly didn't come up. It looks very nice. We are able to see everything. The cardiologist wears a hologram lens. But does it translate to real everyday use? It perhaps doesn't. So there is place for technology, and also as we innovate, we also need to be aware of our limitations and move on from some of these technologies towards what is most beneficial for humankind. The next part of my discussion is about digital transformation. This is also an interest of mine. I'm in the health and informatics leadership group in New Zealand, where we have where much of our practice is now based on evidence as to the trends what we find from our practice. I work in a public hospital system, and in every public hospital system has got resource constraints. So we work in a carefully regulated world with the constraints and the resources we have. So I work with the engineers to design care pathways, all of it digitized. Previously, much of these care pathways are ad hoc. Some of this is by email, some of this are by letters. Now, patients are referred, and right from the point of referral through to the discharge and follow-up is captured digitally. And every person who engaged in the patient care pathway for cardiac surgery or structural heart disease intervention are given access privileges to these systems so that we can have audit trails. And all the stakeholders are updated regularly through the movement of patients through our system. I work with engineers to make a component-based microservices architecture with various technologies that are available currently, mostly open source. So much of the patient details is also picked up. And some of this is done by the cardiologists in the peripheral hospital, regional hospitals, referring to our center, and then these are compiled. The coordinator understands where these patients are at any given time. And also nationally, we are able to have a system to understand where patients are waiting most and the results of some of the interventions we do. This is the discharge summary as the patient goes through the care pathway. Much of this is automated and automatically generated and then shared with multiple stakeholders. In New Zealand, the indigenous population is called Mari. Mari population tend to live in remote communities, and many of them are in socially underprivileged societies. So the risk of a Mari patient dying from cardiovascular disease is almost 3 times as high as a non-Mari patient. So we have designed programs to reach out to patients who don't tend to reach hospital fast enough. So we have a Mari liaison nurse specialist who visits patient's family and does screening examinations, point of care blood tests. And if any of these are abnormal, they get a heart scan in the community, and then we are then able to select patients who need to be at the tertiary center. And much of this is managed by a remote health management platform that we have built both at the level of a community as well as at the hospital to track activities. So every part of this social intervention is picked up right from the beginning through the intervention and also on follow-up. So this data is crucially important for us to understand what we need to do, what we are doing, and also target select populations and plan funding with the funders. Some of this is also by supporting the Mari health nurse, liaison nurse specialists, and echosonographers from the tertiary center by remotely using technology. This is a sample of the dashboard of patients. And this is where the chat integration is inside the application, both video chat as well as audio and text between the specialist as well as the liaison nurse specialist and the echosonographer. And all of this is digitally captured and archived. There are several layers of security that we go through, and most importantly, some of the systems are not some, all of the systems are GDPR compliant. It goes through a WASP platform to understand vulnerable points. The video security is also that surpasses the level that is stipulated by FDA. The most important part of it is these are analytics that are built into these platforms, both the cardiac surgery platform, the remote health management platform. So we understand the Kaplan-Meier curve, the trends of clinical outcome measures for different procedures we offer at the hospital. So we can also streamline the outcome measures depending on the frailty of the patient, depending on the kidney function, so that we learn valuable lessons going forward. Inbuilt into this is machine learning systems, where we should automatically predict which valve we should choose depending on the patient weight, patient size, depending on the extent of calcium that the patient has in their native valve leaflets. Thank you. I'm happy to take questions.
Yeah, do we have any questions? But before we take any questions, we have Dr. Viveka joining us at the moment. Very good afternoon to you, sir, and thank you so much for having joined us. So let me just a second, sir.
Shreya, I have to say,
Yes,
welcome,
sir.
Dr. Viveka Kumar.
Yeah, thank you, sir.
Principal Director and Chief Cath Lab, Max Healthcare, Cardiac Science, Max Super Specialty Hospital. I will request you to chair the session, though our first person is already there, and Mr. Das is there, Rajesh, who got this global award for cardiac surgery. Also, he's here. He has given presentation. So I will request to chair the session and give your thoughts and word of wisdom on the subject. Thank you.
And I have to inform everyone that Dr. Chopra had to leave. He had joined us just a while back, but he was feeling a little unwell. So he is not going to be a part of the session anymore. He was having vertigo and headache.
Yeah, so thank you. I think that was a very good presentation by Dr. Nair, and he showed what we have in offering now in current interventional cardiology, and he nicely showed the care pathway. I think in today's world, the care pathways and combination of AI would do magic to decrease the adverse outcome in high risk patients, especially those who are patients coming with acute myocardial infarctions and those who have CCS and all. So I think that was really very nice presentations. I would like to ask him one question that, how do you see the future of AI in not only the high-end interventional cardiology, especially the structural heart, and also in the care path of various other diseases like, heart failure and myocardial infarction in particular coming?
The AI is a very broad concept. I work with people who have specialized in artificial intelligence from Europe. There are several advantages to this, but most of the advantage is based on data. And if you don't have data, much of what we predict does not really make meaningful sense on a clinical perspective. So we are designing heart monitoring devices, external heart monitoring devices, which are wearable devices, where we will generate a large volume of data, which can then be used to reasonably predict which patients may fall sick almost a week before they would fall sick. And this is useful for patients with heart failure, for example. Depending on the molecular nature of their sweat, we should be able to predict which patient will translate into a hospital admission, which patient may not be translated to hospital. I think this is where the future of AI will be in medicine in general.
Yeah, thank you very much. So, Aishwarya, can you tell who is our next speaker, please?
Sure, sir. So we have Dr. Manish Kumar, who is now going to take the stage. Dr. Mahesh.
So, Dr. Mahesh. Good to see you after. How are you doing? Great. So Mahesh is a very old friend of mine, and really it's a pleasure to see him. Very versatile interventional cardiologist, and we worked together long back in Cochin, isn't it? So let's see what he has to say. Mahesh, over to you.
Thank you, sir. Thank you, Dr. Garg and the World Environment Foundation for giving me this opportunity. The topic given to me is the newer advances in cardiovascular medicine. I thought I will touch on 4 different things which I felt made a lot of difference in the management of cardiovascular patients. Greetings from the southernmost part of India, Kerala. A lot of COVID here too, but we are still surviving. So first I would like to talk about what is FFR and imaging in PCI. Whenever there used to be a cardiology conference, everybody used to talk about something called as an oculostenotic reflex. You saw the lesion, you stented the lesion. So eventually we came over to the fact that the lesion has to be physiologically significant and valid enough to deserve a stent. So that is where the physiology of assessing a lesion, in addition to being seeing to an angiogram, was started, and we started what is called as a fractional flow reserve. This is the maximum achievable blood flow in the stenotic artery divided by the maximum blood flow in the artery without stenosis. So you basically measure the blood flow beyond the lesion and before the lesion and take a ratio and see if the ratio is statistically significant before you decide to stent the lesion. So this is the aortic pressure. This is the pressure wire that is put. This is the lesion. So this is the distal pressure, PD, and the proximal pressure is taken as 1 or 100 is a PA. And we take the measurement in between and then make sure that this ratio is met. Then studies were conducted to find out what is the correct measurement ratio that is required and that is beneficial to the patient. And an FFR of 0.90 equal to 90% of maximum flow, 0.80 equal to 80% of maximum flow. By changing the FFR from 0.5 to 0.95 by stenting the affected lesion, you're increasing the lesion from the flow from 50 to 95%. So a pre-lesion, a pre-stenting FFR tells you what is the present state, and post-stenting FFR tells you what you have contributed to this thing. So FFR is just merely not exactly the flow in the presence of stenosis. It subtends much beyond that. So in the presence of FFR in the presence of a stenosis, this PA will be, say, assuming 170, and this is the difference that is taken, PD by PA, and that is taken as the FFR. So larger the area perfused by the vessel, the higher the chances that the FFR becomes positive. So if it is a 100% lesion and this physiology has got a 70% lesion on angiogram, and if it subtends a large perfusion area, the FFR would be definitely positive. However, if it's a very tiny area and it's a very small perfusion area, even if the lesion is 70%, since it is subtending to a small perfusion area, it is unlikely that the FFR would be positive. So the physiology does not translate into the stenosis that we see on angiogram. Vice versa also. If it's a 50% lesion and if it's subtending a very large perfusion area, you may still find the FFR to be positive. So, second point I would like to stress is that if there is the area that is subtending is normal myocardium, then the FFR becomes positive. Same vessel size, same lesion size, but half the area is scar tissue and half the area is normal myocardium, then the FFR, the physiological significance is not that much as having a totally normal myocardial perfusion. So the area we are, what are the things we are able to subtend? We are able to find out which is the area that is the myocardium that is being supplied, B, what is the stenosis as per the angiogram, and C, what is the FFR, which implies the amount of myocardium that is being subfused and the amount of minus the amount of scar tissue that is being subfused. So this gives you an exactly the lesion that is to be stented, and the permutation combinations are phenomenal. So if you think or thought that as every 70% need to be stented, you're wrong. And if you thought that every 50% had to be left alone, again you're wrong. You should, when in suspicion, when you are dealing with a large vessel, please do an FFR. You will get a more clearer picture. So that is the bottom line for FFR. It's a physiological thing, and you have to keep physiology in mind, just not the angiographic finding in mind. Next, what I would like to tell you is about OCT. It's a form of imaging, and this is how a vessel looks like. It's got smooth muscle, foam cells, scavengers, macrophages, monocytes, a lot of things. Then this is the plot that's seen. So this is how, this is the imaging catheter, this is the vessel, this is the guide wire shadow, and this is the layers of the vessel that is seen as adventitia, media, and intima. This is how an optical coherence tomography image looks like. It is done by passing a small catheter, a camera, into the vessel through over a guide wire, and then images are taken and they are summated, and you get a clear display. This is how a normal vessel, a coronary OCT, looks like. This is a fibrous plaque. You can see that the external elastic lamina has been pushed in. It's got a large, high backscattering, relatively homogeneous area. This is called a fibrous plaque. And now this is a fibrocalcific plaque. So this outer area that you see is fiber, and this round globules with shadow inside, these are all lumps and lumps of calcium. This is a fibrous area, this is the calcified area. How to tackle a fibrous lesion is totally different from how to tackle a calcified lesion, is totally different from how to tackle a fibrocalcified lesion. So depending on what type of lesion you have to you have to decide that what is the line of management where you need a cutting balloon, where you need a pre-dilatation, where you need a post-dilatation, where you need a rota or any other newer modalities is decided by this. So the FFR decides whether the lesion needs to be done or not. The OCT decides how it is to be done and from where to where it has to be done. That is the landing zone distally and the landing zone proximally. So much of information is given to you. And after the whole procedure is over, the OCT will tell you whether you have done a good job in addition to the FFR. So this is how, these are the other things you can see. This dark area you can see is a large lipid pool, but there is no calcium, a little bit of fibrous tissue is there. This is the thin cap fibrofatty layer, which shows we can actually measure the thickness of the layer, and we can decide whether this guy is going to be dangerous. It's one of the types which is going to easily rupture. You can see cholesterol crystals. You can see thin cap fibroatheroma, TCFA, which is the root cause of all the myocardial infarctions. This is the thin cap fibroatheroma with a huge lipid pool lying behind. So you can see a fibrous, which is bright pixels. You can see a lipid, which is a sharp thing with a large dark shadow. You can see calcium, which is blobs inside these things. So you can define what is the type of plaque you're dealing with. And with FFR, you can tell you what is the significance of the lesion, and then you decide the strategy. This also tells you about restenosis. What is the etiology of restenosis? Here it is new atherosclerosis. Here it is a huge ruptured fibropratic plaque, and this is just fibrous plaque. Do you see? So you can actually identify what is the reason for your ISR in instant thrombosis, whether it is because of proliferation or because of poor stent deployment initially. So OCT imaging gives you pre-intervention assessment, deployment deposition, and complication and post-procedural assessment. It can be used in all the 3 stages of the thing. So this is how an OCT image will look like. You can see how beautifully the stent can be seen fully inside the vessel, whether the stent is overlapping. You can see the cross-sectional area. You can see the branches coming in. You can see the small, this reflection is all because of the stent struts. The cardiologist will follow it easily. And it also tells me what is the area that I have achieved, what is the percentage of residual stenosis that is there. And it comes almost up to the left main. So OCT will tell me what is to be done pre, post, and assessment in subsequent stages in case there is a restenosis. So FFR tells me the physiological significance. OCT tells me the character of the lesion, and also tells me whether the lesion how the lesion has to be handled depending on fibrocalcific, calcific, or lipid pool. That is the 2 imaging things I will tell you. Now I just tell you about 2 pacemaker new developments. This is how the older type pacemakers look like. You have pacemaker, you have leads coming from this side, you have leads coming from that side. Sometimes they can be extracted, sometimes they cannot be extracted. And after a particular time, if there is lead failure, you end up putting more and more pacemaker leads. There are 2 solutions to that just recently come into market. One I would like to say is about the subcutaneous ICD, where the ICD is put under the armpit, and it is placed above and outside the chest wall, just under the subcutaneous chest wall. It's got 3 basic vectors to give a shock. It can give up to 5 shocks per episode, 80 joule shock, 128 seconds of ECG can be stored, and shows up to 44 episodes. It identifies, it says a surface ECG, intracardiac ECG, and this is a subcutaneous ECG. You can see that unlike the intracardiac ECG, which comes in as single lines, this is almost similar to the surface ECG. So the SICD actually captures the surface ECG, which makes it more physiological. Above 220, it gives a shock. 200 to 220, it takes some time to analyze whether it is need to be shocked, whether it is supraventricular tachycardia. The algorithms are applied, and below 200, it does not shock. So this is a straightforward programming and follow-up. So there is absence of leads within the heart and the central venous circulation. No leads at all. Pocket infections are rare. If it happens, you can just open it and take it out because you're not going intravenous. Then explanting is easier. Younger patients who have a lot of physical exertion and who tend to break the transvenous leads do much better with this simplified implant procedure, and it is definitely more cosmetically more better. So This is the when there is no indications of bradycardia pacing and there is no indication of CRTD indication. There is in the high risk group of patients where there is risk of lead complications, infectious risk, venous access, patients with no pacing indication. Subcutaneous ICD is the new way to go. And lastly, this is the first subcutaneous ICD that I did. You can see the subcutaneous. This is a previous ICD which couldn't be taken out because of the age of the 12 years old lead. I couldn't pull it out. This is a subcutaneous ICD. The lead is lying subcutaneous, and it comes, and this is the pocket, and this is the machine, which is kept well outside. So if I need to take it out, this is very easy. 1, 2, since it is not intravenous, I need not, there is chances of infection are very less. I just quietly need to go in and change the battery if indicated. So there is the advantage subcutaneous ICD. Lastly, I would tell you about this new small pacemaker called Micra, which is as big as this. So you can see how the pacemaker started off with such a huge thing. It has come down to less than. Why is it important? All the things I told you about the leads going in and scars being formed and post-implant problems. So pocket-related complications are about 8% at 5 years with traditional technology, infection, hematoma, and erosion. Lead-related complications are 11% at 5 years. So these two things can be avoided. This is a self-containing contained pacemaker, which has got a bipolar pacing mode of VVIR. Now it has been upgraded to VDDR. So it can sense atria and pace the ventricle. It's got bipolar sensing. It's an MRI Sure scan, capture management, rate response, battery status diagnosis can be done, and it can be deactivated or reactivated. So you can see how small it is as compared to a coin. So it gives you a 12 years of life, and this is how it looks like. You go in with the introducer, push into this thing, the tines go in, and the catheter can be withdrawn, and the Micra remains inside. How this looks like on implantation, you reach across a tricuspid valve, gently push across the tricuspid valve. Once it jumps into the RV, push against the RV wall, give a small injection to confirm that you are against the RV wall. And once you're sure you are against the RV wall, you start deploying it like I showed you in the picture. How does the deployment look? Sorry. This is the deployment. Once it is deployed, it can be it gets deployed into the RV wall, and then the sheath is the device is withdrawn, and the device remains, and the delivery system is withdrawn. This is how the device looks eventually in the. So after that, you just gently pull on the device to make sure that you are there. When you pull, this is what you get when you pull. So you're pulling the device back just to ensure that the tines are adequately inside. And the advantage of that is that if you see a conventional thing, you have screwed the lead inside. When you screw the lead inside, there is chances of fibrotic response around it. While the Micra device has got leads on the side, and the area which is spacing has got no fibrosis because there is no lead that has been screwed into that. And another advantage is that suppose you have a placement which is not technically the most sound place, you find that the leads are floating and not doing anything. All you need to do is to get the device back in, pull it out, then rearrange, realign the system, and then push it back in and find a new spot and come out. It is as simple as that. So you can, any number of times you can redefine the Micra. So it is multiple studies have shown that there is 98.3% of the patients have got low cystocytine. So this is a new where the VDDR has come, which senses the atria and paces the ventricle. So you get a dual chamber compatibility pacing with a single Micra in the ventricle. Thank you. I thank for the opportunity and willing to take any questions if any.
Thank you, Dr. Mahesh, for a nice presentation about the advances in cardiovascular sciences, right from the pacing to the intervention and physiology and imaging. So if I say that, that these procedures which have made the, life of not only the patients easier and decision making has become better, but also the life of a cardiologist also, because there are many situations where we had no hope, but with the help of technologies we have come this far. And I think one thing I would like to know that in these advances, what is this status? These devices getting monitored at home by the patients so that they don't have to visit the hospital, especially in COVID time, and can they get, avoid the hospital visits and get all these devices monitored on their own mobile phone as well? So a few words on that.
Yeah, the newer devices they do have a mobile phone monitoring thing. I was really skeptical because if you can monitor something through mobile phone, I was just wondering whether it will interfere with the device itself. Unfortunately, it does not. The system is so airtight that you can easily, sitting at home, send the all the information that you want to send to the clinician sitting in his office. The only flip side I saw to it was there is one of my patients who sends it to me every day. So now I can't tell him, boss, you don't have to send it every day, only once you have a problem. So it has got a flip side, but otherwise I think it is fabulous thing to happen during the times of, specifically during the times of COVID and elderly. Without coming to the hospital, they're able to send me the data of anything that is difficult. And if they're on the central monitoring system, if anything goes wrong, the company automatically tells you that, look, this patient has had this event, kindly look into it. That's a fabulous new step which has already come in.
Any other questions, if people can put in the chat box if they have? Dr. Garg, would you like to ask any questions?
Dr. Kumar, the science of cardiology is very, very complex, and at the same time, it requires some basics. So, what are the basic requirements that we should avoid cardiac arrest? This is a basic, simple question that agitate our minds.
So the most
I think, Dr. Mahesh, it's $1 million question. I think the whole world, including the Apple Watch and the, all the what we were discussing about AI and the Dr. Nair from New Zealand also, this is what we are looking at, because we don't really know when the plaque will rupture and whom the MI will happen. So I think the world of wisdom is required. So would you like to sum it up for us, Dr. Mahesh?
I think you already summed it up. It is like, when you think that you've crossed all the bridges and reached a conclusion, suddenly one guy sprouts up saying, I have had a cardiac arrest, and he has got nothing wrong with him. So he's on a treadmill, happily going, and has a cardiac arrest. The fellow who's got coronary artery disease has a cardiac arrest. The athletes' hearts, Jackie Joyner, Kersey and gang, they have a cardiac arrest. So the etiology is so wide and so widespread that to localize and come to a single line or a single textbook solution for cardiac arrest is, as of now, impossible, sir. The spectrum is too wide. We can just narrow it down to say we can short down about 90% of the causes, majority being coronary artery disease and hypertrophic cardiomyopathies, and we can say that these are the things that we should look into. But every now and then, when you have decided that you have come to the end of it, you kind of sodium channel disease, a potassium channel disease, a long QT disease. So there is no end to this spectrum. As of now, we are helpless. We can only tackle what we are. The brain can tackle what the mind knows types.
Yeah, so I think answering Dr. Garg's question is that, we can identify these groups, but you cannot prevent it 100%. And that is the place where, the monitoring of what we call ectopics, the atrial fibrillation onsets, and all these things would, tell us in advance that something is going to wrong, going to happen in particular patient. We had a lot of information from patients who had, left ventricular systolic dysfunction, and those who were in devices. We got a lot of insight from them that the patients who get into multiple atrial ectopic runs of SVTs and all, and then they eventually go into AF. But when these home monitoring devices started raising the alarm and the treatment started, a lot of hospitalization could be avoided. Similarly, we know that those who ejection fraction is low, they are at a higher risk of sudden cardiac death. But as Dr. Mahesh said, we have to go a long way to protect every human being from sudden cardiac, because it's a very varied etiology. And then, if the heart is absolutely normal, if the cardiac MRI and everything is normal, suddenly the guy gets into a huge business loss, and because of the autonomic storm, he gets a cardiac arrest. So it is not only the anatomy, but it's also the physiology. And as long as you cannot control your physiology, working on anatomy alone would not work. So I think that is where the how so far we go into artificial intelligence and monitoring and gadgets, this and that. The role of lifestyle modification is of paramount importance, and I think that is something which has to be emphasized in each and everything. And we need to de-stress the society, de-stress things, and heart diseases and cardiac events are a marker. They get precipitated by inflammatory response in the body. So inflammation, whether it is because the stress or because the infection, because of the COVID, we need to control that and then try to decrease the events, but we'll never ever be able to conquer it. So over to Dr. Anil Garg. I think we are coming to the back end of this session, and you are mute, Dr. Garg, so you can.
Yes. Dr. Kumar, excellent view you have presented. And before that, Dr. Robert from Poland has given his views and how the monitoring device from AI and others digital techniques, they can be just monitored at the hospital direct from the patient. And as you have sum up in one word, that lifestyle is the key. Whereas analytical and physiological and psychological, all aspects are important, but lifestyle monitoring is a must, and that is responsible for most of the diseases, including cardiology. Thank you very much, Dr. Kumar, for excellently reviewing and chairing the session, which is very, very important. This conference is every year on 15 and 16 of April. So I will request sometime on 15th of April next year to take time from you so that you can deliver a plenary address at the inaugural time. Thank you very much, Dr. Kumar, and our other colleagues, Mr. Mahesh, Narayan, and others. Thank you.
Thank you, sir. Thank you very much, and we'll take a leave. Thank you, and excellent session. See you later. Thank you. Bye.
Thank you, sir. Thank you so much, Dr. Nair. Thank you so much, Dr. Mahesh and Dr. Viveka Kumar. Dr. Viveka Kumar, thank you so much for chairing the session. And Dr. Nair, he was here for the presentation. And thank you so much, Dr. Mahesh as well, for the excellent insights into this very technical topic of cardiology. And we'll have a very short break here, sir. And we'll be coming back with another session at 4 p.m. where we'll be talking about quality care in surgery and building a personalized healthcare ecosystem. Thank you so much for having joined us. We'll be back in a while.
Thank you, Aishwarya. Thank you, Shubham, for doing great job in this session. Thank you.
Thank you, sir.
Take a break. You are at about 2 at night.
2:30, 2:24. Yeah, 2:30.
So just have some 20-minute or 25-minute break.
No problem. Yeah, no problem at all. Okay, bye.
Thank you, sir. Good evening, Dr. Yadav. So you need to unmute yourself. Good evening, Dr. Yadav.
Is Dr. Yadav speaking? Ashiti?
Yes, Dr. Yadav would be speaking today.
Okay.
Good evening, Dr. Yadav. Good evening, Dr. Zamir Pasha. Good evening to you.
Good evening to you. And can I do my slide share, screen share?
Yes, you can.
Okay, thank you. Good evening to you.
Is there a disturbance in the sound or is it just me? Good evening, Dr. Monica Mishra. Good evening, ma'am.
Good evening to all.
All right, we'll be starting the session in about 2 minutes from now. We're waiting for Mr. Joy Chakrabarti to join us.
I'm already there.
Good evening, doctor.
Good evening, good evening. I'm not a doctor.
Mr. Joy Chakrabarti, good evening.
Good evening, good evening.
So, Mr. Joy, you're going to be chairing the session, sir.
Yeah.
So, whenever you're ready, we can start with the session, sir.
I'm ready. I am ready. Can you hear me?
Yes, sir. I can hear you, sir. Is there a voice disturbance from my side now?
No, at least I am not facing.
No disturbance, Ashwarya. Thank you.
I was getting the message that there's some voice disturbance from my side, but apparently there's none now. So, all right, we'll start with this session now. This is the technical session. So good evening, everyone. Here is welcoming you all to the technical session 11. And the topic for this session is quality care in surgery and building a personalized healthcare ecosystem. Let me introduce the speakers for the session. Let me first introduce the chair for the session. We have Mr. Joy Chakrabarti, Chief Operating Officer, PD Hinduja Hospital. A very warm welcome to you, Mr. Chakrabarti.
Thank you.
And let me now introduce the speakers for this session. We have Professor Dr. Himatram Yadav, Sir Public Health Specialist, Malaysia. A very good evening to you, Professor. And we have Dr. Sandeep Chatrath, Senior CEO and Medical Director, Metro Group of Hospitals. He's also the Senior Consultant and Advisor, Hospital Management. I guess he's going to join us in a while now. We have with us Dr. Zamir Pasha. He's a surgeon at the Shah Nawaz Hospital. Very good evening to you, sir. And we have Dr. Monica Mishra, Senior Professor, Department of Pharmacology, SMS Medical College, Jaipur. Very good evening to you, ma'am, as well. And now I would request Mr. Joy Chakrabarti to please start the session. He's going to be the chair for the session as well. Over to you, Mr. Chakrabarti, please.
Good evening, and thank you for giving me this opportunity to chair this session today evening. Very interesting session on quality safety in surgical care, and at the same time we have topic on personalized health ecosystem. I'm pleased to note that I have distinguished panelists here present, and they are going to share their thoughts and their knowledge on both the subjects. But before getting into the discussion and inviting them, I would like to have a very brief outline about both the subjects, and I'll try to share my thoughts. So, first is begin with the quality care in surgery, and it has been recorded that over a period of time, this patient safety and quality has become one of the very important and pivotal area in healthcare delivery system. And why it has become? Because it has been recorded by WHO that more than 7 million surgical patients, worldwide, they suffer from complications post surgical care. Also, it has been recorded that close to 1 million people, they die during or immediately after surgery, and all this happens only because of this is something like the safety issue, the quality front, quality areas may not have been covered. Of course, we should not undermine the risks what some of these surgeries are involved. Surgical mortality is almost 10 times more in developing underdeveloped countries than developed countries. So that gives us a thought that there is a wide variation, and that wide variation may be due to some sorts of lack of standardization and lack of best practices adoption across the globe. So we'll be hearing some of the thoughts in that direction today. And the other bit is there is a good number of deaths in surgical care that is because of anesthesia related complication, which is also preventable and manageable. For that, you need to have several steps, and I must say something like guidelines, checklist, and protocols. These are some of the things what has been developed, what are all have been developed already by some of the hospitals. Some of them are in the process of developing that, but I must say there is a long way to go to ensure patient safety. Though we cannot aim for a scenario where there is be zero death, zero complication, but we need to see how we can minimize it close to the zero. And at the same time, all these are happening because of a simple reason, that is because of multidisciplinary, practice which takes place in the surgical care, where you have so many super specialists, so many people part of it. At the same time, so much of complex environmental issues involved inside the operating room or in the ICU, and at the same time, complexity involved amongst the patient. So all these things make the entire, quality outcome or safety issues for the patients are very challenging, and we need to ensure that we are in a position to provide this quality care during surgery. And we have experts in those areas, and they are going to talk about those things soon. At the same time, the other area is of our discussion is going to be personalized health ecosystem. For a long time, the personalized healthcare has been interpreted, analyzed, and you know uh, presented in different ways. A lot of people mistook it by considering that personalized healthcare means when an individual has been taken care of from hospitality, from their services meant for them, boutique services, and all these things. But that has gone much beyond that. And today, in a healthcare ecosystem, this personalized healthcare is possible with the advent of data, statistics, and the big data what is available. And if we can explore and if we can manage them to our interest, that is going to make a huge difference. How it can make difference in some of the Western world hospital, and I want to take name of Stanford or Mayo. They have started working on personalized medicine, and this personalized medicine is nothing but that two individuals suffering from the same disease, same diagnosis, how they can be treated, managed in a different way to meet their purpose. And that is the way the personalized health system is working. But all these are possible with this data, and how there are several trends which are playing very important role and in the emergence of personalized health ecosystem. And what are those? The point one, uh, the explosion of healthcare data requires a new ecosystem built around individuals, and that will accelerate and affordable and accessible care. At the same time, with so much of sensors, and we are seeing the data are captured at the different level through sensors. With the availability of that, by application of 5G as well as artificial intelligence, will create a new network which will transform the healthcare. The third trend, probably, to personalized health and organization must have data to understand and influence behavior. And we must understand that influencing behavior is very important for the personalized health ecosystem, because every individual behavior, directly or indirectly, it is impact it impacts their overall health outcomes. We need to develop a trusted health intelligence system, so consumers, and all other stakeholders can get the expected data outcome analysis out of that. And very importantly, organization must be decisive in the business model to select the right model, that what to do with this data, what to get out of this personalized healthcare system to meet the requirement of the future. And there are several case studies, even some of those have come in Forbes Healthcare recently, where it says that something like target therapy, individualized oncology treatment, those have taken place as an example for this personalized health framework of the discussion today. So I'm going to request my first speaker, Professor Dr. Hematram Yadav, from Malaysia, public health specialist, to start his presentation. Over to Dr. Yadav.
Dr. Yadav, we cannot hear you.
Dr. Yadav, can you hear us? Because we can't hear you. No, still you are not audible.
You're muted right now.
So if there is any audio problem, I think I can move on to the next speaker, and I'll request Dr. Jadhav to come back soon after that. So I move on to Dr. Jamil Pasha, the surgeon from Sahnaj Hospital. So over to Dr. Pasha.
Dr. Yadav, can you unshare your presentation, please?
Hello, good evening, chairpersons and the panelists. Thanks to Dr. Anil Garg and Shubham Garg and the wonderful people of the World Healthcare Awards who have been doing a wonderful job on this healthcare. Are you able to hear me?
Yes, we can hear you.
Thank you very much. So let me share my screen. Are you able to see my screen, please?
Yes, we can.
Thank you, sir. So that is my position as to how to ensure there is quality in surgery, because not only as the trustee of the International College of Surgeons and also as the trustee of the Indian Association of GI Endosurgeons and as a fellow of the Royal College of Surgeons of England, London, and also fellow of the American College of Surgeons, I deem it my pleasure to present before you the quality. Now, this is something that is undefinable. How do we define ethics? How do we define quality? How do we define standards? So, the degree to which a set of inherent characteristic fulfills requirements. So, these are the ones that is attributable to a service. What set of service is this? This is attributed to not only nobility, precision, because every surgeon, when he makes it incision, he is to be precision qualified. And that being so, quality is conformance to the requirements and patient satisfaction. And herein, I would like to say that since the medical profession came into the ambit of the consumer law, we are calling them customers. Do we? Yes, because it is all driven by the industry. And so, the proper performance according to the standards of interventions is known to be one, safe, affordable, and have the ability to produce an impact on mortality, morbidity, disability, and malnutrition. Mortality, morbidity for a surgeon, say for example, in a month when I do 100 cases, one death makes 0.001% morbidity. But for the patient, it is 100% morbidity. That we should have it in mind. So, the myths of quality are that we think it is luxury. This is expensive, not affordable. This is intangible, not measurable, as I told you just about the love, about the sympathy, about the empathy. That is, sympathy is when you have that pain sensation of the patient that who walks into you. But empathy is where you feel the pain yourself. That is when you become a full-fledged medical personnel. And then you have problems due to the paramedical staff, because this makes up a good team, and here we need to have a good teamwork, and this originates from the quality department. So the questions to be addressed are: is there a quality improvement? Why quality improvement? How to measure quality, and what tools do we need? So these are the challenges that are posed to the health system. So the health organizations are complex systems clinical standards are not enough. Would you believe that in our country, which is as big as so many countries all put together, we have the biggest, the peninsula, and this has more than 100,000 crore industrial investment in an unorganized health sector. That is how we are. So we have cultural and organizational challenges. We have competing power structures, whereas lots of ministries, doctors, nurses, a lot of red tapeism to go through, and we have to build capacity to manage these complexities. And professionally, all the doctors are managing it. They are not jack of all trades. Now we need to be master of all trades. So again, the quality, how do we do the assessment? And this quality goes on to accreditation. And there are legal issues on this. There is something that we need to have increased motivation and satisfaction. Satisfaction also means satiation. The satiety factor should also be improved. So once we do all this, we need to have a quality which is expected of you, a quality which is perceived of you, and what is actually present that you need to take care. So these are the way you look at it from the patients and the attenders who come along with them, from the provider's point of view and from the manager's point of view. From the client's perspective, the services and activities that meet the needs of clients is the expectations and the outcomes. And the providers, we give them medically safe, professionally ethical, and accessible and acceptable to all. From the managers, the HR people who do that, it should be safe, satisfying, affordable, accessible, and delivered in a technically competent manner within the socio-cultural context of the country. So this has to have these dimensions, namely the access, the appropriateness, and the effectiveness. So we have to have these basic premise of quality of service, namely improved service quality, increased client satisfaction, increased loyalty. Exactly the platform on which the doctor-patient relationship is built is on the edifice of faith. Faith, by which I mean the implicit faith that he has on you, that is loyalty. And increased utilization of service, and of course increased revenue also should be there, cure rate, and improved health. So this has to be evidence-based care. That should be equity, that all patients are equal, and consistent care. Every time there is a need, it should be consistent. So the principles have to be transparency in sharing information, ethical practice in professionalism, evidence-based practice in the scientific basis, top-down and bottom-up to make the correct balance, from blame to improvement. Never ever blame, take all the blame yourself. You need to be the captain of the ship. That is the culture. And accountability, it is everybody's business, right from the sentry and the friend, right to the pantry in behind. All these have to be taken care of. And information and sharing and communication bring sustainability. For improvement, we need to have empowering the consumers, give them the patient's rights. There should be professional development, both academically and also culturally. Institutional development has to tell them what do we need to do, and then the management development and the clinical practice development, which I mean harping again and again, evidence-based. So the quality cycle is to have a plan, then act on it, have your center as the customer or mean the patient, check and do. That is the implementation. So the quality plan has to be, quality strategy has to be developed, standards have to be developed, then design training courses. Just for example, where I am, the Indian Association of GA Endosurgeons, we are now doing for the past 1.5 years everything virtually. So here we conduct examinations, we also give them fellowship courses, and we did have somewhere in the fag end of last year, December and January, couple of courses, but then with the pandemic crisis now in full bloom, we thought it is not safe to go ahead with this. So we need to have an infection control committee in a health facility. So we have to develop an health education, then check the quality of care, act according to the areas, agree on actions, and include actions. So this has to be based on 4 planes, namely the national, where you need to have a policy and infrastructure, on the regional basis, where there is performance, monitoring, and macro management, in institutional, operational, and governance, and for the individual, it should be health services prevention, professional accountability, and patient satisfaction. So these have to be traditionally norms, trainings, aids. Speak to them in their own language so that they can understand. Then the quality assurance, where there should be teamwork, process analysis, and data monitoring. As I've been telling again and again, data monitoring is very, very important. And this have to be collaborative. The process, the sharing, competition, best practices have all to be equal. The equity should be there. So these, we have to define standards, norms, guidelines, variations, compliance with norms under the given time, because in any conference of this magnitude, the most precious entity is time. And in the given time, with such a vast topic, I don't think I'll be able to do justice to all this. But anyway, let me go ahead. So the Six Sigma approach is the define, measure, improve, control. And in the indicator of this is the diagnosis and treatment is a process. It has its input and output judged by the indicator. And it should have been a certain procedure and minimal standard level of the diagnosis treatment should be defined. So the key processes are measurement, monitoring, and improvement. And continuous improvement, that should be there. And the quality indicators are the burden of disease, the effectiveness of the intervention, the scientific soundness of the measure, the feasibility of collecting data. So some indicators are, say for example, waiting time not more than 30 minutes, number of dehydration deaths in diarrhea, number of IPD admissions, number of cases with hemoglobin in a given blood. I am talking both government, non-government, institutional, private also, and number of repeat x-rays, number of entry cases. And some indicators are the average length of stay, the surgeries postponed, the number of newborn where the birth weight not recorded, and dropouts between DPT1 and DPT3. And so the determinants of customer satisfaction are basic, performance, delight, where he is happy with you. The basic factors are that whether the doctor was not there, the lab was not functional, and there was customer satisfaction was not fulfilled. And in excitement factors are where the customer satisfaction is delivered, where there is clean facilities, reduced wait time, and there is no dissatisfaction at all. So the performance factors are this, that the cost satisfaction of the performance is high, where there is a low infection rate, and also home visits also can be assured and directly connected to customers' explicit needs and desires. So these attributes should always be there, namely indifferent attributes, questionable attributes, reverse attributes. So from the healthcare, we need to be safe, effective, patient-centered, timely, efficient, accessible, equitable, and consistent with good terms. So safety, the improvement of the safety means reducing medical errors, do no harm. So it should be competence from technical side, managerial side, communication side. So the effectiveness of care should be examples. We need to have a lot of examples. We can go ahead with people have fallen down in the ramps, where there is not safe disposal of needles, where there is patient safety is not being there, requirement is not there, and identification and the wrong site operations, communications, everything has been not done. So you have to have the improvement of medication safety, and develop policies to take care, and healthcare associated infections, and also the requirement should be there. Reconcile medications, where you should have a goal, and ensure correct site, correct procedure, corrective surgery. That's also very, very important. So risk factors for wrong site surgery is also there. And medication safety, you should have be label all medications, which is very, very important. So the universal protocol is you should have documentation properly, surgery site properly, the equipment should be properly, body part should be monitored properly, the procedure should be monitored properly. Then only you will have a patient who is fully satisfied and delight. So to have a compliance, you need to have a checklist, just like the pilot who does that in the cockpit before takeoff. And to reduce this, you have to have harm resulting from falls. Then compliance solution should also be taken care of. And the surgical fires, it has happened to me even in my high-tech theaters, where we use a lot of electrical work, the laser work, everything, fires have been done. And the patient's involvement, also keep them involved, tell them about the risk assessment, and the changes in patient condition. If there is a condition change because of the procedure or because of the course of the disease, you should inform them. So you should have a universal protocol for all this. This is a question and answer scorecard before the patient is wheeled into the theater. And if there is an adverse event, again a scorecard which has also been marked by the wonderful people of our surgical colleagues. So quality improvement in healthcare is to help the patients find their way. In the hospital, have a lot of signages giving the women directions, and if there is a friendliness of the staff, they'll be really very happy. So to track quality assurance, we need to have regulation, we need to have certification, we need to have accreditation and credentialing, grading and rating, quality awards. That is what this World Healthcare has brought this about. So in regulation, there should be a legal restriction mandated by the government or state attempts. And in the certification, designation earned by a person, organization to perform a job or a task. And this should be renewed periodically, valid only for a specific period of time. And in accreditation and credentialing, where there is a certification of a competency, authority or credibility, assessment by an independent agency. Credentialing refers to a type of designation, award, status as the one that you are giving today to many of our colleagues, to my friends, many of the health institutions, which I am very, very proud being a trustee of the surgery associations. I'm very happy that a lot of people are getting awards for their performance. And why accreditation? Because this gives a better control of operations, improves staff confidence and evaluate business reliability of a test. Insurance companies can rely on these tests and ensure better support in legal cases, and it gives traceability provision. So, and also grading and rating should also be done, and also quality awards. So recommendation and appraisal evaluation for high degree of consistent sustained performance, and this is instituted by professional bodies and or independent entities. And the reliability notation has also been done. I think this has also been taken into criteria when you are giving all the awards. And quality levels, what should be the quality? It is 100%. We have zero margin of error either in surgery or in any of the medicine also, because it could be 90%, 95, 96, 98, 99, 99.9%. But still, what does this 0.001% mean? It means there are 22,000 checks from the wrong bank account every day. If there are 16,000 mails lost by the postal service, 2,000 unsafe airplane landings are made every day, 2 major airplane accidents per week. If 99.9% is acceptable to you, then your heart fails to beat 32,000 times each year. 500 surgical operations are performed wrongly every week. 20,000 wrong prescriptions made every year. 19,000 babies are dropped by doctors at birth while delivering. So, well, there is only 1% difference in the DNA genetic code between a chimpanzee and a human being. Please have that in mind. Even we are not affordable to have these 0.001% error in our medical judgment or in our treatment plan or in our quality assurance. Well, in our profession, there is no scope for error. For any error committed, it's all the difference between life and death, between relief and disability. There is no second chance. Then, well, thank you. The future is ahead of us. Thank you so very much.
Thank you, Dr. Pasha. It was wonderful, and in a very short while, though you are not confident of covering all aspects of quality in surgery, but I could see that you have touched upon almost all the important points, and whether it is accreditation, whether certification, whether it is ethics measurable or quality is measurable or not, I think all these minute points, and you have given a very good overview that what are the aspects someone who is at least trying to ensure quality in surgical and in broader terms in healthcare delivery, those have been touched upon. And one of the very important thing what we say, that we should do the right thing which is for the interest of the patient, and we should do the same thing even if I am not watched at certain time. I should do the right thing all the time even if I am not watched. So thank you very much, and I'm sure there will be questions at the end of the session what you will be taking. And with that, I move on to again to Dr. Hematram Yadav, and request you to share the screen and you can go ahead with your presentation. Can you share your screen?
Looks like we still cannot hear Dr. Yadav.
Okay. Dr. Jadhav, can you hear us? So you can wave your hand. We can see that. Okay, but somehow we can't hear you. So not an issue. So we move on to Dr. Manika Mishra, Senior Professor, Department of Pharmacology, SMS Medical College, Jaipur, and going to talk about the very important topic of, I started interaction with that personalized health ecosystem. So over to Dr. Mishra.
Thank you so much, sir. A very good evening to Sir Joy Chakravarti, to Sir Shubham Garg, Dr. Pasha, and Mr. Yadav. And also, first of all, I'm so thankful to the organizers because they invited me and gave me an opportunity to speak on this global platform. So should I share my screen?
Yeah, please. Please go ahead and
am I
share.
audible?
Yes, very much.
Okay.
Yes.
Not able to share the screen. Good look, Kubula.
At the bottom green, you can share.
Yes, I'm sharing. Share karwa the screen. Yes. Yes. So, I start my topic. So I'm related to medical education. Medical education plays a crucial role in healthcare to train the medical graduates to efficiently take care of the health needs of the society and to tackle any new health problems as they arise in an ever-changing environment. Now, we also help develop an attitude of the medical graduate.
May I request you to get into the full screen share mode?
Gudu ko bulana.
One sec, please. Sure.
So just a minute, sir. So actually, there's some problem in the communication. Full screen.
Hello.
Yes, sir. Hello.
Can
Full
you hear
screen.
me?
Yes, sir.
Oh, that's me.
Yes, sir.
Dr. Yadav, we can hear you now, finally.
So I will get in next, all right? There's some technical problems. I really don't know. Anyway, I'm sorry I won't disturb.
Dr. Manika, can I request you to go for the slide share mode?
Yes, sir. Yes. So should I start?
Yeah, start, but can you share your slide? Complete means what I mean is full screen.
Full screen, yes, sir.
First,
Yeah,
please
yes,
open
just
the
a minute.
file.
Yes, sir.
First,
Yes,
please
sir.
open your file.
Yes, sir.
Then
So is it
share
okay?
screen.
Is it okay, sir?
It's not open. Please open your first PPT.
So I have opened the PPT. Is it not visible?
Yeah, the screen that we see is your documents, your computer folder, and the location of the file. So probably it might be on a different screen. You need to click on the WHC-2021 so that the screen opens. PowerPoint presentation.
Yes, sir. So just wait, just a minute, sir. Just a minute, sir.
Please send the email.
So I'll just I have sent
the
the
Dr. Anil Garg email ID. We will share.
yes, sir. Sir, yes. I'll just send. बेटा वो मेरा वो email इसमें भेज दो.
Meanwhile, you can speak without slides.
Hello, Dr. Anil. How are you, sir?
Just fine. Thank you. Thank you, my dear.
Nice to see you.
Yeah, this is all technological.
Yeah. So we old people have technological problems.
Yeah.
Mr. Chakrabarti, do you think Dr. Yadav can go first till the time?
I think we can go
Mr.
ahead.
Mishra is...
So I think we can go ahead. So request Dr. Mishra to unshare the screen, and I move on to Dr. Yadav once again.
Okay, can unshare.
Dr. Mishra, please unshare your screen.
You have to delete.
Yeah, now Dr. Mishra's thing has come. So I think Dr. Mishra, continue.
Oops.
Okay. I think.
You want me to unshare? I can go. I can.
Yeah, you go ahead, Professor Jadhav, you can go on.
Go ahead. Okay. All right, because of the time constraint, I'm going to rush through this. There seem to be a lot of issues there. What I'm going to talk to you today is actually the new challenges in public health, focusing on the future of personalized care. I think Joy has already given a lot of what I would say. But firstly, I would like to thank the organizing committee for having invited me for this conference. I think it's a very interesting and a very well-organized conference, I must say. Let me go through what I'm going to say today. Personalized healthcare, as we all know, is actually personalized healthcare is an overarching framework for care that unifies predictive technologies with an engaged patient to coordinate care with the primary aim of promoting health and preventing disease. Basically, as Joy introduced, it is a care for the individual patients because all of us vary our condition from person to person. So this framework will take care of the individual patient care. And currently the healthcare system, what I tend to do is more than 700 billion in the US alone. Actually, they are providing just care, but rather than better care. And we hope that actually the personalized healthcare will be considered a better healthcare. The personalized healthcare technology should reduce this waste considerably. And to understand the personalized healthcare in the future, we need to understand, first of all, the weaknesses of the current healthcare system and the changes that will be required to adapt the personalized healthcare. So the current healthcare system, globally, I would like to just go through a few. I won't take a lot of time because of the time constraint. The World Health Report 2010 says about 20 to 40% of all health sector resources are wasted. This is interesting, 20 to 40%. Inefficiencies that undermine the national efforts to strengthen the health systems. And inefficiencies vary from individual hospital to hospital. The way medicines are purchased and used, the way hospital admissions are managed, how the health worker capacities and motivations are addressed, and the way the health services are delivered, and the list goes on. You can go on and on this matter. And the second aspect is the lack of commitment from ministries of health. Ministries of health globally give low priority to the health sector. In some countries, of course, rightly so, probably the defense sector gets the highest in education, the next, but the Ministry of Health gets very low in terms of the percentage of GDP. For instance, many of the developing countries, the percentage of GDP is from 2 to 6%, as compared to the developed countries can go to as much as 50%. So ministries have low commitment for the percentage of GDP, low per capita health expenditure, lack of comprehensive delivery of services, and of course, inequality of health services. So lack of commitment. Third one is actually the financial coverage for patient is low. Insurance coverage is not in all countries, we know that, and the poor and vulnerable are not covered by health insurance. And out-of-pocket payment is still high in many developing countries. As again in the introduction, it was mentioned that the poor patients are not able to pay the care provided by the private hospitals in most countries. And despite this, non-communicable diseases is increasing rapidly and thus increasing the cost of care. So financial coverage is very important in terms of patient. The next is the availability of health services is poor. Basic health services in the rural areas in many countries is still very, very basic and very poor. Secondary health care needs improved infrastructure and quality of services in district hospitals. And of course, expand health services to cover the prevention, promotion, treatment, rehabilitation, the whole range of the services. And finally, health inequities and quality of care. Health inequalities in terms of geographical distribution, economic, financial, demography, physical distribution, physician distribution is again very unevenly distributed between the urban and the rural areas. And finally, the quality, which is, I think, was mentioned just now, and efficiency is still poor. So basically, there's a lot of issues in the current medical care system. So there are some, I'm going to just discuss only a few future scenarios of healthcare, which probably will change the health scenarios in the future. And that's where we need the personalized healthcare. So the prerequisites required for personalized healthcare. What are the future scenarios in healthcare? One is rapid urbanization. We know that people are migrating from the rural to urban areas. Focusing on prevention and wellness in health will increase in the future. Everybody is talking about wellness programs in most of the countries. There's a likely increase in diseases like chronic diseases like hypertension, diabetes, and cancers. And of course, in some countries, the focus is on increase in the universal health coverage. So future scenarios, urbanization, wellness, chronic diseases, urbanization, and sustainable financing through health insurance. Hopefully, health insurance will work in many of the countries, which actually at the moment is not working. New and emerging diseases will increase. We see now the COVID-19, and we expect more and more new emerging diseases coming in the future. Technology and artificial intelligence advancements will happen, and we need to adjust to this technology and artificial advancements. Patients as a center of focus. Right now, as we know, the hospitals are the main focus. Patient has to be in the future center of focus, and genetic literacy among physicians and patients. So with this future scenario, we need to have some prerequisites for change of personalized healthcare. So personalized healthcare is the individual healthcare, as I mentioned earlier. Patients will vary individually. They will be put in the center of healthcare system rather than currently the hospitals are the center of healthcare system. So placing the patient in the center of healthcare system and changing the paradigm of healthcare provision. Each patient is different, so we need to address them differently. Secondly, patient diagnosis specific to each patient using genomic material in patient diagnosis. Now we already know that actually the genome has been worked out, and we know all the diseases or likely parts of the genome, and we need to work out individually for each patient what likely is actually the genomic material in the patient, confirmed patient. One example is the HER2 positive for breast cancers and tumor markers for certain cancers. So each individual patient will be different in terms of diagnosis and the probable diagnosis. So to achieve better health, better genetics and literacy for professionals is required. Right now, there's very little information on the genetic testing. Online distance learning is required. The aim is to involve the genes involved in the certain diseases. In many of the European countries, I think they already have a checking mechanism for online genetic testing and online distance learning. But we in Asia and many other countries, I think we have a long way to go in this matter. Fourthly, artificial intelligence. This conference, I think, has been talking about artificial intelligence. This will going to be the future, as we all know, and learning to use it would be a requirement. Everybody, at least in the medical field, would learn how to understand the robotics, the medical diagnosis, and medical statistics, and of course, the human biology. Next prerequisite is data utilization change in the personal health care. Data utilization, there will be large amounts of data or big data, collection of data, timely analysis to tailor the most appropriate treatment and diagnosis for patient care. Just for the information, I was involved in a project called Womb to Tomb in the Ministry of Health in Malaysia, and we were actually working for personalized healthcare. In this system, we identified right from birth till death. And when you're talking about birth to death, we identify the birth, and then we look at what are the immunization conditions you require as a person grows into youth and to adult. The diseases like diabetes, hypertension, not everybody will get it. So each individual patient would have an individual card right to the tomb till his death. And then we give the specific treatment for such patients. So data utilization is very common. And related to data utilization is a seamless healthcare between public and private sector. Most countries now have a very separate private and public sector. The public sector run by the government is of course inefficient in many ways. The private sector, because of the bottom line, they of course try to make the patient diagnosis much better and clearer. So data will be able to move from private to public sector. That requires a lot of legality, ethics, and things like that. And this will be a big challenge to allow the data to be used by both sectors. Interesting, we actually have been working on this as well here. We have introduced a card, but it's still in the early stages, and a card like the identity card. And in this identity card, of course, you will get information of the patient and medical data. And so when it talks to private or the public sector, the data is entered into the system, and you can go to the private sector, and of course, the data is available. Very early stages, having lots of problems in this seamless healthcare. Next one is retaining the humanity. Despite all these changes in healthcare for personalized individual, you are likely to have a lot of technology and advancements and robotics and all that. So much so the patient aspect, the patient in terms of sympathy, in terms of empathy, the humanity aspect of the patient might be lost. And that's because we'll be very dependent on technology and machines to make our diagnosis under AI, but we need to work on the humanity and not lose it out in the future. And adaptation to new technology, of course, we have to start adapting. Right now, the AI, the medical apps, which are simple apps now available on our handphones, which can give a lot of diagnoses as well as preventive measures and healthcare apps and wellness apps and things like that. And of course, robotics. Robotics, as you have seen, surgery and advancements in robotics there, and it requires a lot of effort in terms of training, etc. in this. Flexible organizations. Organizations need to be flexible. The physicians must be able to adapt to the new change in the environment quickly. The physicians and the organizations must be able to. For instance, now the COVID-19 is a very good example. The hospitals are actually basically in terms of diagnosis and treatment, and they don't take care of very much of the preventive aspect of chain. And as such, the hospitals are not able to adjust very fast when you have a major epidemic. And that's why in many countries you have separate patient beds and things like that for. And finally, improve governance in healthcare, including research and clinical governance. Healthcare in terms of research is very, very crucial because research makes you into identifying new diseases and things like that. And of course, clinical practice. Advantage of the personalized healthcare, hospitals and medical centers, there will be totally reduced costs. Hopefully, initially, of course, with the technology, it may increase, but long run, it may reduce the cost. Better optimization of healthcare, length of stay, reduces research costs because the algorithms and methods of diagnosis may be much cheaper. And of course, there's most possible increase in terms of revenue. Patients, of course, decrease patient management and satisfaction and decrease mortality, hopefully with the early diagnosis and treatment, and reduce costs and efficiency in the system. So overall, personalized healthcare is the future, with technology and AI to be introduced along with that to identify the patient with the diagnosis with the individual patient, and individual patient getting treatment specifically early, and as such, it will likely to decrease mortality. With that, thank you very much, and over to you.
So you can answer the screen, and thank you, Dr. Yadav. I can say that you have shared the 10 commandments for personalized healthcare.
As you did, yeah. Yeah, same as what you did in introduction.
Yeah, true. And I can see that you have touched upon, and very nicely you have compared the present scenario of COVID-19, and I'm sure there'll be some questions on this soon. Now, coming back to our next speaker, Dr. Manika Mishra, may I request you to, share your screen and start presentation? Yeah.
So I'm really sorry. So I could not start at that time. The slides were not shared. So I begin my today's presentation. So I am basically a medical educationist. So medical education plays a crucial role in healthcare to train medical graduates to efficiently take care of the health needs of the society and to tackle any new health problems as they arise in an ever-changing environment. Also, we help medical graduates to improve the attitude, not making medical profession a business, not thinking the patient as a customer. Patient is a human being, and the approach should be with humanity, not customer service. So on one hand, we prepare a medical graduate to work efficiently at a primary healthcare center. And on the other hand, as more than 10% of our qualified doctors work abroad. So the quality of medical education acquires global relevance and should meet the international standards. When we talk about the present scenario of medical education, it shows an alarming shortage of medical teachers corresponding with the sudden upsurge of upcoming medical colleges. Then there is an issue of outdated medical curriculum, which has now been replaced and revised by our National Medical Commission and tailored to the community needs. Then there are no desirable evaluation system for the proper assessment of a medical graduate, and also poor internship supervision. All these bring about a downhill trend in our medical education. Myself, Dr. Monica, I'm serving in the field of medical education since last 25 years in a government setup. And I have done this study. It is a questionnaire-based survey on the feedback opinion of the students during the COVID pandemic.
On the fan.
Yeah, the global disruptions caused by the COVID pandemic in the year 2020 led us to a new perspective to find out an alternative teaching method to ensure the continuity of medical education. So the only option left was e-learning and the online classes. The study was planned to ascertain the impact of online teaching method on the understanding of the subject pharmacology and to explore the feedback opinion of students on the various teaching methods. During the COVID pandemic, as the e-classes were arranged instead of the conventional classroom, and online feedback from 150 students of second MBBS from SMS Medical College, Jaipur, who are now appearing in the university exam, was taken in the form of a questionnaire. All possible questions regarding learning teaching methods with regard to the subject of pharmacology were framed and sent personally to their WhatsApp mobile numbers. They responded promptly and the results were then analyzed. So the results have been depicted in two tables, table number 1 and number 2, pertaining to the learning of the subject pharmacology and the teaching techniques, which I shall discuss shortly. Next, please. These are two tables which are showing the results of student opinion on teaching techniques. Next, please. Then regarding the satisfaction levels, the students in general were satisfied and said that the faculty did their best during the critical COVID times. Next, please. There were certain reforms which were suggested by 28% of the students, which closely rhyme with our new curriculum of competency-based medical education. So we'll discuss them now. Next, please. The curriculum in pharmacology is witnessing a change from emphasis on animal experiments and dispensing pharmacy-based curriculum to an applied holistic approach. Attempts have been made all over India to make the teaching of pharmacology more interesting and relevant. The subject is vast and the student needs to memorize every detail of the drug. All students found the subject pharmacology important for rational prescribing for future clinical practice. All the students opined that case-based interactive sessions should be part of a regular teaching schedule. Next, please. In a small group learning, students were able to ask questions with confidence and get their doubts cleared, besides developing personal rapport with the teacher. Students enjoyed thoroughly the tutorials as it involved the active participation of all students. Problem-based learning helped students to develop critical thinking skills for rational prescribing. Then lastly, and the most important, the case studies with the real life situations were most interesting, most liked by the students, as they motivated them towards self-directed learning. Through this, though the study reflected that the students' reservation was towards older conventional classroom teaching, but they did appreciate the newer case studies and the problem-based learning. The training of a tomorrow's doctor who enters medical practice should include a greater integration of basic and applied pharmacology for producing healthcare professionals with appropriate knowledge, attitude, and skills for the rational use of drugs through an innovative curriculum regimen. Now we discuss this innovative curriculum regimen in detail. The concept of an innovative integrated curriculum arose from the perceived weakness of the traditional curriculum, as the fresh medical graduates were not able to treat patients independently without the institutional diagnostic support, and declined to go to serve the rural population, which comprises 66% of the population in India. The faulty dichotomous curriculum, that is, there is a divide in preclinical and clinical. This was thought to be the majorly responsible, wherein the medical student is taught the individual basic science disciplines in the early phase and is expected to apply the knowledge in the latter clinical phase of the curriculum. And the only solution and meaningful way is the curriculum that emphasizes horizontal and vertical integration of basic and the clinical sciences. That is a curriculum that helps to learn the basic sciences in a clinical context. For example, the problem-based learning and the case studies, which were most preferred by all the students. Then regarding the assessments also, the assessment, how do we assess a medical graduate? So ideally, regarding the assessments, the setting and evaluating the questions also should be integrated across the medical disciplines with the interdependent, overlapping and multidisciplinary concepts. So it is recommended, highly recommended, to appoint curriculum managers and discipline champions who work together to ensure proper balance in various disciplines. Now, the application of information and communication technology, ICT, in teaching learning process is emphasized, which promotes evidence-based medicine and is also a useful aid in a computerized aided lab for various simulation exercises.
May I request others to keep mute?
So we were talking about the application of ICT. ICT, besides promoting evidence-based medicine, is a useful aid in a computerized aided lab for various simulation exercises. These simulation exercises are now alternative to animal models and have been inculcated in the newer curriculum. ICT is a means of sharing of relevant information amongst peers, promoting team spirit. Now we talk about the latest chip technology. Now we are talking about the personalized healthcare. So it needs something. I talk about the personalized healthcare in the form of latest chip technology. So on the efficacy side, as personalized medicine concepts are rapidly advancing, there is an advancement of a disease in a dish model. So there is organ on a chip and disease in a dish. So this is the advancement which utilizes patient-derived stem cells and disease cells and are helping to discover or develop drugs based on patient pharmacogenomics, drug metabolism, and other variables that Sir Joy Chakrabarti was also talking about. According to the variables, the drug is prepared now. According to the pharmacogenomics, the genetic variable, the patient carries his chip along with him, like a mobile chip. He'll carry a chip, a personalized chip. So as a cautionary note, if personalized precision medicine is the future reality, these models need integration with system biology like genomics, transcriptomics, proteomics, metabolomics for successful clinical outcomes. However, these omics in precision is rapidly evolving with combined computational bioinformatics tools, where big data analytics are replacing the conventional human data analysis. So this latest chip technology, various in silico methods, and the newer disciplines of these molecular pharmacologies, this genomics, all these are subjects of bioinformatics. They need to be accommodated to increase the knowledge base within the time frame, within the given time frame for training a medical graduate to meet the global standards. Next, please. Worldwide access to ICT facilities in medical schools would minimize global differences in pharmacological standards, so that the government has to look about this issue. Now, when we talk about this digitalization, the advancing digitalization of the human healthcare, as discussed in many of the sessions yesterday and today also, it requires that the digital skills and the digital teaching learning technologies be communicated to the medical faculty and also students and be used wherever they offer real benefits. Now, many of our speakers emphasized on the systems driven by artificial intelligence, the algorithms of which can themselves become the diagnosing agents in the system. The role of patient as the owner and the guardian of their health data will fundamentally transform their roles in healthcare. So today, Dr. Rajesh and Dr. Mukesh took us to a trip to cardiac digital world. So that is almost unknown, although we also work at a tertiary level, but it was really an amazing trip. So another role of digitalization is the medical informatics initiative that can help research results to be translated more quickly as the treatments. So now, with the perspective of teaching, educational data mining and learning analytics, that was talked about by Dr. Robert, who's a physiologist, and he talked about this data mining and learning analytics. This existing and to be collected data can be used to give teachers better insights into their learning groups and to be able to better adapt teaching to the actual needs. Now, what is needed is a digital infrastructure that enables educators to collaboratively develop, use, and content. In the creation of such an infrastructure, the intensive participation of teachers, medical informatics, and education researchers is crucial. A mutual integration of current projects with research, education, and healthcare can be of great benefit. The Master Plan for Medical Studies 2020 does not address the topic of digital transformation. To meet these challenges, it needs a national initiative, medical education in the digital age. So in these challenging times, implementing newer methods of teaching, and also this is also a challenge that dictates the need of promoting computer literacy amongst faculty. Now, if I can talk about myself also, I'm not much computer savvy. So computer literacy is a must amongst faculty and students so that the benefits of ICT can be fully harnessed. So in these challenging times, implementing newer methods of teaching would definitely raise the bar of medical education. Next, please. So to conclude, traditional pharmacology teaching in India has been criticized for not preparing students for medical practice, as also facing the challenge to catch up with the researchers growing at a fast pace internationally. The pharmacology component of the medical curriculum needs to be clearly defined in terms of input and expected outcomes, which must be reliably and validly assessed as a prerequisite for a medical graduate. Thus, the innovative integrated medical curriculum, training a medical student with a holistic mindset at the very outset, along with developing skills such as communication, team spirit aided with ICT, will enable the medical graduate to function effectively in clinical practice, academics, and pharmaceutical industry. So this is all what I wanted to talk about. Thank you so much for patient listening.
Thank you, Dr. Manika. And from your entire presentation, I can tell you I've got enough inputs and knowledge for myself. And 3 points I want to highlight from here. The first, what you have very correctly told, the curriculum needs to be looked into keeping the advancement of digital front in mind. The second thing you have mentioned about working between industry, academia, research, that has to happen in a big and significant way. And the third point, probably the topmost in terms of my area of interest, is the precision medicine. And you mentioned about it, and I'm not sure when it will come up
Yes, sir.
in India and going to be popular, but already it has started becoming very popular in Western world, and that is the language what people are talking about in the Western world. So thank you for all information, all knowledge, all the your study findings what you have shared today. So with this, I hand over to the organizers. I understand there are question answers, and they're going to take few questions.
Sure. So I think there's a question from Sarik, and the question is, have you verified whether all attended the classes promptly and how? And I think this is in relation to what Dr. Mishra was saying.
Yeah. Sir, actually, it was an online class arranged, and it was inbuilt system in which the attendance was online. It was there. The attendees, it was showing on the screen that the students attended. And then we also followed them personally, asking questions. The feedback was taken personally. Also asking questions through messages and also personally. So it was not about attendance, that they attended or not. It was about feedback, that what do the students think, that how do they themselves want, how they have to be prepared as a skilled medical graduate. Can they prescribe? Can they handle the situations when they go to the periphery? Because the most important problem is that at the periphery they don't want to work, they want to pursue PG courses, because actually they are not prepared. They are not prepared as a medical graduate to give the treatment properly, to rationally prescribe the drugs, because so many errors, because Sir Pasha also told, error is not allowed in our medical profession. So now if they prescribe inappropriately and are not skilled and competent, so that is the real situation in India today, although we are talking about the digitalization and digital world. But the fundamental thing in our own nation at PHC, what we see is the quacks and lesser educated people, they are taking over. And they treat the patients. So the medical graduates do not want to go there and serve at the rural areas.
Got it.
Mr. Joy, with your permission, can we say a few words?
Yeah, sure.
At this moment, I would like to invite each and everybody in the annual conference next year. Dates are fixed 15 and 16 April every year. So I will request you to join the conference next year, World Healthcare Conference next year, and we will see that it will be a physical one. And the pandemic will go,
yes.
This corona will go. Now I will request Shubham to address.
Well, I was just saying that, again, a question for Dr. Mishra and probably Dr. Pasha. Something in the lines of COVID itself, like, I mean, has there been a change in the whole educational syllabi as well? Just the learnings that are coming from COVID, and how does it really impact the new learnings or the new syllabus that the students would go through? Just because we understand that certain things are new, certain things are coming up, and are the syllabuses outdated? Are we thinking of updating the syllabuses, or how is it really being perceived from an educational standpoint?
Yes. So can I speak? Yes, sir. So from the educational point of view, the syllabus is the same. The fundamentals are always the same. It is the curriculum that we change, the methods that we change. The fundamental always remains the same. Now, based on that fundamental, now we grow. Okay, so that is the thing. Now the student should have that fundamental knowledge to go at the research level. Now COVID has instigated, and also to the student, now he also is to he thinks over, like scientific research can be done. So that is the way that we train our graduates. Having a strong base, and then you grow up. You should be a clinician also, a scientist also, and research papers also. Now we promote it at the earlier level, not postgraduate, also at a graduate level also. We are promoting researches. So the student is exposed to research work also. So Corona has instigated and stimulated us to grow that ways. Even the faculty is also now well updated and growing towards that.
Can I say a few words?
Yes, please.
Yeah, usually medical curriculum, because I've been involved in medical curriculum as well. The medical curriculum usually is approved by a certain body. In the case of the Malaysian context, it is the Malaysian Qualification Agency. So the curriculum is fixed. So when this Corona-19 story came out, you can't really change much in the curriculum because it has been approved by the qualification agency, because they will come back to you in 3 to 5 years and see, have you really done what has been approved before? So you cannot change midway just because there's a COVID-19. However, having said that, what can be done is, when you have, like Monica has just mentioned, you have problem-based learning, small group discussions, and in this problem-based learning, which has not been clearly defined in terms of the curriculum, you can choose any aspect of the problem-based learning. So what students do is, or the lecturers do, is to identify these newer things coming up, and they introduce it in the problem-based learning and discuss the issues at stake. But the curriculum mainly remains to the next check of the qualification agency, because otherwise they will say, why didn't you do this? Why didn't you do that? Because that was what was approved. That's in short about the curriculum changes in the medical profession.
Those are great and valid points, Dr. Yadav. I think probably in the next 4 or 5 years, we'll see that the government or basically the governing body would make some changes that might have something associated with the pandemic in the syllabus, so that we all are well prepared from an educational standpoint, both as well as leveraging data analytics, AI, and use that as a part of making proactive judgments so as to what kind of a pandemic, if any, would be coming in the next decade or so. So great insight. Thank you.
Right. So I'd like to thank all the speakers for a very thorough session, and the chair for moderating the session so wonderfully, so that we got all the perspectives on this topic. I, in fact, thank all the speakers and experts for having various locations across the world, for coming together, participating and dwelling upon several important issues related to healthcare. And also, the two-day World Healthcare Conference witnessed experts and stakeholders giving us insights into various issues and showing us the way ahead as well amid this pandemic that we are going through, and also giving us hope that future will be better, and that we also learn the lessons of the pandemic as well. And the summit also celebrated the achievers who have held on and given their best, and despite these bleak and adverse circumstances at the moment. So we thank everyone who helped in making this conference fruitful. I express my deep and heartfelt gratitude to everybody. Thank you all, and we look forward to your esteemed participation in our future conference as well. And that is going to be an annual affair now. I would request Dr. Anil Garg for the vote of thanks.
Thank you, Aishwarya. Thank you, Dr. Joy Chakravarti, Dr. Yadav, Mishra, Monica Mishra, and all others. Jamir Pasha, who is the supporter, big supporter for us, and for Shubham for conducting this session, and all 2 days he is awaking from California. And thank you very much for each and everybody. We will meet next time in April 15-16, 2020. Meanwhile, we will have some webinar. We will definitely invite. Okay, thank you. Thank you, Aishwarya and Puneet and Shubham and Tarna and Dr. Sargam and Pratyusha again for supporting and helping me. Thank you very much.
So I wanted to thank Dr. Anil personally, because he allowed me, despite being late, to submit my abstract, but still he allowed me, and I prepared the slides in just 2 days. But the opportunity that was given to me is really, I want to thank you wholeheartedly. Thank you.
And finally, I have to thank my wife, who is a chairperson of Energy and Environment Foundation, and for just supporting me financially, morally, and socially, so that we can able to do this conference on regular basis, adding quality each and every time. Thank you very much for all.
Can I just say, I think the real thanks should go to Anil and his whole team, because this has been a fantastic organization, I must say. The number of speakers coming from all over the world and managing them, and not only that, in the awards as well. And I was watching a few. I must say you have done a fantastic job, Anil. And I know you have got the wife at the back of you, but I must congratulate you and the team. Ashwarya as well. She has been managing very well, actually, the whole thing. So my personal thanks to Anil and your team. Well done.
Thank you. Thank you very much.
We are humbled, sir.
Okay.
Hello.
Thank you.
Thank you, sir. It's been a pleasure.